So I would request all the speakers and the panelists and our faculty members to please join us on the stage. Professor Harun Hamid, please join us on the stage. Dr. Mubin Rathore is already here. I would also like to request all the speakers who are available for morning session, including Dr. Nighat Yasmin, Dr. Umme Lubna, to please join us on the stage. We warmly welcome Professor Asghar Naqi, the Secretary of 42nd International Scientific Symposium. Sir, please join us on the stage, and we are going to start very shortly. उनसे पूछ लेना ये बिलाल साहब सामने डॉक्टर अमिशा We start the 42nd Annual International Scientific Symposium with the theme Exploring New Horizons in Medical Education and Healthcare, and I would like to request Muhammad Khawar for the recitation of Holy Quran. Muhammad Khawar.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الذين آمنوا اتقوا الله ولتنظر نفس ما قدمت لغد واتقوا الله إن الله خبير بما تعملون ولا تكونوا كالذين نسوا الله فأنساهم أنفسهم أولئك هم الفاسقون لا يستوي أصحاب النار وأصحاب الجنة أصحاب الجنة هم الفائزون لو أنزلنا هذا القرآن على جبل لرأيته خاشعا متصدعا من خشية الله وتلك الأمثال نضربها للناس لعلهم يتفكرون. तर्जुमा ऐ ईमान वालों, अल्लाह से डरते रहो और हर शख्स देख ले कि कल क़यामत के वास्ते उसने अमाल का क्या ज़ख़ीरा भेजा है। और हर वक्त अल्लाह से डरते रहो, अल्लाह तुम्हारे सब अमाल से बाखबर है। और तुम उन लोगों की तरह मत हो जाना जिन्होंने अल्लाह के अहकाम को भुला दिया तो अल्लाह ने भी उन्हें अपनी जानों से गाफिल कर दिया और ऐसे ही लोग नाफरमान फासिक होते हैं। अहले नार और अहले जन्नत बाहम बराबर नहीं, जो अहले जन्नत में हैं वही कामयाब हैं। अगर हम इस कुरान को किसी पहाड़ पर उतारते तो देखता कि खौफ इलाही से वो पस्त होकर टुकड़े टुकड़े हो जाता है। हम इन मसालों को लोगों के सामने बयान करते हैं ताकि वह गौर व फिक्र करें। सदक़ल्लाहुल अज़ीम।
Jazakallah. Now I would like to request Dr. Mubin H. Rathore, MD, Professor and Associate Chairman, Department of Pediatrics, University of Florida, for his talk on an update on monkeypox.
ये माउस है, ओके,
ये कंट्रोल सारा पीछे है, ये यहाँ से नेक्स्ट होगा
और नहीं वो कौन सा लेज़र, ओके ठीक है, ओके। अस्सलाम वालेकुम, बिस्मिल्लाहिर्रहमानिर्रहीम। आई थिंक दिस इज़ गोइंग टू बी अ लिटिल टफ। मुझे 10 से 15 मिनट दिए गए हैं। इट्स लाइक दरिया को कूजे में बंद करने की बात है, मंकी पॉक्स को 10-15 मिनट में डिस्कस करना। But I'll do my best, and I'm going to skip through some things rather quickly so that I can cover as much as possible. So all of you know that November 28th, WHO has recommended a new name for monkeypox, and we will start using the preferred term Mpox. The CDC is suggesting at this time to use both Mpox and monkeypox until monkeypox is phased out. So you will see me using both terms during my lecture. So I think there are some key facts about monkeypox that we all need to recall and remember. This is sort of because the time was short, so I put some things in there. So smallpox vaccine also provides protection against monkeypox. Now, most of you are too young, probably have not gotten smallpox vaccine. I have scars to show on my upper arm for smallpox vaccine, and the last time I got smallpox vaccine was in 1974. So I have a scar on my forearm also. So I may be, so those of us who have gotten smallpox vaccine may have some protection. There is another vaccine that has been approved for monkeypox. I don't know if it's available in Pakistan or not. So as you know, this is caused by the monkeypox virus, which is a orthopox virus genus or the family Poxviridae, and it is really closely related to smallpox, and that is why the cross protection occurs. It is a self-limited disease with symptoms lasting about 2 to 4 weeks, and it can be severe, but usually it is not. In the case fatality rate is between 2 to 6%. I run the University of Florida's HIV program at University of Florida Center for HIV AIDS Research, Education and Service, which we lovingly call UF Cares. It is one of the largest HIV programs, not only in Florida, but in the country. And we, of course, were very concerned because of the high risk for monkeypox amongst the HIV infected population. And because it is transmitted to humans through close contact with an infected person or an animal, and of course in the United States and most also in Pakistan, it is going to be through contaminated materials at close contact. Body fluids, respiratory, maybe there is some concern that even respiratory droplets may transmit it, but it's usually direct body contact or body fluids or contaminated fomites. The presentation does resemble smallpox, although it's less contagious and less severe illness, and it typically presents with fever, rash, swollen lymph nodes, and may lead to a range of medical complications. There is a medication, Topox, which is developed for treatment of smallpox, but is also recommended for monkeypox. We are part of the AIDS clinical trial group, which is a large network of centers that do studies in adults And we also are part of IMPACT, which is these are both NIH funded when we do pediatric studies. Also, although I'm a pediatric infectious disease specialist, but I take care of adults and kids. And so we are doing the TOPOX study for adults, children, pregnant women, everybody. So more data is going to come. I created this slide last night. Once I found out I only have 10-15 minutes. So if somebody has something important to do, you can leave now, because I'm going to try to delve into a little bit more into these topics. But I wanted to make sure I give a summary, because I may not be able to go through all of my slides, and I'm sure Sarah will tell me when my time is over. So what I thought I'll do is compare monkeypox to COVID-19. You can read all about monkeypox in the books on the CDC website, on the WHO website, and I'm sure some websites of the Ministry of Health of Pakistan. But I thought I'll give you a comparison, because we have been so consumed by COVID-19 over the last several years. So I thought a comparison would be appropriate. I want to remind everybody there's a big difference as an infectious disease specialist and epidemiologist. One of my roles as an epidemiologist, I'm the chair of the Infection Prevention and Control Committee for a 5-hospital health system, which includes a children's hospital. And one of my roles is to not only develop policies, procedures, and guidelines, but also to educate healthcare providers. And that's one of the things I had to do very early on when monkeypox came. This is an outbreak which is very different from a pandemic or an epidemic. I don't have time to go into the details on explaining the differences, but if anybody is interested, you can go and search that a little bit more. SARS-CoV-2 was a novel virus. As a result, we really did not know much about it when it came about. And so the rise in new SARS-CoV-2 variants has coupled with a virus's ability to transmit airborne only fueled and continues to fuel this fire. So that's why it's a pandemic, it's an epidemic, as opposed to monkeypox. It's not a novel virus. We have known about it for decades, and it spreads primarily through close contact, and so it's a less efficient spreading between humans. And that's an important distinction to be made when you're talking about a pandemic or an epidemic and an outbreak. So that differentiates these two viruses. And whereas for SARS-CoV-2, we had to go through a lot rather quickly to develop a vaccine. We already had a vaccine available for monkeypox, so these are being administered in the United States to high-risk communities. We give the vaccine at our center, not only to our HIV-infected population, but anybody else who's at high risk. So I just wanted to compare the two. The monkeypox, as I said, is caused by monkeypox virus, and COVID by SARS-CoV-2. The year monkeypox was discovered was in 1958, as opposed to SARS-CoV-2, which was in 2019. The monkeypox is a double-stranded DNA virus, and SARS-CoV-2 is a single-stranded DNA virus. That's the other important thing to remember, is that the monkeypox only has 2 clades, and we know that SARS-CoV-2 already has 28 clades. So, and we want to get more of them. And there's probably a much better knowledgeable virologist in the audience than I am who can explain that better, but that's a huge difference. And of course, the differences, I already talked about that. The primary route of transmission is different between the two. That makes a huge difference. And of course, we know that there are different animal reservoirs. We believe that it's the bats, pangolins, and minks who are the reservoirs for SARS-CoV-2, and of course for monkeypox, it's monkeys, rodents, and other small mammals also. I'm going to quickly talk about this because there's just not enough time. It's a small virus, SARS-CoV-2, about 100 nanometer in diameter. It's the S protein is the one that binds to the host cells, and that's the protein, we think is the key element, and that's the one the vaccines are really focused on developing antibodies and developing protection. Whereas monkeypox is a large virus, 220 to 450 nanometers long, and has surface proteins that facilitate its entry into the host cells. It has 11 to 12 such which are called transmembrane proteins, and that will fuse the host cells. So I think there are significant differences between the two viruses, not slight. So I'm going to talk a little bit about monkeypox, because I think what you need to remember is that there are really two viral clades, the Congo Basin clade and the West African clade. Luckily, the current monkeypox outbreak is with the West African clade, and it has a much low case fatality rate of about 1%. So I have 2 minutes left, so I'm going to do some quick things here.
You can take more.
Okay. Let me see. I'm going to try to focus on some. So what is clear is that monkeypox is far less transmissible than COVID-19, and that's a good thing, and that is why it's sort of withered away. We had these cases of monkeypox. Even in my own community, we had cases of monkeypox, and we're not seeing that many of those. I understand that there aren't too many cases of monkeypox in Pakistan, but certainly we are not seeing as many either. Quick reminder of the symptoms of disease. I'm going to just focus mostly on monkeypox. You're all aware of what happens with SARS-CoV-2. So monkeypox can take up to 3 weeks after exposure for symptoms to develop, and symptoms may mirror those of COVID-19 during the early stages, where all viruses, they will cause fever, some headaches, some chills. Right now it's influenza, RSV, human metapneumovirus, adenovirus. So they can all cause very similar symptoms. And clinically, monkeypox really differs from COVID-19 is by the development of rash. The rash is so key in monkeypox to differentiate. And this rash can be painful, it can be sort of itchy, and can be distributed on the face and the extremities and the genitals. And the differential diagnosis, if I have time, if I come to that, that's what we are talking about here. And it's self-limited disease. Most people with monkeypox will recover in 2 to 4 weeks, but it can be fatal and severe, especially in the immune compromised. And that's why we talk about HIV patients. And of course, the mortality rate, fortunately, is nowhere close to what we saw with COVID-19. Again, the severity depends on age. Young children are more likely to develop a severe disease with monkeypox and the presence of underlying conditions. Diagnosis, for SARS-CoV-2, we had to develop new diagnostic tools, where for monkeypox, we had those tests, and they may not always be available to everybody, but we have the big differences. For SARS-CoV-2, we have a point-of-care testing. We can all do antigen testing even at home. We don't have something like that for monkeypox, and I don't think that's going to be developed very soon, since the outbreak is not as severe right now. Prevention and treatment of monkeypox. As I said, no COVID-19 vaccines were at present at the start of the pandemic, but now we have 4 vaccines. Actually, that's in the United States. There are a lot more vaccines, the Sputnik vaccine, several Chinese vaccines, but 4 vaccines are approved in the United States. But for monkeypox, as I mentioned in the very beginning, there were already vaccines available to protect individuals. The live attenuated vaccine is called the Jynneos vaccine. Is currently being used for widespread vaccination efforts. Jynneos was developed to prevent really smallpox and is also protective against monkeypox. We are also participating in the vaccine trial, but it's people less than 18 years of age at highest risk for monkeypox infection. And now this vaccine is approved for use in less than 18-year-olds under what we call an emergency use authorization in the United States, at least. Jynneos is preferred vaccine for monkeypox and may be used for those more than 6 months of age under certain circumstances. There's a second smallpox vaccine called ACAM2000 that can be used as an alternative and can be used in those more than 1 year of age. ACAM2000 does have the potential of more side effects. So just remember that is not as safe as the Jynneos vaccine. Again, we focus on those for prevention who are at high risk. Those are currently MSM and some other individuals with MSM is men who have sex with men. There are no specific treatments for monkeypox, although tecovirimat, which is Topax, is a drug which is approved for use in smallpox and is also now approved for use in individuals with monkeypox. I wanted to just quickly go over within 20 days of illness of onset, the epidemiologic risk factors. There are reports having contact with person with similar appearing rash or someone that confirmed that epi-link, the epidemiologic link for monkeypox is critical, and its close contact with or intimate person contact is important. Or if in the United States we have traveled to parts of the world where there's an increased risk. I want to show you some this quickly. I'm going to skip through these slides. Stop me anytime. Okay, I can stop anytime. As I said, incubation period is 4 to 17 days, and during this time the person may not have symptoms and may feel fine. We talk about the prodrome, the enanthem, and then characteristic rash that may be painful or itchy, and then I'm going to try to show you some pictures of the rashes. The rash can be a variety of types. I don't know if it transmits well or not, but as you can see, this could look at many different types. Lesions typically develop simultaneously and evolve together at any given part of the body. So it doesn't come in crops, they evolve together. You know, we are familiar with the chickenpox where it is in crops. There are different developmental phases. The lesions go through 4 stages: macular, papular, vesicular, and pustular before scabbing over and desquamation. Now, it's important to know that you are not considered non-contagious until they have scabbed over and desquamated. Here's some other examples of how the rash may look. I just want to give you the feel of that. They may be rectal symptoms, for example, purulent bloody stools, rectal pain, and rectal bleeding, and they have been frequently reported in the current outbreak, and that may be because it was largely seen in the men who have sex with men. As I said, I'm not going to go. Here's some other pictures. I mean, this rash can pretty much look like anything. I'll make this my last or next to last slide. I just wanted to go through this because this is important. It starts as an enanthem. Sometimes lesions first form on the tongue and the mouth, so you have to look into the mouth. Then it becomes macules, and for 1 to 2 days, those macular lesions appear, and the next 1 or 2 days, they become papules, and then again 1 or 2 days they'll become vesicles, and these are typically these vesicle lesions will be present. Then become pustules, which last 5 to 7 days, and it takes another 7 to 14 days for them to scab over. And when they get resolved, you can have pitted scars or areas of a lighter or darker skin may remain after scabs have fallen off. Those of us who have seen people who had smallpox, you know how they look really scabbed over and pitted, and they can have on the face of the part. This may look like that, but not as bad. The differential diagnosis, of course, chickenpox, measles, bacterial skin infections, scabies, syphilis, and medication-associated allergies. You have to consider all of this. Again, if it's diffuse rash, it may be slightly different differential. If it's genital rash, slightly different. If it's proctitis, you have to worry about GC, chlamydia, and HSV. I think I'm going to say for treatment of monkeypox, some of the other things that have been tried are cidofovir, benocidofovir, trifluridine for eye disease, and of course Topax. I think that is my last slide. Thank you very much, and I appreciate you giving me a few extra minutes.
Thank you, Dr. Pati Thakur. I think a very important talk, sensitizing us with something which is actually very new for us. Of course, our generation has not seen the chickenpox, the smallpox, and the mpox coming up. We really need this sensitizing talk. So I have a question, and then I have a request as well. My question is, although the vaccine is not available with us at the moment, but if the vaccine does become available in Pakistan, what would be the high-risk groups that we would focus to vaccinate?
Yeah, I think since, well, of course, one is the HIV infected, especially MSMs, and I've heard in the last several weeks that there's certain outbreaks of HIV now in Pakistan. I think, unfortunately, because of social and cultural reasons, we don't talk about these things. But there are a lot of MSM in Pakistan, whether we like it or not. So if they are MSM, especially if they have HIV, they would be at increased risk for. So that would be one group that I would think would be eligible. But other people who are increased immune deficiency, who may be at increased risk. But I think it's going to be tough because the MSM are not going to come forward. So as healthcare providers, we want to make sure we can reach out to them.
Right, thank you very much. And the other thing that I wanted to say is, or rather request this sensitizing talk, I see the pediatrician sitting over here as well. I know that you agreed to come to the pediatric department on 27th, so I would really love if you could talk in more detail about Mpox over there. So I think that would be a very good session for all the audience. Dr. Mubin Rathod would be with us in the Department of Pediatrics in the morning of 27th of December, Tuesday.
Inshallah. Thank you very much.
Please let me know if any student want to ask any question. Anyone who wants to ask any question? Okay, thank you very much. Dr. Mubin is always very kind. He is the reviewer of Annals of King Edward Medical University, advisory board member, and also he is a contributor to the most cited research articles published in Annals of King Edward Medical University. So, sir, we have a lot of gratitude for you. Now I would like to request the President Camkhana, Dr. Fateh Shehzad. He is among us. Sir, please come on the stage and please have your seat. Our next talk is by Dr. Nighat Yasmin on characterization of genomic diversity among carbapenem resistant E. coli clinical isolates and antibacterial efficacy of silver nanoparticles from Pakistan.
Thank you, Dr. Saira, for inviting me for this talk. Today I will talk about the characterization of genomic diversity among carbapenem-resistant E. coli clinical isolates and antimicrobial efficacy of silver nanoparticles from Pakistan. My name is Dr. Nighat Yasmin, and we recently published this article in journal Microorganisms last month. So, repeated exposure of the bacterial species with the antibiotics results in the selection pressure that ultimately leads to changes in the bacterial physiology and resistance development. So, carbapenem resistance has been accumulated among the enterobacteriales due to the significant spread of core carbapenemase resistance genes that are present on the plasmids or mobile genetic elements, and carbapenemases are the most stable and transferable form of resistance, and the core carbapenemases including NDM, OXA48, VIM, IMP and KPC. So since the identification of NDM carbapenemase, its spread has been commonly detected among enterobacterials, especially in Pakistan, India and China, while IMP carrying enterobacterials were predominantly detected in Taiwan and Japan. VIM was most commonly leading cause of the outbreaks in Europe, China, and especially the Greece is the hub of the VIM carrying outbreaks, while the KPC producing enterobacterials were reported in USA, Europe and China, and OXA48 was predominantly spread in Turkey, Europe and Mediterranean region. So this geographic distribution of carbapenemases shows that they have adopted some transferable ways, or they are very intelligent that they adopted these ways that they are now spreading worldwide. So common carbapenem resistant enterobacterial pathogens are the E. coli, Klebsiella pneumoniae and Enterobacter species, while the E. coli E. coli is a part of normal human gut microbiota. However, several supremely adopted E. coli clones with multiple resistant genes were shown to custom to the new niches, thus causing far-ranging diseases such as urinary or respiratory tract infections, intestinal infections, and sepsis. So most studies about the antimicrobial resistance from among E. coli in non-clinical settings from Pakistan shows that OXA1, CTXM15 and TEM are present in the chicken meat, MCR1 and TEM are in the cattle farm environment, while NDM, OXA48, TEM and SHIV are present in the sewage water. While the studies from Pakistan in the hospital-acquired infections shows that block KPC2 and NDM1 is present in the Pakistan environment. Secondly, the efficacy of the currently available antimicrobials has been reduced due to the overuse or the misuse of the antibiotics. Therefore, the nanoparticles in combination with the antibiotics enhance the antimicrobial efficacy against resistant microorganisms, and it has been shown that a powerful antimicrobial response has been observed when microsynthesized silver nanoparticles in combination with imipenem were used against the imipenem-resistant Klebsiella pneumoniae, and other studies shows the elevated effect of silver nanoparticles with kanamycin and colistin against MDR pathogens. Therefore, the use of silver nanoparticles may be considered as one of the useful therapeutic strategies for treating microbial infections. So, the globally widespread carbapenem-resistant E. coli strains necessitate the novel approaches to stop the spread of these dangerous infections, and the distribution of carbapenemases among Pakistan, especially in E. coli, is however only partially or sparsely studied, and especially in the study area it is not studied at all. Therefore, this study aims to investigate the burden of carbapenem resistance, genomic diversity, and efficacy of antimicrobials with silver nanoparticles among the E. coli clinical isolates of Pakistan. So, we collected around a total of 184 carbapenem resistant clinical strains were retrieved out of 605 isolates from Mew Hospital during May 2019 to August 2020. And the clinical samples were collected from a diverse range of clinical hospital sections such as surgery, nephrology, medicine, urology, ICU, cardiology and oncology, and the sample types were the urine, wound, pus, pleural fluid, tip cells, blood, sputum and the tissues. We did the antibiotic susceptibility pattern tested by conducting the standard disc diffusion method as per the CLSI guidelines, and the standard broth microdilution method was used. To a certain antimicrobials, MICs, and double disc synergy test and carbapenem inactivation methods were used to identify ESBL and carbapenemase producing strains, and the quality control strains were E. coli and Pseudomonas aeruginosa. Then we isolated genomic DNA by the heat lysis method, and carbapenemase encoding genes including NDM1, OXA48, IMP, WIMP and KPC2, while extended spectrum beta-lactamases including CTXM, SHIV and TEM were detected by PCR. Agarose gel electrophoresis were used to dissolve the PCR products. ये कहाँ से प्रेस हुआ? अच्छा चलिए फिर अभी पीछे करें इसको ज़रा. While we did the in-house cycle sequencing was performed using the big dye terminator V3.1 kit. PCR product was purified by using big dye exterminating purification kit. Capillary electrophoresis was done by genetic analyzer, and we have detected 87.4% of the isolates carrying carbapenemases, and the ESBR resistant genes were detected in 82.1%. The detailed distribution with respect to sample and ward is given in these tables. In order to identify the genetic variability based on the clonal lineage, we identified the sequence types as T405, 131, 101, 10, and 648. And the plasmid replicon types F2, F2K, AC, LM, and N were detected in our clones. And we see that all the resistant strains were 100% resistant to third generation cephalosporins, while the susceptibility against polymyxin B, doxycycline, and amikacin was observed. And the results are compiled in this table. The correlation of carbapenemase resistant genes with sequence types showed that different combinations was existed in our population. Most importantly, we found that ST405 and 131 was prevalent among NDM7 OXA48 and NDM1 OXA48 with a different combination of extended spectrum beta lactamases, while ST10, 101 and 648 was prevalent among NDM1 harboring isolates. The distribution was shown in these tables. And then we see that when we use the silver nanoparticles in combination with the meropenem, we see that synergistic effect in most of the isolates, while few isolates showed no effect. So in our study, carbapenemase production was observed in 64.7% of the E. coli isolates, while previously variable ranges were observed from Pakistan ranging from 37.1% to 93%, while in other species like Klebsiella pneumoniae it was observed 27.2 to 82% carbapenemase production. So we found that 28.3% carbapenem resistant E. coli strains, while from Pakistan the trend is increasing, and it showed that the carbapenem resistance has been increased in Pakistan due to the overuse or misuse of the antibiotics or over-the-counter prescription drugs. Thank you very much.
Thank you very much. Now this house is open for questions. I have one question. Okay, if we have the carbapenem resistant species, do you think that it is also resistant to some other important antibiotics that are available?
Yes, ma'am. We observed that all the carbapenem resistant species are almost 100% resistant to cephalosporins, while polymyxin B, colistin, and doxycycline or amikacin, these drugs shows little resistance, so they are more susceptible. While we also observed that when the antimicrobials are used in combination therapy, like 2 or 3 combinations, then it shows little efficacy against the resistant strains of the carbapenem resistant strains.
Thank you very much for making us wiser. Now our next speaker is Dr. Tavinda Dugal. She is here, and we are very glad that she has joined us. So I would like to invite her on the stage. We have another speaker, Dr. Umair Lubna Abbas. She is Associate Professor of Medicine, Department of Medicine, University of Missouri, Kansas City, US. Her topic is State of the HIV Epidemic and Science.
Slide on करें. The last one.
कौन सी स्टेट हो जाएगा?
Good morning, everyone. I'm extremely pleased to be here to talk to you about the state of HIV epidemic and science. So since 1981, when the first case of AIDS was detected in the US, worldwide there have been about 84 million cumulative HIV infections. In 2021, about 38 million people were living with HIV, 1.5 million people were newly infected, and there were 650,000 deaths worldwide. These data were released by the UNAIDS at the World AIDS Day in 2022. Every year they come out with these statistics. And since the start of the pandemic, there have been about 84 million new infections and 40 million deaths. As you can see from this slide, most of the infections are in sub-Saharan Africa. However, in Asia and Pacific, it's the second largest region with HIV with 6 million new infections. On this slide are listed the modes of transmission. In sub-Saharan Africa, which is the epidemic epicenter, about 50% of the infections are transmitted heterosexually in a generalized epidemic. However, in the rest of the world, majority of the infections are transmitted through men who have sex with men and through injection drug use or unsafe injections. So you may know about it, but the whole world is trying to end the HIV epidemic, and listed on this slide are the fast-track targets by the UNAIDS. And by 2030, all across the world, we wish to achieve 95, 95, 95 for treatment. By that we mean that of all the people who have HIV, 95% be diagnosed and detected through HIV testing. Of these, 95% be on treatment, and of these, 95% be virologically suppressed. These are world targets and are being followed or pursued in all the countries of the globe. In terms of new infections, by 2030, we want to bring down the infections to 200,000 per year. I just told you that in 2021, there were 1.5 million new infections. So we have a long way to go. On this slide, you can see that from 1990 to 2021, the number of new HIV infections globally have been declining, especially after the peak in the mid-90s. However, I'm going to show you some data for Pakistan which are very troubling. On this slide, you can see HIV coalition countries of the UNAIDS WHO. For all the countries listed on this slide, the infections are going down, except for 2 countries. Infections have gone up by about 5% in Angola, but in Pakistan, they've gone up by 74%. And you can see it's the only country that is marked here going up by such a wide margin on the right-hand corner of the slide. Similarly, globally, the number of AIDS-related deaths have been declining. And you can see that there was a peak in the 2005, and since then they've been falling. Especially over the last decade, they've been falling. In contrast, these are the data for Pakistan. There has been a 500% increase in the number of AIDS-related deaths from 2020 to 2021. So I just told you that the global targets are 95, 95, 95 by 2030, meaning that of all people who are infected, they should know their status. 95% should know their status. Of these, 95% should be on treatment, and of these, 95% should be suppressed. Here are the scorecard for the whole world. So for the first 95, the score is an 85. And the next 95, meaning of the 95, so 90% should be on treatment. As of 2021, 75% were on treatment. and 86% totally should be suppressed, and 68% were suppressed. As you can see that the scorecards look very similar for most regions of the world. Here's the scorecard for Pakistan. It's one of the worst scorecards that I've seen. So for the first target of 95, Pakistan is at 23. For the second target of 90% being on treatment, Pakistan is at 14. And we do not have reliable data for virologic suppression. Now, this was the epidemic part of my talk. Now I will talk about the science. So scientifically, we've come a very, very long way in terms of HIV. Now we have the tools available to us to bring this epidemic to a close. But we must close the implementation gap, meaning we should provide these tools and these advancements that have been made to the people who have HIV or those who are at risk of developing or acquiring this infection. And secondly, we need to continue to develop and deliver new and improved treatment and prevention interventions. So first, talking about the implementation gap. So what do we need to do? More testing, provision of antiretroviral therapy, and then retaining these people in care, and then making sure that they are virologically suppressed, management of comorbidities, prevention, harm reduction services, including needle exchange programs, food, housing security, and particularly in the developing countries, including Pakistan, human rights, including stigma and discrimination reduction. One of the most important biomedical research advances of our era has been effective antiretroviral therapy for HIV. And here is the antiretroviral medicine cabinet where you have numerous classes of medications that can be used listed here. In 1980s, a person who was diagnosed with AIDS was at the end stage and would live for only 1 to 2 years. Today, a person in their 20s diagnosed with HIV who are put on treatment can expect to live a normal lifespan. This is an enormous achievement of science. You can see that treatment has globally decreased the AIDS deaths across the world, shown here in red, and then treatment coverage has been increasing steadily across the world. So what are the key gaps? Starting people on treatment, those who start should adhere, and then they need to be retained in care. So of the 38 million people living with HIV as of 2021, about 29 million people were on treatment. So we have a treatment gap of about 10 million. So in terms of HIV prevention, we have numerous interventions, particularly pre-exposure prophylaxis, which are antiretrovirals taken by susceptible people to prevent the infection. Also, treatment is prevention. So if an infected person takes treatment and is virologically suppressed, they cannot transmit the virus. But a person at risk of HIV can also take similar drugs and be protected from infection. So here in 2012, the FDA approved Truvada, which is a pill people can take to prevent HIV infection. However, only 3 million people across the world are taking PrEP, so we have an unmet need. Shown here, my research focus is epidemic modeling. So these are guidelines from the WHO about oral PrEP, and listed here is one of our papers that was a key study that informed global guidelines for implementation of PrEP. And similarly, this is the WHO guidelines for implementation of depivirine vaginal ring. And again, our paper circled in red was a key study informing the implementation. All right, so here are some improved treatments. We now have long-acting antiretrovirals for both treatment and prevention, injectables that can be given every 2 months. The Cabenuva, which is a combination of two injections, cabotegravir and rilpivirine. And in the pipeline is lenacapavir, a capsid inhibitor, which is an injection. And once it's launched, it will be 1 two injections per year, and then the patient will be treated for HIV for the whole year. So this is remarkable. And also we have broadly neutralizing antibodies or BNAbs, again given for treatment and prevention. That's kind of on the horizon. And the cure research is ongoing to eliminate the reservoirs or somehow stimulate the immune system to control the treatment naturally. And then long-acting antiretrovirals are being used for prevention. In the US, we have approval of long-acting cabotegravir injection people can take every 2 months. And then again, lenacapavir for pre-exposure prophylaxis. The search for vaccine continues. So ending the HIV/AIDS pandemic, we need to follow the science, and we have to bridge the implementation gap. Thank you.
Now this house is open for questions. If there is any question, please let me know. Okay, I have one question. If we have a pregnant woman who is having a fetus and we have the risk of transplacental infection with HIV, so what would you recommend? Because now we have many antivirals that are available. So what is the latest recommendation?
So we need to test all pregnant women for HIV, and they need to be put on immediately on antiretroviral therapy. So we do have mother-to-child transmission protocols that are available for those who are detected late stage. But now the way to go is that to provide antenatal care, and they should be tested for HIV and put on antiretroviral treatment. And the regimens are pretty much similar to what non-pregnant women would receive. So the first-line regimen would be tenofovir, diazoxide fumarate, or tenofovir alafenamide, and trithyramine and dolutegravir. No, globally now we are using dolutegravir, integrase inhibitors, so they should be put on treatment immediately. But if they're presenting very late, then yes, there are various protocols, including AZT, that you can give. But the way to go now, the standard of care, is provision of antiretroviral treatment to the pregnant woman. Yes. So the HCV treatments are now have been revolutionized now. You have protease inhibitors. I'll be honest with you, I'm not sure what's available in Pakistan, but in the United States, people who are viremic for hepatitis C are actually treated. And similarly for hepatitis B, tenofovir or tenofovir alafenamide containing regimens are the way to go, because they treat not only HIV but also hepatitis B virus. So tenofovir alafenamide. And then hepatitis C, there's a whole slew of protease inhibitors now that's available that are now used in the Western countries.
So I was just going to make a comment. I think for mother-to-infant transmission, or child transmission prevention, we were part of the original 076 trials. AZT still stays the key. The mother should be treated for her own disease. That's key. But then, during labor and delivery, they must receive IV, ZDV, or AZT. That's part of the protocol. And post, the baby needs to be treated in the United States for 6 weeks, although other parts of the world it's shorter duration. And ZDV, AZT is a part of that, but depending on several factors, we sometimes have to use triple therapy in the baby also. And that depends a lot on the mother's status and if we have the genotype, phenotype of the mother's virus. If we don't have any of that in our practice, the assumption is made this is a high-risk woman who's under care, has a high viral load, we can treat that with 3 drugs until we know otherwise. So I think what has happened in the United States at least, literally within a year or two of implementation of the 076 protocol, which was back in 1994-95, the mother-to-child transmission plummeted. But what we may have to do here is what's done more in South Africa perhaps, which is slightly different protocols, and part of that has to do with breastfeeding. So if the woman is going to breastfeed, you may have to prolong therapy. So there are many factors I think I always stress to my colleagues in pediatric infectious diseases that we have to create our own guidelines for Pakistan. What we do in the United States may not be as useful for resources and other things. Similarly, what's done in South Africa and other parts of Africa may also not be practical. So it's extremely important we have our own guidelines. And breastfeeding is going to be a key factor there. So even in the United States, we are moving towards not totally discouraging breastfeeding because of social and cultural issues, especially amongst the immigrant populations.
Yeah, thank you for those comments. So in terms of guidelines, there are WHO guidelines for global implementation of antiretrovirals, and they also have pediatric guidelines. And one issue about breastfeeding, it's a sticky wicket because in resource-limited countries, breast milk is often the only food that's available to the infant. And if they're using formula feeding, then the water is not sterile. So it's a difficult issue. But again, the highlight is that antiretrovirals, provision of antiretrovirals to all those who are infected, all those who are at risk. And the concept is the same. It says post-exposure prophylaxis for the infant and for the mother's treatment. Thank you.
Thank you very much for the brilliant presentation. And in Pakistan, we are again having another epidemic of HIV, and we have seen that so many cases HIV positive, especially in youth and adolescent, they have been reported. And this is something that we should think of making guidelines in the context of Pakistan. Now I would request our next speaker, Dr. Tavinder Dugal. She is the consultant endocrinologist and the chairperson CAMCA UK. Her topic is Do Men Pause? Debunking Myths and the Reality of Male Menopause.
Thank you, Saira, and thank you for being patient with me. Thank you. A brief 10 minutes talk about this. I thought it was interesting and it would probably be relevant to some of the people in the audience. It's just more recently, this was on Time Cover. It was talking about menopause, and I think people caught on to it, but that is not right. Actually, as far back as 1896, this chap, I don't know if anybody recognizes him from this photograph, but this is Brown-Secord, who described the famous Brown-Secord syndrome. And so he was born in Mauritius, and he was a French scientist. And basically, at the age of about 72, he felt that he needed some testosterone supplementation, and he prepared an extract from dog testicles and injected himself with it. And after injecting himself with it, he reported that the injections improved his vigor and capacity for work. But we now know that, these steroids are fat soluble, they're not water soluble, so it was probably a placebo thing. So this should actually set the tone for my talk, that, a lot of this is perhaps mediated by the pharmaceutical industry and the placebo role in the male for the use of testosterone, as using anything they think that this is doing them good. The issue is of aging population. So I will talk about the US because the study that I looked at was from the US, that people over the age of 65, they are supposed to increase to almost 100 million by 2050, which is more than double of what it is at the moment. And we know that as people advance in their age, their frailty increases, they have falls, they have reduced muscle mass, they have other cardiovascular problems, and that results in hospitalization and morbidity and then subsequently mortality. In a quest to find out that delaying aging and the problems related with aging and finding an coincidental low testosterone or testosterone level, which may be biological for that age group, people have tried to say whether this is responsible for some of those processes that lead to hospitalization and aging, etc. So some people have taken to prescribing sex hormone replacement in older men, and in the US, I'm afraid some of them have even been in the range that is suitable for their age, and they've still been supplemented with testosterone. So what does testosterone do that is so important? And we all know what it does, about 6 or 7 important functions. aside from the reproductive function, it has got the role of building muscle, giving the energy, giving the thought process that the male has. Also producing good bone density and of course giving them the drive. Reducing the fat to muscle ratio, increasing the muscle to fat ratio, so more muscle, less fat. And of course it gives them the male hair pattern which is on the face and rest of the body. And a brief thing about the physiology, I won't bore you much with it, but testosterone, as we know, is something that is made through a cycle that comes from the hypothalamus, and from the hypothalamus to the pituitary, and from the pituitary down to the gonads. And every 90 minutes there's a pulse that generates testosterone, and these pulses are more so in the early hours of the morning. And hence I think measuring testosterone at the right time is very important. So although the pulses are generated every 90 minutes, but the levels would be optimal at the time of waking. So maybe around 7:30 to 10:30. So this is a cartoon that summarizes the whole pathway of making of testosterone, and towards the end you see the prostate, where you have the testosterone being converted under the influence of 5-alpha reductase into dihydrotestosterone, which also acts on the hair follicle, leading to hair fall and also the hypertrophy of the prostate. So lots of organs involved, and also the adrenal gland you see, because obviously the adrenal gland also makes some testosterone, which is the sole provider of testosterone in the female, incidentally. In the males, obviously, we have the gonads as well. So about only 2% of testosterone circulates in the free form, and the rest is kind of bound to albumin. Some of it is loosely bound. And most of the assays would measure the total testosterone. So the total T is measured, which means that the bound and the free is measured together. And therefore it's very hard to say if someone is symptomatic and their total testosterone levels are normal. But you can also look at the sex hormone binding globulin, which is obviously the binding globulin, and make a ratio of it, so which is the index. You can have the index measured, the androgen index, which the labs can measure. So basically what happens is the sex hormone binding globulin increases with age, so therefore the bound testosterone increases with age, and the free testosterone, which is the one that is the functional testosterone, reduces as people get older, especially 60 and above. So this is what happens. So sadly for most people in the house, I think that they have gone past their prime of testosterone. It starts to decline at 25, and then at 35 they have 70 to 75%, and so on and so forth, till they get to 60, where they get half of what they have when they are 25. And in the next couple of slides you will see that by the time people are about 90 or so, it's literally very minuscule amount of testosterone circulating. So this is another cartoon graph that gives you the levels by age, and as you can see there is a very sharp decline around 50, another very sharp one around 60, and then after that it's just floating around till there is another drop around 90. And this is showing this inverse relationship between the sex hormone binding globulin, which is the blue curve, and the free testosterone is the gray curve. The total T is the orange curve. So as you can see, as people get older, the sex hormone binding globulin increases, and therefore the total testosterone, which is the orange curve, will go down. And as you can see, by the time people get to 90s, which they are getting more and more frequently to later and later in their lifespan, their testosterone levels are quite low. So what is the impact? In most people, although the testosterone levels biochemically are going down and have fallen, and the decline is at a steady rate of about 1% from the age of 30 to 40, in itself it doesn't cause many problems, and therefore you have to ask for symptoms, which we will come to in a bit. So what are the symptoms? So basically, someone who has got low testosterone may complain of tiredness, mental fogginess, depression, low sex drive. They also run a risk of osteoporosis, so they might present with low impact fractures. And someone who doesn't have that is obviously high performing and doesn't have any of those symptoms. And as I said, you have to check the levels at very early in the morning. 7:30 to 10:30 is the time when you would ask the patient to present to the lab to get it checked. So I just thought I'd quote a study which was, because there's so much data coming which is giving you different studies which have looked at the bone mass, they have looked at the lean muscle mass, they have looked at the other indices that testosterone may have produced. And therefore I thought I'd talk more about this study which was looking at for about quite a few years, and it was published in 2016 in the Lancet. It was called the TEAM study. So the testosterone was given to older men for about 36 months, which is about 3 years. They had low to low normal testosterone, and it did not improve their cognitive function. So I think in people, when they're at a certain time of their life and certain time of their career path, they might complain of reducing cognitive function. But if replacing testosterone doesn't improve that, then I guess this is something that people have to think about before they start replacing testosterone. I think we need to have further long-term studies before we can start saying, is it going to cause any benefit towards preventing Alzheimer's, because we didn't have any evidence of this in 36 months. So therefore, in the shorter term or in medium term, it doesn't give any benefit to thinking processes. And people of every age can do the activities that they want to do. As I said, that mostly doesn't affect the performance that they have, the physical performance that they would like to do and the activities that they want to do. It is not very simple if people presume that as they age, testosterone falls, and this is the only reason why they're feeling tired, why they have all those symptoms. There is a chronobiology of aging, and lots of hormones are involved in that, and therefore replacing just testosterone is not going to be the wise thing to do. So the general public perception of thinking that, you know, erectile dysfunction or impotence of middle age or later age is just related to testosterone is just false, because lots of other things are happening. There's furring of arteries, there's atherosclerosis, there are several other hormones the cortisol goes up, people may get diabetes, they might be on antihypertensives, there might be lifestyle issues and all those things. The benefits that we know of are that obviously the muscle mass increases when you start to supplement testosterone, the bone density of the person increases, and obviously they score better on the sexual function. But although the muscle mass increases, there was no improvement in their walking test or stair climbing. So although the muscle mass is there, it doesn't really contribute to improved quality of life. So one would wonder, when would you start replacing testosterone? I think mostly it would be people who would be having night sweats and perhaps a lot of muscle weakness, in which you would feel some improvement. So the key points that you would want to take away from this talk, I would think, would be that it's likely to be beneficial in healthy older subjects with significant hypogonadism. So what I'm trying to refer to is that most of the studies that were done were in people who were 60 or older and had no other comorbidities, like they didn't have any diabetes or hypertension. It would be hard to find someone like that, I think, in the population that exists here in Pakistan. So people who have no comorbidities may tolerate testosterone supplementation better, because we know that there was the risk of increased cardiovascular disease in people with testosterone supplementation, and therefore I think replacement in patients who have borderline low or low normal levels is yet to be proven, and therefore the benefits would outweigh the risks, wouldn't outweigh the risks. Also, testosterone shouldn't be used in individuals with, as I said, significant cardiovascular disease and prostate cancer, and it obviously leads to prostate hypertrophy. Extreme caution, obviously, in benign prostatic hyperplasia. There is no known, say perhaps, a study that would give the benefits beyond 2 years, and it's questionable, and there are few long-term treatment studies. So as I say, medicine is an art. We should create safe masterpieces where our patients can feel safe, that we're in the hands of a safe physician who's not being directed by the pharmaceuticals or being pressurized by prescribing things that may not be of complete benefit to the patient. And perhaps use it with caution in the right patient. So this is my email. If anybody wants to have any questions or ask me any questions, they can email me or ask me now.
Right. Now this house is open for questions. Right. Dr. Tabinda, I have one quick question. As you have said, medicine is an art. I totally believe prevention is also an art. So what are 2 or 3 important key messages for the prevention?
So it's mainly keeping active and it's mainly keeping active and keeping the muscle mass and the bone mass in good order. And I think if you're active and you reduce the atherosclerosis, perhaps the other side of having erectile dysfunction and all those things would go down. And every time you are active, you do increase your free testosterone as well. So perhaps it is lifestyle mostly.
Thank you very much. It means that there is no gender difference. Both genders have to have lifestyle modification in order to keep themselves young. I would like Dr. Tabitha Dugar, please have the seat on the stage. I would also like to request our Vice Chancellor, Professor Mahmood Ayaz, along with the Chair of 42nd Scientific Session, Professor Ijaz Hussain, please have the seat on the stage. Our next speaker is, please. Dr. Mohammad Tufail, he is the consultant pulmonologist in Chair Camca UK from 2018 to 21, and we are very grateful that Dr. Tufail has done a lot of webinars for sharing his knowledge, especially during COVID-19. Very welcome, Dr. Tufail.
Assalamu alaikum, and thank you very much, Professor Saira Afzal, for kind introduction to all the organizers to give me this opportunity to talk on this prestigious forum. So, in next 10 minutes or so, I will be talking about any lessons learned during COVID-19 pandemic, any opportunities which have arisen, and how we prepare ourselves for the future. So, this is a paper recently published about a couple of weeks ago in Nature. The WHO estimates the excess mortality from COVID-19 pandemic is much higher what we have estimated. So this is the data from 2020 and 2021. The reported mortality from COVID-19 is about 5.46 million million deaths. But WHO estimates this is not true. It is actually nearly 15 million deaths from COVID-19 pandemic. So this is a quite deadly disease. And I will merely like to mention that we have been involved in many webinars and critical care MDTs here. If I talk about the mortality for intubated patients, from USA the figures are coming anything about 25% mortality. I'm talking about intubated patients due to COVID-19 infection. In UK, our mortality rate is about in the range of 35%. Now, there is no data from Pakistan, and from our own observations, I think if any patient due to COVID-19 gets intubated, mortality is not less than 80%. Do we have data, or anyone disagrees with me? Anyone who does critical care, I think even more than 80%. In my observation, any patients who got mechanically intubated due to COVID-19 infection, I say again, the mortality is more than 80%. Now, in the Western world, if due to any disease or for any service, the mortality is 80%, they will close the unit altogether and investigate it. So I will really argue here that the policymakers and government and our institutions need to really work hard to improve the provision for intensive care medicine in our country. Because any one of us can get ill and all of us will have the same mortality. So just this point to keep in mind. Unfortunately, during the pandemic, we have to rely on our political leaders, and it is all in their hands basically. Dr. Fauci said that I could never have predicted the politicization of science that occurred under Donald Trump's presidency. Once he said that he can treat COVID-19 infection by putting bleach into the lungs. And in UK, we had Boris Johnson, and Boris Johnson made many mistakes, especially in the beginning of the pandemic, not putting the lockdown in a timely fashion, etc. But when it comes to true democratic countries, obviously the advisors will say we only advise, these are the ministers who decide, and they made many mistakes, hence our mortality went up initially. And to be honest, in Pakistan we did not do badly when it comes to political leadership. And then when pandemic comes, there is a misinformation, hoax, lots of strikes and lots of protests, no forced vaccination, please don't lock down us, and all these things. So human behaviors, this is something new. This is a new disease. All of us are all in it together. But we were confronted by lots of misinformation in the media. And one example is one of our Pakistani British surgeon practicing in UK. He made YouTube videos that COVID-19 is a hoax. This is all man-made disease, and etc. etc. I remember I came back after 12 hours duty and seeing patients dying in front of my eyes, and then I read this news. I was really angry. And some of our friends reported him to General Medical Council, and he got suspended. He can't practice. I think that was the right thing to do. Face masks. I think face masks is a very, very cheap intervention to limit the transmission of COVID-19 infection. As you all know, it is the fomite contact or aerosol. Aerosol part is the most important, and masks are the cheapest interventions to prevent it. In many East Asian countries, this is a norm. Even before COVID-19 pandemic, if you are having cold or flu-like illness, they will wear masks. Or in some countries, they will wear masks during winter season to prevent any spread of the viral infection. So among us all, we have to ask ourselves, then in future, even if we get a common cold, will we like to wear masks? I think we should. We should have a low threshold to wear the mask. And there are many variations in the mask. There are masks which are they are developing with self-cleaning, like you do the windscreen of the car, you just wash it. You can do that. There are photothermic masks. There are masks which you can press the button and make them warm or cold, whatever you like. So there are different varieties coming up, and I will advise you all to have a low threshold to wear masks, especially during winter season or you are having any cold. Vaccines saved millions of lives. Believe me, it saved millions of lives. This is a very, very recent data coming from USA. The purple dots are those patients who got vaccinated, and the blue one is the one which did not get vaccinated. And this is a modeling study from Commonwealth Organization, and they say that only in USA through vaccine they prevented about 3.5 million deaths and about 50 million hospitalization, and they say about the economy saved about $1 trillion just due to vaccination. I think we were lucky. Is there any vaccine for HIV? No, they have been trying to develop a vaccine for HIV, they have failed. But we were very lucky that the scientists worked very quickly and we managed to get vaccination. So vaccines have saved millions of lives. And this is a controversial subject. When a pandemic comes, this is a new disease, no one knows how to treat it. There are two approaches. One approach is, that is what we did in Pakistan. What did we do? We started giving them 10 medicines altogether. Hydroxychloroquine, ivermectin, azithromycin, etc. Throw everything on them, whether it works or not. In UK, our practice is very, very different. We recruited patients into this world's largest trial to cover it. I think this is the right approach. If you don't enroll patients in the clinical trials, how you will know that medicines work or not? You have given 10 medicines, which one worked? We don't know. So I remember that on 16th of June at about 12 noon, there was a press release, I was on call, there was a press release that dexamethasone works for COVID-19, and by 1 o'clock I prescribed this to the next patient. So that is how we work in UK. We don't prescribe medicine because one professor has said this works, no. And we really take pride as a UK nation and as our unit. I mean, there were 10,000 patients recruited into this recovery trial by May 2020 in whole UK, and our unit in Leicester, we contributed 1,000 patients alone. And there are many, this trial has shown you which medicines work, which don't work. So please try to practice evidence-based medicine and based on clinical trials if it comes to that. Otherwise you will not know. And recovery trial investigators believe that they have saved about 1 million lives through this clinical trial by telling the clinicians what works, what does not work. Mental health, we should not forget mental health really. Mental health is a big issue post-COVID. I will say this is a second pandemic. Okay. In this study from Lancet, there are 52 million patients with depression and about 76 million with anxiety disorder post-pandemic. And this is a big issue, and we should not brush it under the carpet. And healthcare workers have been affected as well. And I was very pleased. To see this poster, thanks to Dr. Mada Fatima and Dr. Nazish Imran for lending me this slide from poster presentation yesterday. So there is a study done here at Mayo Hospital, and a survey of the healthcare workers, including doctors, nurses, etc., and asking them about their moral injury score. It is up to about 41% said that they were affected by COVID pandemic, and about 14% very seriously. So I really congratulate to the Psychiatry Department of Mayo Hospital for conducting this a very good study. So please don't forget the mental health issues. I share one example with you. I was affected by mental health problems. I mean, especially when I was on the front line as a pulmonologist, looking after the patient. One evening, about 8:30, I was going home after doing about 13-hour shift, and I was in the car park, and one consultant friend, he called me, "Oh, Tufail, यार हमारे जो मस्जिद का जो मुअज्जिन है ना, वो एडमिट हो गया कोविड के साथ." That is May 2020 I am talking about. I went back. मैंने उसको देखा. I mean, typical 58-year-old gentleman from Hyderabad, India. Diabetes, hypertension, slightly obese. 10 लीटर ऑक्सीजन पे है, कोविड. मैंने उनको तसल्ली दी, बताया कि हम अब ट्रीटमेंट करेंगे, देखते हैं क्या बनता है, 50-50 चांस है. मैं अगले दिन आया तो they told me he has died overnight. He had massive hemoptysis and died. तो उसके बाद यूके में एक प्रोसेस है कि जब कोई डेथ हो जाती है तो फैमिली आपको रिक्वेस्ट कर सकती है मीटिंग विद द कंसल्टेंट टू नो फर्दर व्हाट हैपन. तो मैं गया नर्स के साथ और ख़ुद भी, और हम 3-4 लोग बैठे हुए हैं कमरे में. उसकी बेटी आई जो कि फार्मासिस्ट है, तो उसने कहा जी अल्लाह की मर्ज़ी, हमारे वालिद साहब फौत हो गए हैं, लेकिन आप डॉक्टर साहब ये बताएं कि मेरे जो वालिद साहब थे वो हर वक्त बावजू रहते थे. जब उनकी डेथ हुई है तो वो वज़ू में थे कि नहीं? We did not have any answer. Did you allow him to do wudu? I mean, I'm just telling you the extent of mental problems and all those things. And I mean, we did not have any answers for that. Telemedicine. It has become the new normal. You all know Zoom, MS Teams, etc. And thank you very much to the King Edward Medical University and the Vice Chancellor then, Professor Khalid Masood Gondal, and Professor Balkis Shabir and Professor Saira Afzal, Professor Somia Ikdari sitting there, to really allowing us and giving us this opportunity to do telemedicine, to do webinars, MDTs with you. We did for about 4 months, and I think you may have found it useful. So there are new things coming up, as you all know, through 5G we enabled telemedicine, so this is the future. And for all the healthcare workers, I think we should acknowledge their services. And this is an example of our Camcolian. He's a graduate of 1988, Dr. Tayyab Haider. He's a medical director in Basildon Hospital. So he was recognized, like many others, he was recognized by late Queen and awarded him MBE. And I think all the healthcare workers who have worked at the front line should be awarded. But I was really disheartened when I looked into the list. The civil awards in UK in 2021 list, all the civil awards, about 14% went to doctors and nurses. And in Pakistan, only 2% went to the civil awards. I think government should be more empathetic. People have worked very hard, but we don't work for awards. We work because anyone who has saved one life has saved a whole humanity. My last slide, I think, when we say that the pandemic is a once in a lifetime or never to be repeated, I don't agree with that. I don't think we should be ready to face another pandemic. I think this is totally wrong to say that is a once in a lifetime event. I think it may happen in our lives. It is not, but Allah has given us the opportunity to serve the humanity. This is not to say that I'm looking for another opportunity as a pulmonologist, but Allah has given us opportunity to serve the humanity, and we should keep ourselves prepared. Thank you very much for your time.
Dr. Tufail, you have to Now this house is open for questions. If there is any question, please let me know. Ra.
I have some comments and some questions.
Of course.
First of all, the thing that you mentioned about politicization of medicine, I think it's been there since ages. It's always been there. And it's not restricted to a single country. Fossey said something happened in UK, and the same was there. The point is that what did we learn from the pandemic? Another comment about evidence-based, the phrase that we use, evidence-based. So now when we try something, is that UK evidence-based? Because you just mentioned that you found it out and that's the way you do it in UK. So probably about Dexter, that's what I'd like to mention here, that we were using it before the study and it incidentally turned out to be. Another comment is that while we were dealing with the pandemic, we seem to forget, and this was not only in Pakistan, this was a case of ARDS, like any other ARDS, but of course there was this fear and enigma of a new disease, so we were not probably dealing it as we would deal a normal ARDS case. So I think the high mortality, you were very generous when you said that it's 80%, I would say it's more than 80%, and on that too we need to see that at what point did we put our patients on ventilators. So that also affects the mortality. So the preparedness for the pandemic, I think that's the important thing, that what did we learn from the pandemic that we faced. And the point that you raised about the need to build ICUs and people who are dedicated for critical care, I think that you can't say anything more.
Absolutely. I totally agree with you. And I mean, obviously you have been working with us for these MDTs, etc., but the figures are almost there that our mortality is high, what we can do. It is not any criticism by any means. It only means that we need to develop more fellowships in ITU, we need to strengthen you to develop this important specialty in this country. It's also at government level, they have to provide more resources. This is not a specialty which you can develop just without resources. Nursing, trained nursing staff, it is very important. When it comes to evidence-based medicine question, really, it is a very controversial thing. UK, I give you two examples. One was they wanted to know the exact date of steroid. Let's say we know already that steroids work in this condition, but they say we wanted to know what dose, for example. And in recovery trial, you know that they prove that if you are not on oxygen and you are given steroids, it is more harmful to you as well. So they ended up in refining the data, refining the evidence. And the second thing, I give you the example of vaccine program in UK. I think their vaccine program was very successful. I remember that when Pfizer vaccine came, the recommendation was that you give first dose and after 28 days give the second dose. So when we got the vaccine, the UK government took a totally different action. They said no, your second dose will not be after 20 days, will be after 3 months. So that we can give one dose with limited supply to more people. And that they were talking about based on some previous evidence from flu jabs and everything. And I think, and they proved that they were right. So there are some things which you can extrapolate from the previous evidence into it. But when it comes to new treatments like hydroxy, name me any medicine they have not used for Oh, absolutely. I mean, initially, as you know, we were intubating a patient. That was a wrong approach as well. This was a new disease, and we did not know what to do. We made mistakes, yes, but we know more now. Thank you.
Thank you for a very nice talk. I have two comments. One, we found out that we were not prepared. I'm not sure that, although in the US there was a whole pandemic preparedness cell, that every year and year they would spend funds, and even then we were not prepared. So there are a lot of moving parts to this. Secondly, we have to counter misinformation.
Absolutely.
their networks are much highly connected compared to information networks. And the third thing is we need to understand that science is iterative. What we know today may not be true tomorrow. We need to get the message out as fast as we can in good faith. And people need to understand that that's not etched in stone, it may change. And the second comment I have is about the vaccine. 40 years have passed. The reason we don't have a vaccine for HIV is that no one, not a single person who has seroconverted has spontaneously cured himself or herself for HIV. It's the nature of the disease. It's an acquired genetic disorder. They are reservoirs. That's why we don't have a vaccine. Secondly, the reason we have a vaccine for COVID is because the template developed for HIV was quickly adapted. And that's how we have a vaccine for COVID today, because of research that went into HIV.
No, I totally agree with you. I think we have been lucky to have these templates and everything to develop these vaccine programs. Yeah.
There is another comment from Dr. Mubin Rathore.
Thank you very much. I didn't catch all of your talk, but it was what I thought was good. It was very good.
Thank you.
I think vaccine, as was suggested, there are data on vaccine that are available, and then there is a lot of misinformation. The use of vaccine in UK was a public health decision, not an individual decision because of the lack of vaccine.
Absolutely.
There are no data that suggest extending the vaccine 3 months is any better. There are extrapolations, hepatitis B is one path, the longer you wait. So I think that's the important point I was going to make on that is every country has to make their own plan. Is it better to get 1 dose of vaccine to everybody or to get 2 doses, as many people as possible, what it matters? Each situation and pandemic is very different. So again, I'll come back to the same thing. We need to develop local guidelines based on the information, guidelines that are going to be most beneficial.
Absolutely, I totally agree. I think they went okay. They made many mistakes in UK, but on this strategy, I think they were proven right. Thank you.
Thank you very much, Dr. Tufail. And again, a very interesting topic, COVID-19, and it is the best example of international collaboration. And in Pakistan, as per data, I think again a case study because we were the part of solidarity trial of WHO as well as we worked in NCOC and Corona Expert Advisory Group. And yes, our data was there and it was much valid, and our mortality data especially, it is reliable data. So it is a beautiful example how the international collaboration has been done, especially for trials, vaccination trials and different trials. Now our next speaker is Professor Dr. Aisha Malik. She is the Dean of Surgery, Professor of Gynecology in Lady Wellington Hospital. Her topic is Well Women Clinic Initiative, Model for Screening of CA Breast and CA Cervix in Low Resource Settings. Professor Aisha Malik.
Bismillahirrahmanirrahim. I'm grateful for this opportunity to speak in this gathering. I think that this is a wonderful tradition of King Edward that we gather each year with our Campolians from US and UK and all over the world really for sharing of knowledge and exchange of ideas, and we always walk away motivated, energized and with very good thoughts about how to progress in which direction. So on behalf of the Gynae department, I'm going to give this presentation about something which we have been doing in the last 1.5 years. Professor Mahmood Ayaz, the respected Vice Chancellor, Professor Ijaz, Pro-Vice Chancellor, Dr. Asif, Chair Kamgana, Dr. Saira, who is the scientific chairperson, Professor Rathore, Dr. Tabinda, Professor Abrar, and my very dear class fellow, Dr. Umi Abbas. Dr. Umi is now specializing in infectious diseases, لیکن یہ میرے ساتھ تھی اسکول سے. تو آپ سمجھیں کہ ہم KG کلاس سے اکٹھے تھے, کنیڈ میں اکٹھے تھے, اور پھر کنگ ایڈورڈ میں اکٹھے تھے, ٹل سچ ٹائم کہ امی لیفٹ فار US. بٹ ناؤ شی کیپس ٹائز, اینڈ آئی ہوپ کہ ہم آگے کوئی کولیبریٹو ریسرچ کر سکیں. سو دس آئی وانٹیڈ ٹو سے کہ ہم ہر وقت میٹرنل مورٹیلٹی اور آپ لوگوں کو ایک سیڈ اسٹوری سناتے ہیں. سو آئی وانٹیڈ ٹو ٹاک اباؤٹ اے سکسیس اسٹوری, اینڈ آئی ول اکنالج کہ یہ میری ایفرٹ نہیں تھی. دس واز دی ایفرٹ آف دی انٹائر گائنی ڈپارٹمنٹ جو یہاں پہ بیٹھے ہوئے ہیں. پروفیسر کرن خورشید مجھے نظر آ رہی ہیں, پروفیسر عظمیٰ حسین, پروفیسر مہرالنساء, مائی اسسٹنٹ پروفیسرز پرٹیکولرلی ڈاکٹر نومیا, ڈاکٹر زوبیہ, ڈاکٹر سمیرا, مائی ایسوسیٹ سعدیہ and Anika and all the others who are not sitting here also. So we were actually looking to prevent or for early diagnosis of two common cancer killers, CA breast and CA cervix. And CA breast to خیر ساری دنیا میں it is the commonest malignancy in women worldwide. اور پاکستان میں بھی the statistics show that 1 in 5 females are being diagnosed. ہمارا رجسٹری سسٹم پور ہے. سو دیر واز اے کولیبریشن بٹوین دا پرائمری سیکنڈری. ایز یو نو دا ہیلتھ سسٹم ان پاکستان از ناؤ sort of divided into primary secondary, which is taking care of the periphery, and specialized health care. So luckily there was a collaboration. Both health departments agreed on this کہ prevention پہ کام کیا جائے, and that there should be a training of the health care providers from different districts of Punjab. And we worked for 1.5 years, and we had healthcare providers, which means LHVs, nurses, paramedical staff and doctors from 36 districts of Punjab. And they were all here. They came for 1 week. They rotated between Lady Wellington and New Hospital, and they were trained to screen patients in a low resource setting to pick up early features of cervical malignancy and a breast lump. So improved preventive care, we know, would lead to early diagnosis and would help to prevent morbidity and mortality from these two most common malignancies. Breast clinic is in Mayo Hospital. آپ کو چانس ملے تو ضرور وزٹ کریں. اٹس ون آف اٹس کائنڈ. اور breast surgery کی جو سب اسپیشلٹی ہے, that has also been started for the first time in Mayo Hospital under the dynamic leadership of our Vice Chancellor. And we have trained many breast surgeons. So it's a walk-in clinic. At least عورتوں کو پتہ ہے کہ وہ اگر انہیں breast سے related کوئی بھی problem ہے تو وہ یہاں آؤٹ ڈور میں ایک کمرے میں آئیں گی. اینڈ اٹس اے پریٹی گڈ کلینک. وہاں پہ ان کی ایگزامینیشن, میموگرافی اور الٹرا ساؤنڈ اف انڈیکیٹڈ, اینڈ انڈر ون روف اگر سرجری ہونی ہے, بریسٹ کی لمپ ریموو ہونا ہے, اینڈ ریڈیو تھراپی, کیمو تھراپی, ایوری تھنگ از اویلیبل. اینڈ آئی تھنک اٹ از اے بگ سکسیس آن پارٹ آف کنگ ایڈورڈ. بٹ مائی مین ٹاپک از سروائکل کینسر, جس کے لیے ہم نے ٹرین کیا ہے فار اسکریننگ. It is not all over the world, but in Southeast Asia and particularly in Pakistan. I hope جو students پیچھے بیٹھے ہیں جو کل مجھے کہہ رہے تھے کہ میڈم ہم سو گئے تھے. Are you listening? ہم students are awake? Yes, okay. تو آپ کو پتہ ہے کہ جو ساؤتھ ایسٹ ایشیا ہے یہاں پہ سروائکل کینسر سیکنڈ موسٹ کامنسٹ malignancy ہے. I think امی کو پتہ ہوگا کہ US میں that is not so. Am I right, امی؟ سو ہمارے یہاں کیوں یہ سیکنڈ موسٹ کامنسٹ ہے؟ اور اس سے زیادہ الارمنگ کاز یہ ہے کہ اگر یہ ہے بھی سیکنڈ کامنسٹ تو اٹ از دا تھرڈ لیڈنگ کاز آف کینسر ڈیتھس ان ویمن. اس کا مطلب ہے کہ اگر کوئی خاتون ڈائگنوز ہوتی ہے سروائکل کینسر سے تو ان میں سے 2/3 جو ہیں دے ول ڈائی. حالانکہ میں نے کہا وہاں 1/2 to 2/3 اینڈ آئی ٹیل یو دا اسٹیٹسٹکس. جبکہ آئی ہیو ورکڈ ان UK فار 2 years. وہاں پہ کینسر اسکریننگ سسٹم اتنا اچھا تھا کہ آئی نیور سو اینی وومن وتھ CA cervix. They were all picked up in the CIN1 cervical intraepithelial neoplasia stage. ان کو ٹریٹ کر دیتے تھے with laser or with cryotherapy, and they did not progress. They were kept in regular follow-up. اب پاکستان میں ہماری جو پاپولیشن ہے وچ از ایٹ رسک از 49.25 ملین ویمن who are aged 15 years and above. اور کرنٹ جو ایسٹیمیٹس ہیں جو میں نے فگرس دیکھے ہیں کہ nearly 12,000 women are diagnosed with CS cervix. These are the ones جو ڈائگنوز ہو رہی ہیں. جو ڈائگنوز نہیں ہو رہی وہ اس سے بھی زیادہ ہو سکتی ہیں. اور اگر 11,600 میں سے 7,000 mortality ہے تو that is unacceptably high. And that is because of the late presentation. یہ اوور آل mortality figures ہیں پاکستان کے ڈیو ٹو کینسر. And as you can see, CS breast is the commonest. لیکن CA breast میں بھی mortality اتنی ہائی نہیں ہے comparatively. If you see the overall disease and the mortality, because it's picked up early. CA cervix میں ہمیں کیا پرابلم ہو رہی ہے کہ پک اپ لیٹ ہو رہا ہے. سو جو پیشنٹس ہیں ان میں سے میجورٹی آر گوئنگ ٹو بی ناٹ کیورڈ. اس سے زیادہ افسوس کی بات ہے کہ زیادہ تر کینسرز میں وی ڈونٹ نو کہ کاز کیا ہے نا. ہم کہتے ہیں کہ جی کوئی انوائرمنٹل فیکٹر ہے, کوئی جینیٹک فیکٹر ہے, اور ہمیں نہیں پتہ کسی کو کینسر کیوں ہوتا ہے. CA cervix is the only one جس میں ہمیں پتہ ہے کہ the causative agent is human papilloma virus, that it is sexually transmitted. اور جب میں کالج میں بھی تھی میڈیکل اسکول میں تو ہمیں پتہ ہوتا تھا کہ جی ننس کو کبھی نہیں ہوتا اور prostitutes میں it is common because of multiple sexual partners, the risk of transmission of, so it's actually a sexually transmitted disease. And the virus will obviously attach to the cervical epithelial cells, and then it will depend on the host immune response. ٹھیک ہے, اگر آپ کی صحت اچھی ہے, آپ اس کا مقابلہ کر لیتے ہیں, آپ اس کینسر سیل کو آپ کی باڈی کل کر دیتی ہے, کلر سیلز, یو وڈ بی سیوڈ. لیکن ہماری پاپولیشن انڈر نرشڈ ہے, انیمک ہے, ان کی امیونٹی اچھی نہیں ہے, اینڈ a lot of them succumb to it and it will progress to invasive cancer. So this is the visualization جو ہم نے پروگرام ڈیوائز کیا کہ اگر سروکس کو آپ ویژولائز کر سکتے ہیں بائی پٹنگ ان اے اسپیکولم. ٹھیک ہے, ایون دا فائنل ایئر اسٹوڈنٹس کین سی دا سروکس. دا نارمل سروکس از دا ون جو بالکل پنک ہیلدی آپ کے لیفٹ ہینڈ سائڈ پہ ہے. اینڈ وین یو اپلائی ایسیٹک ایسڈ وچ از ایزیلی اویلیبل, سمپل سرکہ اس کی ڈائلیوشن بنا کے, تو ایسیٹو وائٹ چینجز ول بی سین. تو آپ کو نظر آئے گا. اینڈ دا فرسٹ از CIN1 ہیومن پیپیلوما وائرس. تو جتنا وہ ایسیٹو وائٹ چینج کوئکلی اپیئر ہو, جتنا شارپلی ڈیمارکیٹڈ ہو, آپ کو نیکڈ آئی سے نظر آ رہا ہے, اور جتنا کلوز ہو ٹو دا جنکشن ٹرانسفارمیشن زون, اس کا مطلب ہے کہ اٹ از مور لائکلی ٹو پروگریس ٹو سروائکل کینسر. آل سیکچولی ایکٹیو ویمن آر ایٹ رسک. اور obviously lower socio-economic group, immunosuppressed, جیسے میں نے کہا, early age at marriage, and prevention of this infections کیونکہ نہیں ہے. So we will be looking at this کہ یہ ہمارے, اب ہم کنونشنلی اسکریننگ کیا کرتے تھے, ہم پیپس میں لیتے تھے. سروائکل کینسر کی ویکسین بھی اویلیبل ہے, لیکن ہم نے گورنمنٹ لیول پہ کوئی انیشیٹو نہیں لیا کہ ہم لوگوں کو دے سکیں. اور ایک ٹپیکل ریزسٹنس جو ویکسینیشن کی ہوتی ہے کہ اس سے فرٹیلیٹی کمپرومائز ہو جائے گی, مے بی یہ پرومسکس بیہیویئر جن کا ہے صرف ان کو لگنی چاہیے. سو اے لاٹ آف مسکنسیپشنس وچ از وائی دس ویکسین ڈڈ ناٹ بیکم سکسیزفل. جو اسکریننگ کی جو ورلڈ وائڈ ریکمنڈیشن ہے, دیٹ از دیٹ اف دا اسمیئر از نارمل, 3 ایئرلی اسکریننگ ہونی چاہیے ان ایج گروپ 25 to 49, اور 50 کے بعد 5 ایئرلی ٹل دی ایج آف 64. یہ ہم سمپل سے انسٹرومنٹس ہیں. ایک پلاسٹک کا اسپیچولا ہے وچ از کالڈ آئر اسپیچولا. اس سے آپ سروکس کو جو آپ کو نظر آ رہی ہے, آپ نے اس میں اس کو ڈال کے 360 ڈگریز پہ روٹیٹ کرتے ہیں. اس پہ سرفیس ایپیتھیلیم کے سیلز آ جائیں گے وچ کین بی سین آن دا سلائڈ, اور یو کین یوز اے سروائکل بیسڈ لیکوڈ بیسڈ سائٹولوجی. لیکن یہ چیزیں ہماری پیریفری میں کام نہیں کرتی, کیونکہ جو ہم سلائڈ بنا کے پیشنٹ کو دیتے ہیں وہ توڑ دیتی ہیں, گرا دیتی ہیں, گھما دیتی ہیں, اینڈ وی ڈو ناٹ گیٹ دا سائٹولوجی رپورٹ. سو وی تھاٹ وی ٹرین دیز پیپل. اگر کولپوسکوپ ہو, دیز ور کولپوسکوپک سیشنز ویئر وی ور ٹریننگ دیم, And we are now, Unit 1 is the referral center कि कहीं भी जहाँ हमने अपने लोगों को ट्रेन करके भेजा है, if they see any abnormality in the cervix, they can refer the patient to us and we are managing these patients. But the way forward, we are coming to the last two slides, that we need dedicated state-of-the-art operating rooms. We need a dedicated trained team for surgery, a well-equipped ICU, liaison with radiology, pathology, oncology department. And we want to make this hospital a model for other healthcare centers. And our objectives of training were that in a low resource setting, visual inspection of the cervix after application of acetic acid, which our trainees will be able to appreciate the acetovite areas, take sample for histopathology from the suspicious area if indicated, and would be able to treat or refer. So this is our take-home message. Improving women health matters to women, to their families, to communities, and to societies at large. So improve women's health, improve the world. Thank you very much.
Now, Madam, you have to stay for question answers. Now. Now this house is open for question and answers. Any question? Okay, thank you very much, Madam. Now I would like to request Dr. Muhammad Aslam. He is the president, former president of Camcana, to please come on the stage and have this sir. Professor Muhammad Aslam. Our next speech is from the President Camcana, Dr. Muhammad Fateh Shehzad. He is the hospitalist in Danville, Kentucky, US. His topic is career counseling, how to successfully get into residency and interactive session with the medical students.
नहीं रेजिडेंस तो बाद में जी। अस्सलाम वालेकुम। This discussion topic is more like a guidance than an educational speech. तो प्लीज़ अटेंशन लें, यंग फिजिशियंस और स्टूडेंट्स के लिए ज़्यादा ये टॉपिक है। As I said last night, Camcana is extension of King Edward Medical University in USA and Canada, and we would love to have more Camcolian join us in USA and Canada. I will briefly describe that how Camcana can and does help young physicians and students to get rotations, electives, observerships, as well as guide during the matching process and in visa guidance. Students can get rotations in VSLO programs. Camcana is and KEMU is a part of the SLO program, and we do pay annual fee on behalf of KEMU. Postgraduate and young physicians can get observerships through Camcana and Apna Facebook page, as well as contacting Apna and Camcana Executive Committee. I will talk a little bit about visas which are required for rotations as well as for observership. For students who go for rotation and step 3, they require B1 visa, which is easier to get for students as compared to doctors. For residency and fellowship, J1 and H1, J1 is sponsored by ECFNG and H1 is sponsored by the program. Usually there is no refusal for J1 and H1. There is sometimes administrative processing that may take longer time. Before the match, we do get some statistics. This year we were contacted by around 800 applicants who are going to apply this year. Fortunately, King Edward Medical University students are at the top. There were 92 applicants this year. Last year, 51 did match, which was against the highest number among all universities and medical colleges in Pakistan. You can see the graph. The King Edward is number 1, then is Dow, Sindh Medical College. Aga Khan students have not contacted as many students, so their number might not be accurate. Next slide. Another positive thing we have noted as the number of students have increased in medical schools, universities, and the male-female ratio is totally different than what it used to be. In my class, we were 240 male students and only 20 female students. Now ratio is different. So this year, the match, 288 were male applicants and 201 were female applicants. 291 are male, 288 female. Last year in the match, there were 329 total matched residents from Pakistan and 109 were females. Next. Now, year of graduation does matter in the matching process, so I will suggest that you should apply earlier. Of course, you have to pass your step 1, step 2, and in some cases step 3. If you look at the maximum number of applicants in this slide is from 2018, then 2019, 2020, 2021, and some are from 2022. So 3 to 4 years is a good window period, but some program will not consider your application for their review if your graduation year is beyond 5 years. I will take some questions from students and young graduates, and I will suggest that please do ask questions instead of sending Facebook messages and direct messages on WhatsApp asking questions. You have time to ask questions so everybody else can understand. Any question about observership, rotations, visas?
Can I make a comment?
Yes.
I think it's extremely important that for the United States, everybody understands USMLE is key. If you want rotation as students, you must have your USMLE Part 1 done. Medical schools US medical schools, we don't even allow our own students to get into clinical rotations, which they have, until they have done their USMLE Part 1, which they can do after their second year of medical school. So that's key. I get requests often from friends that the kids want to do rotations and they have not done USMLE Part 1. That's a non-starter. That's number 1. As Fateh said, it's easier to get rotations if you're a medical student as opposed to a doctor. Did you have a question? If somebody has a question, please raise your hand and ask the question first. I was just filling in time. Second thing is, when you do rotations there is a value-based rotations. If you do your clinical rotation at a university, that's the most high value. If it's not a university, and you do it in a residency program, that's also high value. Now, I'll tell you, if you do a rotation in a doctor's office, that is valuable. But the people who are evaluating your application, they are not stupid. They know, not from Pakistan, from India, from Nepal, that you all know doctors there. So you can show up in a doctor's office. That means you may see some patients, you may understand some things, but that's not a real observership. So I'm not saying don't do that, but sometimes that's the only choice. A couple of other things. Many universities, including mine, does not anymore allow any observership. People, for doctors or students, if you are interested in doing a rotation and you're a medical student, you have to apply through the university. We do have offer international rotations, but you have to pay for them, and then they can be quite expensive. So you need to get all that information ahead of time. The other important thing is plan now. If you are in final year and you're starting your planning to do some residency in the United States, I hate to say that, but you're late. You should be starting in your second year planning if that's what you want to do. Now also, 5 years, as Fateh said, if you have graduated more than 5 years, now it's all electronic. The system will not even select your application. The second thing is your USMLE scores. In our own program, until a few years ago, the cutoff was 220. Now the cutoff is 240. And we have students from Pakistan, doctors from Pakistan, who have scores of 260. I don't know how they get that. I'm sure I can't get those. But they have very high scores. So that's another thing. So there's a balance of doing your USMLEs earlier and doing them well. Do them when you're ready. A failed attempt is a huge negative. A failed attempt in USMLE is a huge negative. So be careful about that also. I'm just going on.
I would like to add what Dr. Rathore was saying about the rotations for students, because most of you will require a visa, which is going to be a visit visa, B1, B2. Nowadays, the person who is going to interview you, if he or she finds out you are going to go do rotation in a clinic which is not attached with the residency program, university, they will refuse your visa. So make sure that if you do rotation as a student, it should be university-based or residency-based program, not in a clinic. Observership is different. You can do in clinics, but student rotations, internship, clerkship should be in a residency program or university program.
So I have a few comments. So things are becoming extremely competitive because there's a very large pool of applicants who want to get into these residencies. So things that students don't realize, observerships do not count. So you should try to get a hands-on elective while you're a student. So just coming, showing up somewhere and just observing really is not very helpful. Number two, try to have some sort of research participation. Here, when I was a student, there was not much emphasis on authorship, research. These things count. Particularly, students should be encouraged to be a first author or an abstract, present at the scientific meeting. Those things need to be on the CV. 3, KEMU can have institutional affiliations because a lot of times academic institutions allow student electives if they have institutional affiliation, but it's becoming very, very difficult for international students to secure electives unless their institution does not have an affiliation. So those were some of my comments. And again, yes, we can put in a word, but a lot of times there are automatic filters that screen you out. If your scores are not up to the mark or you're not particularly hands-on elective, a lot of programs don't even look at your CV if you don't have hands-on electives on your CV. So that's very, very important. And try to get into research and
Thank you.
publish.
Thank you very much, Dr. Fateh Shehzad, and he is available. If anybody has any question and want to ask face to face, they can ask. You can come here. Yeah. You can make the comment first.
While our student or graduate is coming for a question, I can get put on a Kankana, go on the Kankana website, kankana.org. We have a visiting student program. We have affiliation with the university where you can have some rotation or I should not say observership or something like that. So please know that, and I agree with Dr. Rathore and Dr. Umar what they said. I think rather than go on rotation, I think I would emphasize on research because that way you spend some little bit more time rather than doing 2-week rotation or 1-month rotation, and you don't really develop any connection or relation with the program or the people. You are there, and once you are there, out of there, you are out of seen, out of mind kind of thing. But if you do research, like Dr. Umar was saying, I think you are there for some period of time, and you will connect with some of the researchers, and that is considered very prestigious in case you have the first authorship, like she was saying. So these are my comments.
Assalamu alaikum everyone. I'm a fourth year student here. The question I had was that you repeatedly mentioned how it's important, how electives are more valuable than observerships, and it's ideal to do it during your 5 years of MBBS. The point I wanted to raise and the question I had was that you're all familiar with the format of the MBBS program. So what would be an ideal time period, because we don't really get any breaks during which we could go for electives during the academic year. So that is one point I wanted to raise, because I'm aware that there are other universities that provide a certain time period during the medical degree for this opportunity. Thank you.
So don't go with. No American medical schools provide time, to the best of my knowledge, for preparation for USMLE. Caribbean schools do. There are some schools in Caribbean who also will be international like that. They do provide, but they also have a very sort of different structure. You can do your degree in 5 years even, so they do provide you time. I'll tell you that most of us, we did at my time it was FN Gens. I did it in 4th year. The best time to do your USMLE Part 1, in my opinion, is before your preclinical, after you've done your anatomy. That's the best time, because otherwise you forget now. You have to prepare all along. You can't, you can talk to your vice chancellor, your faculty, and maybe they can provide some couple of weeks or so. I don't know what the structure is now, but those things can be done. So I wouldn't say that you don't do that. The observership, this is a hierarchical model, okay? What is best? Best would be you work in a university program as a student elective, you work in a research program in a university. I did 1 year of research fellowship at the University of Cincinnati at Children's Hospital before I got my residency. And as Aslam said, you get to know. So I got a letter of recommendation from the chairman of the Department of Pediatrics. That was very helpful. I'm old enough that I'll tell you, my FNGEM score was 76. 75 was pass percentage. I was in 4th year. I could not have gotten a residency unless I had that. So I think you did research. So if you work in that, you come to know these people. They will write you strong letters. They know how to write letters. So don't worry about it. If you can't get that, get the next best thing. The United States experience is valuable. It's just the hierarchy.
I would like to add one more thing, that nowadays, of course, you all will need visa, so it's very important that when you apply for visa, these days the waiting period for B1, B2 is 16 months. So if you're planning to go in 2023 or 2024, you should apply for visa accordingly, waiting time, which is, as I said, 16 months. It can vary from 12 months to 18 months. So it's very important that you apply on time. I get a lot of messages and calls that my rotation is next month and my appointment is in 2023, which is very difficult for us to make it earlier. As US Embassy and Consulate, they do consider, but they just simply will say that we don't have enough staff. So apply in time. Another comments I want to make about this accreditation of PMC with WFME, which is going to be important by end of 2023. If PMC, PMDC is not accredited, recognized by WFME, then no student, no graduate of Pakistan will be able to be certified by ECFMG, which is going to be very negative. So the best thing for you all, what you can do is, if you are registered before 2023, like a third-year student can register with ECFMG, even if you don't write exam in next year, or you don't pass exam, you will qualify, you will be eligible for certification with ECFMG. So at least get registered third-year, fourth-year final students before 2023 is over. Thank you.
Thank you very much. Our next speaker is Dr. Mohammad Shafiq Gill. He is consultant histopathologist and assistant medical director, Sherwood Forest NHS Trust, United Kingdom, and executive member of KEMCA UK. His topic is multidisciplinary approach to cancer management, the United Kingdom experience.
Assalamu alaikum and good morning. I think you have been listening to so many interesting and very exciting talks since mornings, and one issue with attending these seminars is sometimes there is so much data to absorb, so I would try my best to protect you from data toxicity today. It's always a privilege to come back to King Edward Medical College because I have very fond memories of this place. It was my formative years here, so I always look forward to this opportunity to come here and have sort of have interaction with people. Coming to my topics, basically I know we're just sort of a little bit recovering from COVID now, so we can start looking at the diseases we used to deal with before COVID. And cancer has always been one of the major diseases we have to deal with. And globally, there is a huge cancer burden. Approximately 1 in 3 people get cancer, 1 in 4 will die. So I think hopefully that's the only data bit I'm going to talk about. And cancer can affect multiple organs, so it involves multiple specialties, and that creates its own challenge. When we look at across the globe, every country has their own way of dealing with cancer. And it's not only the healthcare organizers, it's sometimes the people, the physicians, the surgeons who treat it, because they move between a curative mindset to a palliative mindset, and we see both extremes of the paradigm. In terms of when we talk individuals, obviously the moment someone is told they have a malignancy, it can have huge psychological impact, and then it can have all the other impacts in terms of going through that rigmarole of the extensive diagnosis, treatment, and then life beyond or after cancer as well. It becomes a major challenge. And when you talk to patients, every patient has their own story to tell, because everyone goes through a very unique journey when they go through the cancer survival process. And I'm sure Pakistan is facing the same, but in UK, we are, because as people are living longer, and our pathology database goes back to 1988, and what we are experiencing sometimes is we are now diagnosing people with their 3rd or 4th cancer. So they get a cancer, they get treated, after 5 years they get another one in a different organ, and then the story goes on. So it's people are up to 4th cancer now. And then, so it's becoming just part of normal life, basically. I moved to UK in 2002, and the UK Health Service was going through a very fascinating or a major transition period at that time. Because in around 1995, there was a major European study published which showed that when you compare with the rest of the Europe, the survival rates for cancer in UK were relatively low. And please keep in mind, when I say low, UK was still one of the reasonably best developed healthcare systems. So they were not very low, but they were comparatively low. And they were concerned, they wanted to see what could be the possible reasons for that, and what can they do to improve the cancer survival rates. So when they did an initial sort of horizon scanning type study, they realized the quality of care provided by various hospitals, there was significant variation within that. And so basically, the government looked at ways to how we can improve the quality of care, then which could ultimately lead to improvement in survival rates. And they set up a commission, just like the way governments usually do, Coleman-Hine reforms, we call it, or Coleman-Hine report. They were basically 2 chief medical officers, one from England, one from Wales. They did it like a deep dive. They looked at what would be the possible reasons, and they came up with recommendations, basically, which as like a policy document for the government, that if you want to improve the survival rate, we recommend you should take these steps. And one of the key bit was, which I think government came up with, the key sort of priority was that all patients should have access to a uniformly high quality of care. Now that, for a government, for a political government, that is a very innocent and basic type of statement, but that's what all governments would like to say, that we want to provide the best of the best care. But when we start looking at downstream, how easy it is to implement, and that's the bit I want to talk about, and there are some parallels we can use in Pakistan, so I think that's the bit I'll focus on that. So the other basic commitment was that basically the cancer care should move from generalists to specialist providers, whether it's the hospitals, centers, or the clinicians. So that was the other way. But then there was a lot of detail to fill those requirements. So then in 1997, another document was brought in which then provided those logistical sort of details that how that specialized or specialist type of care should be delivered. And one of the key requirements was that this should be what we call a joined up or multidisciplinary care. Now, I think that the doctors are similar world over. They're very, I would say, intelligent people, very hardworking and very competitive people. And generally team working and working as a clinician do not normally go hand in hand. So people are very good doctors, but when you put them into teams, the challenges sometimes are much more evident there. So the basic proposal was that for every roughly a minimum of 1 million population, you set up cancer centers. And the cancer centers should have like specialist surgical teams with reconstructive or plastic teams as well. There should be appropriate facilities for chemotherapy, for radiation. And the bit I highlighted, because that sometimes, and that's from my background as well, diagnostics is the key if you want to set up a world-class or very good, excellent cancer services. And even if you talk in Pakistan, you can talk of Aga Khan Hospital, you can talk of Shaukat Khanam, some other, maybe Shifa International, you would realize the backbone is the diagnostics, which helps you deliver high-class cancer services. And palliative care and rehabilitation are other key areas. So the basic organizational arrangement was that every organization should have a lead cancer clinician who should then provide the oversight in delivering all the cancer services. And I had the privilege of being the lead cancer clinician for my hospital for about 2 years. And this cancer center led by that lead clinician, then they set up training the workforce, whether it's medical workforce, and making sure there are right systems of ongoing development for the medical staff. And then there are appropriate audit processes in place to ensure that whatever training we are providing, it is making a difference. So at the same time, and there was some high-level studies coming which provided the evidence for this Coleman-Hine report. Basically, those studies were highlighting that to provide a robust cancer service, you need to have high workload, you need to have specialist-type doctors who can then ensure better outcomes. Because in some centers, there were some surgeons who were maybe doing surgery only 3 to 4 times a year. Similarly, there were some pathologists who were only diagnosing maybe 5 or 6 cancers in a year. And that was the reason or the underlying basis for the lot of variation we were seeing in the country. So the report was accepted widely because that made sense. But there was something unusual about these reports, because historically, the tradition or the culture has been every time something is not working, you throw in a bit more money, you bring in some more technology. And my management guru, Dr. Andy Haynes at UK, he always used to say, if you automate a poor system, it just becomes an automated poor system. It does not simply improve. So you have to look at the elements to improve that system rather than just automating it. So I think this bit was unusual because this demanded the workforce to change, the working arrangements to change, rather than adding the technology bits there. So the basic concept of the MDT was it brings all those key experts together, but then the crux of the working arrangement was that they work independently. They work together, but they freely provide their own opinions. And as the MDTs were evolving in the UK, we saw that challenge many times. Sometimes a surgeon would dominate, sometimes an oncologist would dominate, and even a radiologist or pathologist. So it took time for those individuals to understand that we are working towards a common goal for a patient, and we freely provide our independent opinion but for a common purpose. And then the assessment system was not like some other body, but it was what we call peer review. So one hospital would go into the other hospital and check their systems and provide the assurance that are you working well, or are there areas you need to improve. So the core membership of the MDT was, obviously it varied for different MDTs, but it should have surgeons, clinical oncologists, medical oncologists, radiologists, pathologists, and cancer nurse specialists. And again, I would put emphasis on the cancer nurse specialist, because that has been a huge contribution to the cancer care process. There is the nurse specialist, but they are the key people. The patient will only see a doctor for a while, for a surgeon or even some others, but from the start to the end, a patient would stay in touch with their what we call a nominated key worker or a designated nurse. They would look after the patient, and that provided the continuity of care. And then based on the specialism, you could then have the extended membership of the MDT. At roughly the same time, early 2000, the National Health Service was also going through many other challenges. So yes, it was a priority, but then it was, the implementation was sort of hit and miss because there were so many other challenges going on in the NHS. So although it started in 1998, but when there were early data coming about 2006 and 7, there was a realization that although the teams were formed, but the teams were, and there was a concept that the patient should be at the center of the team and everyone should be working toward the patient. But sometimes the feeling which came, and I was part of some peer review process, that yes, the patient was in the center, but more like the football. So they were still being kicked around from one specialty to the other. I think as Dr. Aisha mentioned, sometimes it was again the patients had to sort out their own scans, sort out their own appointments. So it wasn't a fully joined up care. And although when we talk to the teams, they will tell you success stories, but then when you talk to the patients, they were just missing in that the celebrations of the teams because they were nowhere to be seen. So roughly around the same time, there was a lot of evidence coming from in terms of the tumor biology, learning that cancers are quite complex diseases, and it's not that easy for an individual to look after all the aspects of cancer. So that helped in terms of improving the teamwork, because the treatment for the cancer became complex. Like just giving you one example, in the UK we moved from mastectomy to breast conserving surgery. So for that you need the tumor to be properly localized, you need a radiologist, you need the pathologist to tell you exactly if the tumor has been completely excised or not. So that automatically generated the need for working together, and that really helped in improving that process. I'll just skip this slide. So the challenge was, is this working? Because there was a lot of investment, time and energy going into that. So the outcome was measured by two criteria, survival and the quality of life. And that was the real test, that is it really making a difference? So when we look back now at the data from the UK, there is robust evidence coming that the MDTs are making a difference. The cancer care is improving, patients are having a better experience, the quality of life is improving. And when we look at, I'm just using one example from breast cancer, although the blue line shows the incidence is increasing, we are diagnosing more cancers, but the mortality is going significantly low. And that is like a proof that this process is working. Obviously, it's coupled with other technological advances like the better nursing care, better surgical procedures. So it's all put together, but this is one of the key elements which is making a difference. So it's not like an end itself, it's just one of the elements which helps provide better care, but to develop that system, you need to have standards which obviously have to be nationally developed, and to support teams in developing and then measure progress and then measure the impact of those changes. That's how we can demonstrate that we are making progress, and more patients are getting a better experience and are surviving longer with cancer. So the story is changing from it being a death sentence to it's no more a death sentence, it's a curable disease if patients are handled appropriately as a joined up multidisciplinary care, and that is what makes a difference, because every society has its own stigmas. I still remember 1993 or 4, I reported a bone marrow trephine. I was just one of the junior doctors with him, and the patient's relative came to get the report, and they just asked me a question, Dr. Sahab, report to bata de. And I just told her that it's a lymphoma, and she said, Dr. Sahab, TB to nahi hai na. TB nahi hai. She said, Allah ka shukar hai, TB nahi hai. Because the thinking was it's the TB which is the death sentence, not the cancer. I think now we are moving through the phase that it's probably the cancer which is the death sentence. But with appropriate care, probably that stigma can be improved, because that would help us in encouraging patients to come for screening, for early detection, which can make a huge difference. So I think I would end there. And as Dr. Tabinda Dugal mentioned, I always come here looking for that young man on the right lower hand side, see, because that's what brings happy memories of King Edward Medical College days here. Thank you.
Thank you very much. Now this house is open for questions. Our next speech is by, thank you very much. Right.
Thank you very much. Just an observation, maybe I missed something on the slide, but in the list of the members of MDT, I didn't see any mention of an list. It is for pain interventions.
sorry, I missed the bit. Could you say it again, please? So pain management.
That's part of MBT.
That's right. I think that's one of the very important things that Dr. Taban Tadukal, our chair, is always very strong advocate of that. I think pain management is a very crucial component of cancer care, and I think we probably need to, in our future programs, need to include that. But that is, they are a very essential part of the cancer management process, and we have like programs which help with that. So that yes, my apologies, that should have been highlighted as well.
Thank you very much, Dr. Shafiq Gill. Now our next speaker is our Mardi Vice Chancellor, Professor Mahmood Ayaz, and he would be talking about quality and safety improvement projects in residency programs.
बहुत शुक्रिया सायरा, थैंक यू वेरी मच. अस्सलाम वालेकुम. अस्सलाम वालेकुम. अच्छा, पहले तो ये मैं बहुत शुक्रगुजार हूँ फ़तेह शहजाद साहब का, असलम साहब का, शफीक साहब का, मुबीन राठौर साहब का, असलम साहब का, और उन्होंने बड़ा आपको वाज़ेह तौर पे बताया कि अगर आपने अमेरिका जाना है या वलायत जाना है तो आपको क्या करना पड़ेगा. हम में से कितने सारे लोग जो है ना अमेरिका जाना चाहते हैं? हाथ तो खड़े करें, ख्वाहिश का इजहार तो करें. अमेरिका बुला लेता है जो जाना चाहता है अमेरिका, कोई मसला नहीं है. अच्छा, और हम में से कितने सारे हैं जो कि वलायत जाना चाहते हैं? अच्छा चलो कोई बात नहीं, ठीक है, ख्वाहिश का इजहार तो है ना. देखिए, बहुत परेशान ना हो इस बारे में. थोड़ा सा लगता है इस तरह ही कि बड़ा मुश्किल है अमेरिका जाना, वलायत जाना. मैं थोड़ी सी आपको अपनी कहानी सुनाता हूँ. When I had my MBBS, I wanted to go to America. I wanted to become a surgeon, so I did my ECFMG. उस साइड पे ECFMG होता था, मैं किया, अमेरिका पहुंच गए. 8 महीने मैंने सारा अमेरिका देख लिया, सारा का सारा, लेकिन सर्जन बनना चाहता था तो रेजिडेंसी नहीं मिली. तो जब जेब में $3 उस ज़माने में जब वो टिकट होती थी, अगर आपको याद हो तो वर्कों वाली टिकट होती थी, तो वर्कों वाली टिकट में आखिरी टिकट रहेगी क्या मैंने जहाज़ पे बैठना है, तो मुझे मजबूरन वापस पाकिस्तान आना पड़ा, क्योंकि तलब यही थी कि बनना मैंने सर्जन. मैं और जगहों पर रेजिडेंसी मिलती थी, सर्जरी में नहीं थी मिलती. बहरहाल वापस आ गए, यहाँ पे FCPS किया. FCPS करने के बाद फिर वलायत चले गए, वहाँ से FRCs किया 2 जगहों से. उसके बाद वापस आए. फिर मैंने बताया ना कि अगर आपके अंदर तलब हो कि आपने जाना है अमेरिका तो चले जाते हैं. तो आई सिलेक्टेड फेलोशिप प्रोग्राम इन लैप्रोस्कोपिक सर्जरी, वेंट टू पोर्टलैंड ऑरेगन, वहाँ से अपना काम कर लिया. वहाँ से भेजा गया. मेरे ली स्वानस्टोन में मुझे मेरे टीचर थे, उन्होंने कहा कि अगर आपने लैप्रोस्कोपिक सर्जरी सीखनी है तो फ्रांस जाएँ. वहाँ से फ्रांस से ले गए. तो फिरते फिराते वापस पाकिस्तान आ गए, किंग एडवर्ड में दोबारा लग गए. तो मुश्किल नहीं है, सिर्फ तलब होनी चाहिए, नॉलेज होना चाहिए, इल्म होना चाहिए. क्योंकि आपको याद रखने की बात ज़रूरी है वो ये है कि पुराने ज़माने में ये कहा जाता है कि द लक विल फेवर द ब्रेव. नो, द लक विल फेवर द ट्रेन माइंड. जितना ज़्यादा आपका ट्रेन माइंड होगा, जितना ज़्यादा आपके पास नॉलेज होगा, स्किल होगा, लक आपको उतना ही फेवर करेगी. सो स्टार्टिंग विद दिस, डोंट गेट डिसअपॉइंटेड. मुश्किल होता जा रहा है दिन ब दिन, लेकिन जिसकी तलब होगी, जिसमें जज्बा होगा, जिसके अंदर जिसका ट्रेन माइंड होगा, ही विल बी एबल टू गो अब्रॉड एंड गेट हिमसेल्फ और हरसेल्फ ट्रेन. सो डोंट वरी अबाउट दैट, यू विल बी देयर, डोंट वरी. हम सब हुआ है, आप लोग भी होएंगे, इसलिए कोई फिक्र की बात नहीं है. सो आई एम गोइंग टू टॉक अबाउट द क्वालिटी एंड सेफ्टी इंप्रूवमेंट प्रोजेक्ट्स इन द रेजिडेंसी प्रोग्राम, बिकॉज आई अपार्ट फ्रॉम बीइंग द कस्टोडियन ऑफ दिस यूनिवर्सिटी, इसके प्रोग्राम्स को भी मैं देखता हूँ. बट आई एम अ डायरेक्टर ऑफ द नेशनल रेजिडेंसी प्रोग्राम इन द कॉलेज ऑफ फिजिशियंस ऑफ पाकिस्तान. So most of this presentation would be based upon that how we are going to actually improve the quality and safety. Can you assess who is this person? Anybody? ये क्या करने की कोशिश कर रहा है? डाइव कर रहा है. So in the first picture, if you see this, he is a professional cliff diver. Every day he would come to this cliff. He would see the depth or the height from where he has to jump. It's about 275 feet, which I gather from the literature. He actually assesses the direction of the wind. He would actually determine the depth and how far he has to jump to avoid the cliffs lower down. He knows the depth of the water. He knows that there are no sharks. He knows that there are no rocks deep in the water. So he knows where he's going to jump. And then he takes a leap forward and bends his body to an angle so that his body should hit the surface of water down below at 275 so that his body is not hurt. This is what a resident does every day. He knows where to come in, park his car, enter into the hospital, which way to go, how to reach the ward. वार्ड की एक सेट रूटीन है, उसके अंदर कैसे उसने काम करना है, कैसे एडमिशन्स करने हैं, कैसे लुक आफ्टर करना है, हिस्ट्री कैसे लेनी है, इन्वेस्टिगेशंस कैसे भेजनी है, कैसे उसने अपने सारे काम करने हैं. एंड इन अ वेरी हैज़ार्डस एनवायरनमेंट ही वुड वर्क एंड देन कम आउट एवरी डे इन एंड आउट जस्ट लाइक दिस हाई राइज डाइवर कि वो अपने रेजिडेंसी के प्रोग्राम में से इस तरह गुजरता चला जा रहा है. बट दिस इज़ नॉट द सेम फॉर अ पेशेंट. एक मरीज़ जब किसी अस्पताल में आता है, he doesn't even know where to park his motorcycle. अपनी गाड़ी कहाँ उसने पार्क करनी है, अस्पताल का कौन सा दरवाज़ा है जिससे उसने अंदर एंटर होना है, कहाँ जाना है, किस वार्ड में जाना है, किस डॉक्टर के साथ मिलना है, उसको कुछ पता नहीं होता. एंड इन द प्रोसेस ही माइट बी एंडिंग अप विद अ रॉन्ग डॉक्टर, he might be ending up with a wrong investigation, wrong kind of treatment, and in the end he might be emotionally very hurt or physically hurt as well, or maybe he can die. तो उसको तो नहीं पता. Now I'll just move to my next slide with this background. You can see what is happening. There's a master trapeze artist who is hanging downwards, and this little girl is jumping in faith that this master trapeze artist who knows his art, who knows where to be at what point of time, उसको पता है सारे काम का, he is very well trained. लेकिन इस young girl को, she does not know that she is leaping into what. But she hopes that this master trapeze artist will hold her hands and carry her to safety, would not let her fall down. So imagine that this master trapeze artist is a doctor in the hospital, and this is a patient who is just expecting this doctor to hold his or her hand there and carry this patient to the safety. And look, the next slide. This time, this little girl is blindfolded. ये आपने सर्कस में देखा होगा अक्सर. The kind of faith, the amount of faith this little girl has on this trapeze artist, that he or she, that trapeze artist, is going to carry this little girl to safety. Blind trust. Now, this is the kind of trust the patients they have in us. ये हमारे थर्ड ईयर फोर्थ ईयर की सुन रहे हैं फाइनल के. So this is the amount of trust this patient has on us. Okay, we are going to take this patient to safety. Some or the other, the quality of us would be such that we are going to take this patient to safety. And in this background, since I'm a surgeon, I will tell my patients that, trust me, I'm your surgeon. Now, this is the kind of projection which we get to them. कि अपनी वो ज़िंदगी आपके हाथ में दे रहा है, और मैं उसको कह रहा हूँ कि look at me, I'm your surgeon. वो कैसे मुझ पे ट्रस्ट कर रहा है, क्यों कर रहा है वो ट्रस्ट मुझ पे? क्या मेरी रंग, नस्ल, अकल, शक्ल देख के या डिग्रियाँ देख के मुझ पे ट्रस्ट कर रहा है? No. He's trusting me because he thinks that I'm safe. Like that trapeze artist, I will carry that little girl blindfolded to safety. उसको कुछ पता नहीं कि मैं कौन हूँ. And who is going to do this? This is the resident team who is going to build up that trust. That resident team, the residency programs, they would build that trust upon the public that yes, this surgeon is safe. क्योंकि जगह जगह पे वो थोड़ी थोड़ी quality और safety improvement कर रहे होते हैं. And this comes from the point कि जिस वक्त मरीज़ अस्पताल में दाखिल हो रहा है, उसने OPD में अपने आप को दिखाना है, उसका एडमिशन का प्रोसेस, उसका वार्ड में जाने का प्रोसेस, उसका प्री ऑपरेटिव केयर, उसकी ऑपरेटिव केयर गाइडलाइंस के हिसाब से, उसकी पोस्ट ऑपरेटिव केयर. तो over the years, the residency teams and the residency programs, they build up a trust that yes, I qualify to be a safe surgeon for you. Now, my question, which is written down there, is to the residents who are sitting over here: should we be worthy of this kind of trust? Please raise your hands. Should we be worthy of this kind of trust? क्या मरीजों को हमारे ऊपर ये ट्रस्ट करना चाहिए? हाथ नहीं खड़ा किया किसी ने. بہت تھوڑے سے لوگ ہیں. اس کا مطلب ہے کہ مریضوں کو ہمارے پہ ٹرسٹ نہیں کرنا چاہیے. نہیں, مریض کو ہمارے پہ ٹرسٹ کرنا چاہیے. اس کا اعتماد, یہ جو آپ کے ہاتھ نیچے رہے ہیں, مجھے لگتا ہے کہ ہم نے اپنے مریضوں کا اپنا اعتماد کھو دیا ہے. تو جنہوں نے ہاتھ کھڑا نہیں کیا, یہ سارا کا سارا لیکچر جناب آپ کے لیے ہے, آپ کی طرف ڈائریکٹڈ ہے. مجھے پتا تھا ہاتھ کھڑے نہیں ہوں گے, بیکاز وی نو دیٹ آر پیشنٹس ڈو ناٹ ٹرسٹ اس. So should we be worthy of that trust, I'm going to target all of you who did not raise your hands. So what is quality improvement safety? It is a data-based activity. آپ ڈیٹا گیدر کرتے and try to see that what is wrong where. You do not try to change the whole residency program. آپ focus کرتے ہیں کہ this part of the program is not working well, اور آپ اس کو فوکس کرتے ہیں and you go into the process that what is not working well. یہ thought process ہے, اور یہ کوئی بڑا لمبا چوڑا thought process, اس کے لیے آپ کو بہت brilliant ڈاکٹرز ہونے کی ضرورت نہیں ہے. آپ فوراً اندازہ کر لیتے ہیں and most of you actually know کہ کہاں پر گڑبڑ ہے, کہاں پہ ہمارا مریض پرابلم میں آتا ہے, اور ہم اس کو ٹرسٹ بلڈ اپ نہیں کر پا رہے ہوتے. بٹ سم آر دی ادر یو آر افریڈ ٹو اسپیک کہ بھائی ہمیں اس چیز کو یہاں پہ درست کرنے کی ضرورت ہے. آئی وانٹ ٹو الے یو دیٹ فیئر ان یو. میں چاہتا ہوں کہ آپ اپنے ریزیڈنسی پروگرامس کو اس طرح بلڈ اپ کریں, اور میں بھی آپ کو سکھاؤں گا کہ کس طرح ہم نے سارے پروسیس کو کرنا ہے. اینڈ الٹیمیٹلی یہ آپ کو ٹرسٹ اس لیے بلڈ اپ کرنا ہے بیکاز دی پیشنٹس دے ٹرسٹ یو, دی انسٹیٹیوشنز دے ٹرسٹ یو, یور ہیلتھ کیئر پرووائڈرز دے ٹرسٹ یو, اور آپ کی ریگولیٹری باڈیز آپ کو ٹرسٹ کرتی ہیں. سو this is the quality and safety improvement which we want in our residency programs. And why is it important? اور یہ میں نے آپ سے بھی ذکر کر دیا کہ اس لیے امپورٹنٹ ہے کہ ایز اے ڈاکٹر I must be absolutely sure that I'm trustworthy of this patient because I like that. جب میرا مریض مجھ سے آ کے یہ کہتا ہے کہ ڈاکٹر صاحب بات یہ ہے کہ مجھے آپ پہ بڑا اعتبار ہے, I like that. I want to have that kind of trust. Similarly, ہمارے انسٹیٹیوشنس کی ریکوائرمنٹ ہے کہ ہمارے مریضوں کا ہمارے ڈاکٹرس کے اوپر ٹرسٹ ہو, اور ہماری جو ریگولیٹری باڈیز ہیں وہ اس کے اوپر بڑا دھیان رکھتی ہیں کہ کیا ہمارے مریضوں کا ہمارے اوپر ٹرسٹ ہے یا نہیں. سو دیٹ از وائی ان دی ریزیڈنسی پروگرامس دس کوالٹی اینڈ سیفٹی امپروومنٹ از آف اٹموسٹ نیسیسٹی, کہ جب تک ہم اس کو امپروو نہیں کریں گے ہم مریضوں کا کانفیڈنس واپس بحال نہیں کر پائیں گے. سو واٹ میکس اے گڈ کوالٹی امپروومنٹ اینڈ سیفٹی پروگرام, یہ آپ سارے سے واقف ہوں گے. دیر اسپیسیفک گولز ہونے چاہیے, میجریبل, اچیویبل, ریزلٹس شوڈ بی فوکس, ٹائم باؤنڈ, اور اس کو ہم بیسیکلی اسمارٹ کے ایکرومنٹس سے ہم کرتے ہیں. اور یہ چھوٹی چھوٹی انٹرونشنز ہوتی ہیں. میں آپ کو دکھاؤں گا کہ ہم نے چھوٹی چھوٹی انٹرونشنز کر کے کیسے ان چیزوں کو ہم نے بہتر کر لیا. اور اس میں یہ ہے کہ اب ہم کیسے اس کو کوالٹی امپروومنٹ کو اور سیفٹی پروڈکٹس کو ہم کیسے اپنے ریزیڈنسی پروگرامس میں انکارپوریٹ کر سکتے ہیں. اینڈ مائی کوشچن ٹو یو وڈ بی دیٹ یو آر فورتھ ایئر فائنل ایئر اسٹوڈنٹس اینڈ ریزیڈنٹس اس وقت, have you ever participated in a program such like that? Have you ever done that? Dr. Sayura, have you ever done that? میرے خیال میں we have not done that. So it is becomes of utmost importance that we have to take a lead. We have to develop these quality and safety improvement programs in the residency so that we should be able to do, and this has to be done at the resident level, this has to be done at the supervisor, the program director level, and at the institutional level. اور ہم نے اس میں کام کیا, میں آپ کو دکھاتا ہوں کہ ہم نے اس میں کیسے کام کیا. کہ جو پروگرام ریزیڈنٹ ریکوائرمنٹ ہے اس میں ہماری کیا ریکوائرمنٹ ہے کہ ریزیڈنٹس جو ہے دے شوڈ بی ایکچولی سسٹمیٹکلی گوئنگ اباؤٹ سیئنگ, ٹرائنگ ٹو سی تھنگس ویئر وی گیٹ رانگ, اور وہ کلینکل ڈیٹا بیس کو یوز کرتے ہیں ٹو امپروو دی کوالٹی. اور اس کے بعد وہ بتاتے ہیں کہ اس چینج کو امپلیمنٹ ہمیں کرنا چاہیے, اور اس کے بعد دا پروگرام شوڈ بی کمیٹڈ. اور یہ میں آپ کو بتا دوں کہ ہمارے ریزیڈنٹس دے آر ویری کلیور, دے پک اپ دا پوائنٹس کہ یہاں پر اس کوالٹی امپروومنٹ کی اور سیفٹی کی ضرورت ہے اس مریض کو, بٹ سم اور دی ادر دے شائے, they are overawed by the presence of the professors, they would not speak up. But if you sit down with them, they would actually pinpoint to you کہ سر آپ کو یہاں ان چیزوں کو امپروو کرنے کی ضرورت ہے. اور اس کے ساتھ جو پروگرام ڈائریکٹرز ہیں اپنے ڈپارٹمنٹس کے, ان کو یہ ان کے لیے بہت امپورٹنٹ ہے کہ وہ اس چیز پہ مسلسل غور کرتے رہیں کہ دیکھیں اگر کوئی ریزیڈنٹ آپ کو بتا رہا ہے کہ یہاں پہ کوالٹی امپروومنٹ کی ضرورت ہے, تو نہ صرف اپنے انسٹیٹیوشن کے اندر, اپنے پروگرام کے اندر, بلکہ انٹر ڈسپلنری پروگرامس کے اندر اس کو امپلیمنٹ کریں. تو یہ پروگرام ڈائریکٹرز کی ذمہ داری ہے کہ اس کو کیسے کرنا ہے. اینڈ ایبسولوٹلی دی پروگرام institutional requirement is there کہ institutions کو they should be ensuring like if we are heading Mayo Hospital, we should be ensuring that in Mayo Hospital these quality improvement programs are done and they are implemented. And this is very famous, और ये हम सब इससे वाकिफ़ हैं कि how to do this, कि that we plan and then we actually do and then we study and then we act. और इसकी छोटी सी बना, I was the principal of Surgery Institute of Medical Sciences. We had a great collaboration with the BMJ, और हमने वहाँ से डॉक्टर मैथ्यू क्लेटन को बुलाया और मैथ्यू क्लेटन ने हमें ये इंटरवेंशंस करनी सिखाई. इसके बाद में एक छोटी सी वीडियो है. If we can actually, can we play this video for us?
On average, it actually takes 17 years for a piece of research to get into clinical practice. But that's the difference between the kind of research I was just talking about and quality improvement report. Let me take you to Lahore, to a hospital in Pakistan. Here, a group of junior doctors led by a doctor called Matthew Clayton did some very brilliant work to improve the experience of patients.
A huge problem is that the outpatient clinics, patients come back to maybe 6 months, 3 months after being discharged from hospital. They have sometimes just not taken the drugs at all, sometimes they took them all in the first week, sometimes they overdosed on it. And this is simply because they do not understand the handwritten discharge prescription they are given. We wanted to make an intervention. We designed a pictorial-based discharge prescription chart. So instead of sort of handwriting the name of the drug with a lot of sort of medical acronyms, we made it much simpler. We had a sort of picture of the sun rising over the mountains to represent morning, the sun above the mountains to represent the day. We got the pharmacists to start writing number 1 or number 2 or number 3 to correspond with our discharge medication sheet on each of the boxes of drugs they give to the patients. The pharmacists understood this concept. They were very happy to sort of engage with the whole project. And all of a sudden, the illiterate patients had a box. They could read the number on it, and then they could refer to the chart, and they could see just where the X's had been put to mark the time of day they should take it and how many days they should be taking it for. And by the time we left, within 9 days from start to finish, this discharge peripheral was being used on the medical wards in this large teaching hospital in Pakistan. And since then, it's been extended to some surgical wards and home wards since as well.
This project was published in BMJ Quality Improvement Reports, and it showed that there was a 20% increase in patients' understanding of their prescriptions. This was a fantastic report, and what's really exciting about it is that later on, a hospital in Toronto did a very similar project after being inspired by reading this project. And that's what we want to try and encourage people to very quickly publish their work and share it so that other people around the world can emulate the ideas that are generated from projects.
Thank you for watching this video. So you can see that with very small interventions, you can actually improve your programs. क्योंकि हमें प्रॉब्लम ये आई थी सबसे साथ में एंडोक्राइनोलॉजी डिपार्टमेंट में कि मरीज़ को जो दवाई लिख के दी जाती थी वो खाते थे उनको पता नहीं था चलता. So this small intervention, or I just wanted to show you this because you have to believe that we can do things here in Pakistan and these things could be recognized all over the world. क्योंकि हमारे ही प्रोग्राम को कॉपी किया गया कनाडा में and it worked very effectively. क्योंकि अगर आपने methodology ठीक रखी हुई है, then this is going to be standardized and this is going to be exported. So I want this kind of quality improvement programs to be run here. लेकिन इसके साथ साथ चूँकि मुझे CPSP में काम करने का मौका मिलता है, तो वहाँ पे हमने जो quality improvement की, we actually developed a structured residency program, which is a competency-based outcome program. We had developed an e-log system of CPSP, जो मैंने यहाँ पर आके किंग एडवर्ड में भी 32 स्पेशलिटीज़ के अंदर हमने e-log यहाँ पे डेवलप कर लिया है. And we had the acquisition and the implementation of the skills program. Professor Ibrar Ashraf is sitting right here. इन्होंने मेरे साथ मिलकर हमने ये तमाम skills workshops यहाँ पे CPSP में इंट्रोड्यूस कर दिए और हमने यहाँ पर भी किंग एडवर्ड में भी इंट्रोड्यूस कर दिए. और फाइनली अभी हमने रिसेंटली जॉइंटली हमने एक सेफ लैप्रोस्कोपिक कोस्टेक्टमी with the collaboration of Professor Asghar Naqi यहाँ पर बैठे हुए हैं, उनके साथ मिलके हमने ये सेफ कोस्टेक्टमी प्रोग्राम जो है ना, a small intervention कि आप क्वालिटी किस तरह लेकर आ सकते हैं किसी प्रोग्राम के अंदर. और उसमें ये तो खैर CPSP का जो हमने अपना स्ट्रक्चर विजुअल डिस्प्ले चार्ट्स बनाए हुए हैं एंड यू कैन सी दैट वी आर डूइंग इट इफेक्टिवली. ये मैं इसके बारे में बात करना चाहूँगा कि हमने ये लॉन्च किया सेफ कोस्टेक्टमी प्रोग्राम के अंदर जस्ट टू इम्प्रूव द क्वालिटी एंड सेफ्टी. हमने इसको एडवर्टाइज़ किया ऑन बिहाफ ऑफ सोसाइटी ऑफ सर्जन्स ऑफ पाकिस्तान और उसके बाद हमने इसको, कैन वी मूव फॉरवर्ड, ये इट्स नॉट वर्किंग, कैन वी मूव फॉरवर्ड. then we asked for applications, and the applications we got all over from Pakistan, from every province. بلکہ اس کے علاوہ imagine that this safe cholecystectomy program جو کہ ہم ایک single unit میں run کر رہے تھے, اس کے لیے we had applications from Oman, Egypt, Afghanistan and Saudi Arabia. So if you provide a quality improvement, you will get people who would be enrolled. Next slide please. So we had the services of Professor Farooq Afzal, Professor Asghar Naqvi, Professor Yar Mohammed sitting here, and Professor Waris Faruqa. ہم نے jointly اس کو safety quality improvement in laparoscopic surgery کو develop کیا. آگے چلیے. اور یہ ہم نے پہلے اس کا پروگرام اسٹیبلش کیا. نیکسٹ. اینڈ دین وی ہیڈ اے پری ٹیسٹ, اس میں ہمیں پتہ چلا کہ کون کون سی اسکلس ڈیفیشینٹ ہیں. آگے چلیے. ہم نے ان کو بینچ ٹریننگ دی, ہم نے ان کو ماڈلس پہ لے کر کے ان کو اینیمل ٹریننگ دی, اور ہم نے الٹیمیٹلی ان کو ہیومن ماڈلس پہ ٹریننگ دی. اینڈ دین وی ایکچولی گاٹ اے فیڈ بیک, and every out of those 20 candidates, everybody showed that they had some kind of an improvement in whatever they wanted to know. Unke improvement of knowledge aaya, improvement of eye-hand coordination aaya, better dissection aayi, they learned their laparoscopic skills, and they had a built up confidence that they can perform a safe laparoscopic cholecystectomy. Next slide please. And when they went back, their colleagues said that yes, they are significantly improved in their clinical skills as far as laparoscopy is concerned. Aage chaliye. And we also gave them a questionnaire کہ ان کے خیال میں ہم اور کیا اس میں further improvements لے کر آ سکتے ہیں. Next slide please. So یہ میں نے آپ کو دو چھوٹی چھوٹی انٹروینشنز دکھائی ہیں کہ ایک اگر ہم نے پیشنٹ کی ڈسچارج سمری میں کیا چھوٹی انٹروینشن کی ہے, تو ریزیڈنسی پروگرام میں اس کی کوالٹی اور سیفٹی آف دی پیشنٹ کے اوپر کیا امپروومنٹ آئی, اور ہم نے جب ایک دوسری انٹروینشن کی ان سرجری کہ ہم نے اپنا خود گائیڈ لائنز اسٹیبلش کی کہ واٹ از اے سیف لیپروسکوپک کولیسٹیکٹمی, ان کے اوپر کارآمد کیا, اس پہ بندوں کو ٹرین کیا, اور ہم اس پروگرام کو کنٹینیوسلی رن کرتے چلے جا رہے ہیں سو دیٹ وی شوڈ بی ایبل ٹو پروڈیوس such residency programs جس کے اندر quality اور safety inbuilt ہو, and ultimately it would benefit the patient. So thank you very much for your attention. Thank you.
Thank you very much, sir. Any question please? Right. Yes.
The question is to Dr. Mahmood sir. How is the safe cholecystectomy program and the other antibiotics which you take can improve the confidence of the patient and the physician?
Yes,
Is it going to be an attitude problem, or is it gap between the patient and the doctor which we have to track basically?
The idea is to do this because پیشنٹس کا جو کانفیڈنس خراب ہو گیا نا, اس میں سب سے بڑی بات ہے کہ خدا نخواستہ if a complication happens, if I do 100 remarkably well laparoscopic cholecystectomies and لوگ کہتے ہیں کہ ٹھیک ہے یہ تو اس کا کام ہے, اس کو آنا چاہیے تھا, یہ اس نے کر دیا کام, ایسی کوئی بات نہیں ہے, لیکن جس میں ایک میں کمپلیکیشن ہو جاتی ہے everybody he will tell everybody کہ یار یہ ڈاکٹر ٹھیک نہیں ہے, اس کے پاس نہیں جانا ہے, اس نے کام خراب کر دیا, مطلب اس کی اپنی گریونسز ہوتی ہیں. So it is very important to have built-in quality and safety improvement programs in the residency programs to produce doctors who are very well, articulate what they are doing. کیا کام کر رہے ہیں. اچھا یہ confidence building layer ہے. اب یہ ڈپینڈ کرتا ہے اس residency program کے اندر ان کا inbuilt mechanism کیسے کہ پیشنٹ کا اعتماد کیسے آپ ہوتا ہے. اس کا فرسٹ کانٹیکٹ جب آپ کے پاس OPD میں آتا ہے, وہ ڈاکٹرس کیسے اس کو کیٹر فار کرتے ہیں, کیسے اس کو ٹریٹ کرتے ہیں, کیسے اس کو بات کرتے ہیں, پھر اس کا ایڈمیشن کا پروسیس کیا ہے, اس کو اگر پتہ ہی نہیں ہے کہ اس نے کہاں پہ جا کے ایڈمٹ ہونا ہے, کیسے ہونا ہے, کس طریقے سے ہونا ہے, وہاں پہ اس کا کانفیڈنس خراب ہوتا ہے. پھر وارڈ میں اس کے ساتھ جو برتاؤ ہوتا ہے, اس کی ہسٹری پراپرلی نہیں ہے, ایک سیٹ پروٹوکال ہونا چاہیے گائڈ لائن کہ اب اس ریزیڈنٹ نے اس طرح ہسٹری دینی ہے, یہ اس کا آؤٹ کم ہوگا, یہ اس کو جو آپریشن تھیٹر میں لے کے جانا ہے, یہ اس کی چیک لسٹ ہوگی, آپریشن تھیٹر کے اندر اس کے ساتھ کیسے ہوگا, وہ WHO کی لسٹ کو آپ کو ادھر سے فالو کر رہے ہیں کہ نہیں کر رہے ہیں, اینڈ الٹیمیٹلی دا ڈسچارج, جس وقت مریض کو ڈسچارج کریں اس وقت اس مریض کے ساتھ کیا ہو رہا ہے, تو اس کو بھی دیکھنے کی ضرورت ہے. سو دیٹ از ہاؤ, جب تک آپ یہ کوالٹی اور سیفٹی امپروومنٹ اپنے ریزیڈنسی پروگرامس کے اندر بلڈ اپ نہیں کریں گے, مریضوں کا ٹرسٹ آپ کو بلڈ اپ ہو نہیں پائے.
Basically, I'm asking that's mainly the crux of the problem. That when you're doing that, surgical procedure, it starts with the information to the patient. Because usually well-informed patient is a paradise for the doctor, basically. He knows everything. So that's why it's easy for the doctor to explain. Are we doing anything to improve these abilities in the students or in the doctors, that they should be well informed and they will read into the exam of patients who will be well informed? Otherwise, I feel personally that this is the main problem, that patient consent is not been taken in many places.
आपने बिल्कुल ठीक कहा
More confidence will be developed, it has not been in place. And also, not coming to the main thing. When we say these things, I believe in one thing, that is, walking preachers are better than the talking preachers. The ideals for these people and their mentors, for their trainers, are the trainers doing the same thing? Or they're just talking?
जी आप उसमें ये है कि आई अंडरस्टैंड योर कंसर्न, लेकिन इसको कॉलेज ऑफिसर्स पाकिस्तान में भाई यूनिवर्सिटीज़ को कैसे एड्रेस करने की कोशिश कर रही है। कॉलेज के जितने भी रेजिडेंट्स हैं जो एक्सपीरियंस कर रहे हैं और यूनिवर्सिटी के जितने भी रेजिडेंट्स जो MSN की प्रोग्राम कर रहे हैं, दे हैव टू अंडरगो 5 डिफरेंट वर्कशॉप्स। उन वर्कशॉप्स में से एक वर्कशॉप में है कम्युनिकेशन स्किल्स की है, एंड नो रेजिडेंट्स इज अलाउड टू गिव एन एग्जामिनेशन जब तक उन्होंने वर्कशॉप्स को अटेंड नहीं कर लिया होता, उसमें थ्रू नहीं होते। ये 3 डेज की वर्कशॉप्स होती हैं जिसमें उनको प्योरली सिर्फ कम्युनिकेशन स्किल्स सिखाई जाती है, बिकॉज जो आप बात करें दैट वो बेसिकली कम्युनिकेशन गैप है मरीज का और डॉक्टर का। तो जब तक हम अपने डॉक्टर को ये नहीं सिखाएंगे कि हाउ टू डू इफेक्टिव एंड गुड कम्युनिकेशन, तो ये मसला हल नहीं होगा। सो आपकी बात दुरुस्त है, बीच में एक ऐसा गैप आया 10-15-20 साल का जहाँ पे डॉक्टर्स बहुत इफेक्टिव कम्युनिकेटर्स नहीं थे, वो इफेक्टिवली कम्युनिकेट नहीं कर सके, पेशेंट की नीड्स को केटर नहीं कर सके। अगर आप मुझसे पूछें कि मरीज की सबसे बड़ी कंप्लेंट क्या होती है, उसकी कंप्लेंट ये होती है, मैं तो पंजाबी में बात करूँगा कि सुनता है तो दसदा नहीं, दसदा है तो सुनता नहीं, मतलब यही कंप्लेंट है कि मतलब बात करता है तो अपनी बात करते चले जाता है, मेरी तो बात सुनता ही नहीं, और अगर सुनता है तो मुझे बताता नहीं कि मेरे साथ क्या होगा। तो सुनता है तो दसदा नहीं, दसदा है तो सुनता नहीं, ये बिगेस्ट कंप्लेंट है। हम इसी को एड्रेस करने की कोशिश करें एट द लेवल ऑफ यूनिवर्सिटी, और इसी को एड्रेस करने की कोशिश करें एट द लेवल ऑफ CPHP। ये कम्युनिकेशन स्किल्स हमें सिखाए जाए कि देखिए मरीज की बात सुननी भी है, उसको बताना भी है। यू हैव टू एक्चुअली लिसन टू द पेशेंट एंड इन्फॉर्म द पेशेंट। तो वो जो हमारा एक पार्ट था कि टू सिट डाउन विद द पेशेंट एंड लिसन टू द पेशेंट एंड टेक अ गुड हिस्ट्री, डू अ रिमार्केबल फिजिकल एग्जामिनेशन, हेल्थ सेंटर इन्वेस्टिगेशन। अब आया मरीज का चेहरा देखकर उसको साथ ही CT स्कैन करके भेज देंगे तो मरीज का अपना कॉन्फिडेंस होगा। So that is what we are trying to inculcate back, what our teachers taught us, लेकिन बीच में कोई 10-15 साल का गैप आया कि वो शायद हम उसको उस तरीके से फुलफिल नहीं कर सकें।
Okay, thank you very much, sir, for a very insightful discussion. Now, I would like to welcome our very senior professors who have joined us, Professor Mahmood Shaukat, Professor Latif Malik, Professor Mukhtar Randhawa, Professor Laik, and Professor Nasir Zaidi. Thank you very much, sir, for joining us. I will request Professor Latif Malik to join us on the stage, sir. Professor Latif Malik, would you please come and join us on the stage before I invite the next speaker. Next blood. Our next Thank you very much, sir, for honoring us. Our next speaker is Professor of Psychiatry, Professor Dr. Muhammad Aslam. He is the President Camcana in 2020 to 21, Reviewer of Annals of King Edward Medical University, Visiting Faculty of King Edward Medical University, and he has done a lot of hard work in designing this whole scientific symposium. Thank you very much. As a chairman scientific committee, you did a lot of hard work. Thank you for your talk today again.
Assalamu alaikum, everyone. First of all, I want to say that it's always a great honor to be here, and I want to thank you, Dr. Professor, Vice Chancellor Saab, Ayaz Mahmood Saab, and Dr. Sara Afzal, of course. They work very collegially and collaboratively to arrange this scientific session, and I always feel privileged and honored to be part of it. Do you know how to move the slide? Oh. So I've been given a task to talk about my presentation in 10 minutes, and I will try to be short and sweet. I know that most of the audiences are not psychiatrists here, and I see Dr. Nazir Shamran is here. She is the psychiatrist, child psychiatrist I know of. I don't see my dear friend and colleague and my classmate, Dr. Ali Hashmi, who is very difficult to hide. If he was sitting here, I would definitely see him. But anyway, I will try my best. I know a lot of people are not psychiatrists, but I believe that no matter whatever your specialties is, you should know a little bit about psychiatry. And especially as Dr. Tufail was mentioning that during the pandemic, there was huge increase in anxiety and depression. And of course, that recognition is very important. If you don't know and don't see it, and especially we were talking about patient satisfaction, and if patients are depressed, they will not satisfy either. So that's also an important thing. So I will try to make a point of why should we diagnose and treat early depression, because if we don't diagnose and treat early, there is a huge impact and there is a huge consequences in overall on the patient health, no matter whatever their disease is. Here are some of my objectives. I want to talk about how common and how prevalent depression is, and it's a very costly illness and also disabling condition, and some of the risk factors for depression. And I think unfortunately a lot of patients who are depressed, if they're left untreated, they end up committing suicide. You can treat and do a lot of things, and if you don't recognize that they are depressed, they may you put a stent and they are depressed after heart attack, and they may end up dying because of suicide. And then I'll talk about diagnosis of depression. I think everybody should know a little bit questionnaire about how to diagnose and maybe to offer treatment option while they are in your office or your clinic, and maybe you can refer them later on to psychiatrists. As far as prevalence is concerned, as you can see, that depression is a very common illness. It affects millions of people worldwide. 1 in 6 or 7% in the United States suffer from depression in lifetime. And unfortunately, as you can see, that 50% of the people who suffer from depression, they don't even get diagnosed. And the sad part is that for people who even get diagnosed, only 25% of the patients get evidence-based treatment for depression. Now, where should we look for depression? That, as I mentioned, whether your specialty is, you are oncologist, OB/GYN, neurologist, everybody in your practice, you will see patients with depression, especially with the chronic illnesses, which are untreatable illnesses. That's the way you will see the depression. As you can see, the patient with stroke, cancer, they can have up to depression, up to 50% of people may have depression. Now, and not only is a disabling condition, is a very costly illness. As you can see, that the cost, overall cost, direct as well as indirect cost. A lot of time, patients who are suffering from depression, family and loved ones have to take care of them because they don't want to take care of themselves. Even taking medication can be a huge problem for depressed patients, or taking care of their diabetes, blood pressure, or anything like that. I recently had somebody whose loved one who was diabetic and hypertensive, and his close relative died and he became depressed, and I was consulted because his blood sugar was not managed and his blood pressure was not managed properly because he stopped taking medication due to depression. That's why I think we should pay attention to this. I think I'll skip that. According to WHO, if you look at the total disease burden wise, depression still ranks as the #1 disabling condition. Due to depression, there is a lot of early life deaths and disability because of depression. Also, I mentioned about suicide, especially patients who are in an early age. As you can see, there is a bimodal risk factor for suicide, and depression is the biggest, cofactor with that suicide, especially in early age and late age in the United States. I don't know the data or in Pakistan, what happens in late life in Pakistan, because we have a lot of family structure and culturally we are very close to our loved ones, especially in the elderly, our grandparents and parents. And that's why I don't know how common suicide is in late life, but in the United States, the social isolation is a big problem. People live alone if their spouses have died, and they live for years themselves, and a lot of them, they own guns too. As you can know that gun is very easily you can buy in the United States. And they end up committing suicide, especially with the gunshot injuries. There is also misconception that anybody who probably is old and has, probably in a late life, they should be depressed, but depression and old age doesn't go together. Depression can be easily, diagnosed. This is a diagnostic statistical manual. That's how psychiatrists usually make diagnosis. The red, as you can see, the two symptoms in the red, each patient who has depression should have either depressed mood or lost interest in pleasure, and then some of the other comorbid psychiatric symptoms, such as sleep problem, fatigue, or low energy, weight loss, appetite changes. These has to be, but the patient should have either depressed mood or loss of interest in different activities or whatever pleasure they used to enjoy. Here are some of the risk factors. Women tend to have more depression compared to men. There are people who are functional. Of course, it's not a rocket science. If you are functionally or cognitively impaired, you will become depressed. Lack of social support, like I mentioned earlier, lifetime stressor, and the history of depression. If you have depression in the past, you are more likely to get depressed again. There are some of the medication and medical condition which has a high prevalence of depression, as I mentioned earlier too, especially benzodiazepine, which are very commonly used, especially in Pakistan, and antipsychotic medication, which are sometimes used for other symptoms related. They can cause depression too, especially people with mania and psychosis. These are some of the other medications you should pay attention. If these people, your patients are on these medications, you should always screen them for depression, whether they have any ongoing depression or not. Medical condition I already mentioned, especially the cancer, cardiovascular disease, hypothyroidism. These are some of the common diseases which can present with depression. Now, this is a schematic picture of patients. The stress and depression. If in case you leave depression untreated, patient can have metabolic responses, autonomic responses, and behavioral responses. As I was mentioning, that patient, chronic stress and depression can activate your hypothalamus pituitary axis, and people can have hypercortisolemia, and then their blood sugar can go high, and that's why a lot of people who are depressed, their blood pressure is difficult to control. Same applies to the blood pressure. People who have chronic depression, they can have hyper pituitary axis activation, and their blood pressure is difficult to control, and that's one condition. That's why it's important to screen these patients for depression. I will skip this. Screening can be done very easily in your clinics. You have to ask the question whether you have felt depressed or hopeless, whether you have lost interest and pleasure in doing activity you used to enjoy. And it has pretty high sensitivity, as you can see, up to 96%, and specificity of 75%. There is also online questionnaire you can find on the Google, the PHQ-9, depression and inventory scale, which can be done by professional psychologists or psychiatrists. There are, like, as you can see, there are a lot of variety of treatments available for depression. As you can see, that's why I think it's important to treat these patients. If one medication or treatment doesn't work, there are other options. This I already mentioned that unfortunately more than half the patients don't get treated, even they get diagnosis. And this is very unfortunate, and they continue to suffer, and their family continue to suffer with the patient who suffer from depression. Then in summary, I think depression is a common, costly, and serious illness. It can increase the morbidity and mortality, especially suicide is a bigger risk factor, especially in the younger population and older population, according to US data. And if left undiagnosed and treated, there are consequences. Not only the patient can have chronic recurrence of depression, and there are also, they can become disabled, because of depression. They can lose their jobs, they cannot perform in their school, college, or other area of functioning. Thank you very much for your attention, and I'm more than happy to open for questions. Yeah.
Half of the patients are diagnosed as depression. If they're not diagnosed, how do we make this?
I don't know the actually epidemiological evidence, but I think most of there is social stigma. Patient also have social stigma, and they don't even present that. Yeah. Yeah, that's what we believe. There is no data. Yeah. Any other question? Thank you very much.
Thank you very much, Dr. Muhammad Aslam. Now I would like to invite our chief guest on the stage, Professor Mazhar Iqbal Chaudhry. He is a Cambodian, a parliamentarian, and also the syndicate member of King Edward Medical University. Thank you very much, sir, for joining us today. Our next speaker is Dr. Asif Khan. He is the consultant interventional cardiologist from Mansfield Hospital, United Kingdom. His topic is Cardiology Updates, European Society of Cardiology.
Thank you very much, sir. Respected guests, my teachers, mentors, and all the colleagues from KEMKANA and KEMKA UK and medical students. So I believe I cannot justify the European Society of whole guidelines, even in a single guideline in 10 minutes, but I thought to bring up only one topic out of it, which I feel every physician, every medical student should know the basics, how we can do a management of non-valvular atrial fibrillation. And when we say a non-valvular atrial fibrillation, I think we need to understand that terminology, because especially this part of the world, we have still a lot of rheumatic valvular heart disease, and a lot of people are suffering from mitral valve disease. So it's very important that if you have a patient with severe mitral regurgitation or mitral stenosis, which is in a severe category, or if they have a mechanical heart valve, then these guidelines need to look at carefully, because for these patients, you will not be using the new anticoagulant and you will be sticking to the warfarin. So that's one of the important take-home message from this talk you need to take. How we detect atrial fibrillation, because when I remember working as a house officer in cardiology in 2003 here, I rarely remember that we were that much focused on just finding atrial fibrillation and treating it. We were just rate controlling it and trying to cardiovert every patient with amiodarone or tablets at that time. But I think while we read these guidelines, there are safe ways to manage this condition. How we select our patient, how we make the perfect treatment choice, and how we can protect our community. So I'm not going to go much in pathophysiological detail, but we know it's one of the supraventricular atrial tachycardia or atrial arrhythmia, and it can cause disorganizational activity. So in simple word, if you're explaining to your patient, you can tell them it's an irregular heartbeat, and that puts you at increased risk of stroke. It is quite prevalent. So I think whenever we're getting older, our parents, our grandparents, it can happen in a huge number of population, and you can look at these studies, and some of them even show that in near future, we're talking about this burden is very, very high, and we're talking about even Europe and US, 1 in 4 middle-aged people will reach this condition by 2030. So I think this condition need to be assessed and diagnosed properly. As we said, there are a lot of common conditions, causes of this atrial fibrillation, and the most common are rheumatic heart disease, heart failure, and if they have underlying congenital heart disease. But we see this condition a lot in patients who have been post-operatively. So surgical colleagues, we get a lot of referrals from surgical colleagues if they have just done a surgery and people have developed atrial fibrillation either due to electrolyte imbalance or if they have developed other complication of infection or pulmonary embolism. And other common conditions like hypertension, alcohol abuse, obesity, and smoking are all trigger factors. So very important to look into it. There are different types of atrial fibrillation. Again, we can read all in the data on European Society guidelines, but it's very important to detect that if you have been diagnosed with atrial fibrillation, you need to risk stratify them. It's very important to risk stratify, because if we don't detect the proper risk in these people, they will end up with a major stroke and thromboembolic complication. And you can see there is a 46% increase in mortality in these people and 5-fold increase in heart failure. So even this condition, which is easily treatable, easily can we prevent these complications. But if this condition go a long way, you can develop heart failure, and this can be in a quite high prevalence. Again, this slide can even tell you that even 20 to 30% of the stroke patient are coming with atrial fibrillation. Every stroke patient in our in European setup, as soon as they're diagnosed with either a transient ischemic attack, TIA, or a stroke, they go full workup to detect for atrial fibrillation, and that will involve a monitoring, which can be a prolonged monitoring in the form of either they will use a 72-hour or up to 1 week of Holter monitoring, or nowadays we have devices where you can implant. It's called implantable loop device. It's like a small chip device where you implant in your skin. It stays there your lifelong. It can detect up to 3 years. So these are the devices available. And nowadays these smartwatches, Apple smartwatch has done miracles. In USA there's a study and it can detect up to 70 to 80% of atrial fibrillation. So it's very important that these people need a prolonged monitoring. One important thing you can do whenever you're seeing this patient, especially after age 65, make sure you put your hand on their pulse. There is a good specificity and sensitivity. So start touching your patient. Now corona is quite less now, so put your hand on the pulse of the patient and see. You can detect irregular heartbeat, do their ECG, because there is a high chance that you will detect this, because a lot of people are walking in this community with the rate control atrial fibrillation, and they're like sitting with a time bomb inside and will end up with a stroke. If you want to take anything from this talk today, this slide, CHAD-VASc score. How many of my medical students know about CHAD-VASc score? Just raise your hand. Have you heard about CHAD-VASc score? Okay, so only 2 or 3 hands. So are all medical students in UK, when we do talk for third year student, fourth year student, that is a pet question. You need to know your CHAD-VASc score, and that is very simple. All of you have smartphones. There are apps available how to do a risk calculator for atrial fibrillation. There is a Hasbled score which tell you about the risk of bleeding, but that doesn't tell you that don't give them anticoagulation. That just tell you more that they are risk of bleeding. But if you memorize this CHAD-2-VASc score, you can risk stratify them. Being a female, you carry a risk of 1, but that risk of 1 will still remain as 0 unless you remain age below 65. As a female, if you score if you go over 65 and you score 2 because you are as a female, then you definitely need anticoagulation. So it's very important. Look at this risk score. Anybody with a heart failure, hypertension, age more than 65 or 75, because after 75 score is 2, and automatically you score 2, you definitely need anticoagulation. Being a diabetic or previous TIA or stroke, vascular disease easily missed when we take our history. So people either previous peripheral vascular disease or aortic plaque disease or myocardial infarction. And as we talk about sex category being a female. So this slides tell you more about, as I said, mechanical heart valve or moderate to severe mitral stenosis. If you have this condition, you're not going for new anticoagulant. You will stick to your warfarin, which has been used traditionally and has been working very well to prevent stroke. Otherwise, you come back to your CHA2DS2-VASc score and you look into how much they're scoring. And I want to declare this myth or old practice: aspirin or clopidogrel or any of the antiplatelet will not prevent a stroke or TIA in atrial fibrillation. So if you think your patient cannot take anticoagulation and you can just give them aspirin, you think, yeah, it will prevent stroke, that has been proven that has not going to work now. Either you go for anticoagulation or think about other option like left atrial appendage closure or catheter ablation for these people. So you have to manage this patient by rate or rhythm control, and also to assess how you're going to give them a better quality of life and their life expectancy. There are 4 new anticoagulants out in the worldwide market. I believe some of them are also already available in Pakistan for years, and in terms of dabigatran, rivaroxaban, apixaban, and edoxaban, and they all have been used in the trials for prevention of stroke in atrial fibrillation patient. This I've already have brief about how to assess the CHA2DS2-VASc score, and these people need anticoagulation, and there is a 1A indication for anybody who is scoring 2 or more or 3 or more for female. Definitely they need anticoagulation, but also the guidelines suggests if you're scoring even 1 as a male or 2 as a female, it should be considered because there are 2A evidence available for that. This slide is important for what can cause harm. So you should not combine anticoagulant with antiplatelet unless there is an indication. So only indication being an interventionist after heart attack, or if you deploy a stent, then you need a combination of anticoagulant and antiplatelets. And as I said, antiplatelet monotherapy is not anymore being considered for prevention of stroke. And again, you have to understand what valve condition they got. So to understand that, you need echocardiography to understand what sort of mitral valve disease they got. We're going to go when you need to go to the cardiologist for this condition. So all physicians should be able to manage atrial fibrillation, risk stratify them, but when you want to refer them to a specialist, so either if they got underlying WPW syndrome or if they got underlying valvular heart disease, so you can do all your basic workup for these patients, or if they think they have developed already a heart failure, because you can prevent this heart failure by reverting them to sinus rhythm by doing a cardioversion, and either they need a pharmacological cardioversion or electrical cardioversion. Arrhythmia team can offer a lot of things which you can even start in community or when you see them in accident emergency. You rate control them, you can cardiovert them if they're presenting within 48 hours of their first presentation. But history is the key, because their first presentation may not be the first presentation. They may be having palpitation for a few weeks or months. So you don't want to revert them to just achieve the rate control, anticoagulate them, and bring them back for cardioversion. There is a phenomenon called pill in pocket with use of tablet like flecainide, and other options as a catheter ablation is an important thing which is done by a cardiac electrophysiologist. I believe PIC in Lahore have also started doing PVI ablation, as well as in Islamabad, the AR centers are doing PVI ablation. So the people who are not suitable to take antiarrhythmic, or they are young and they are resistant to medical therapy, they should be considered for catheter ablation. The other option is AV node ablation, which is a last resort, because you need to burn the AV node completely and put a pacemaker, and these patients will become a pacemaker dependent. In heart failure condition, important to choose the right drug. So either if your ejection fraction is less than 40%, your option left with beta blocker or digoxin. If you're more than 40%, then we're talking about diltiazem as well into your list of medication. Again, pacing indication is possible if you are failing with medical therapy, or if you're developing a heart failure or bundle branch block. So this is what I've mentioned about the European Society guideline about use of antiplatelet for ACS management, and you have to give a triple therapy for first month if you have just deployed a stent for MI. and after that you can continue with a combination of antiplatelet anticoagulation up to 12 months. After 12 months, it's up to the consultant interventionist to decide either he want to continue with this long-term combination or should we stop doing that because it's high risk of bleeding. I think I will stop here with my time up. Thank you very much.
Any questions? Any questions? Right. Thank.
Yes, I agree.
Yeah, please.
Very informative lecture on interpretation and about anticoagulants nowadays in practice. Do you have the antidotes for the defect anticoagulants? So if in case of emergency or accident, if somebody is taking the medicine and starts bleeding, how to stop?
So at the moment there are... Yeah. So in terms of NOAC, there is no specific antidote still available, but we have been managing bleeding with the usual bleeding practice which we're doing with warfarin and for all these new anticoagulant. There is a new antidote has been worked out for dabigatran, but it's not much used still in practice. But whenever we start patient on these new anticoagulant, we give them this counseling that there is no specific antidote. If you have a head injury or bleeding complication, we will manage all the bleeding complication as standard we do with warfarin. Thank you very much. Thanks for listening.
May I call him again? Okay. Dr. Asif, you have one comment or question from Dr. Tabitha Dubey.
I cannot ignore Tabinda. She's my boss.
No, I had a comment and a question. Asif, one was that I didn't know that myself, but a patient told me I was working for hypogonadism and he said that atrial fibrillation was more common in people with hypogonadism. So that was one, just to let everybody know, because I didn't know myself and I did some research into it and I did find out that, you know, what used to be known as known atrial fibrillation, this was one of the causes. And do you, I don't know whether you do it or whether you still call it known atrial fibrillation or not. Is that the term still used?
So I think the reason I use the word of non-valvular atrial fibrillation is just to make people understand that if they have valvular heart disease, then they should be able to differentiate. Otherwise, it's it's the same terminology. But just for medical, our faculty, we need to understand what's the difference between valvular and non-valvular AF.
And my last comment was about other systemic disorders like toxicosis. So please don't forget to check.
Yeah, definitely. You have to treat the underlying cause. So if you have a bypass surgery or underlying thyroid problem, if you fix the problem, you don't need to go for anticoagulation because you fix the underlying problem. Thank you.
Thank you very much, and Dr. Asif, really a nice gesture of answering a very brilliantly put question. I would like to welcome Professor Sadastam Khan, Professor Fareed Dul Zafar, Professor Muhammad Amjad, and Professor Saqib Saeed, Professor Asif. Thank you very much for joining us. Now, the last speaker of this session, Professor Ebrar Ashraf Ali. After this, we would have inauguration session, and we would also like to welcome Ms. Fatima Fazal. She is here along with her team, and yes, there is a lot of applause for her hard work that she has done for Mayo Hospital, and her presentation would be the part of the inauguration session. After this, we also have many presentations, and that would be in the session 2. So, the last presentation of session 1 by Professor Dr. Ebrar Ashraf Ali.
Thank you very much, Saira. I'm extremely grateful to the organizing committee, KEMCA UK, KEMCANA, for giving me this opportunity. And I'm going to talk about role of simulation in integrated curriculum, a KEMU perspective. If we look onto the curriculum, it is all the planned and unplanned learning activities which we are covering, and we are going to find out, and they are being placed to do the specific learning outcomes. And these are the behaviors which are going to give you the product picture which is going to be there, and it encompass the need assessment, the modes of information transfer, and the assessment. So what is there? The most important thing is that we have to begin with the end in mind. If we are not going to do that, we will not be able to achieve what we are going to try to achieve. Issue is, do we have a product definition? And there is a long list which is present over there. As yesterday Professor Mahmood Shaukat was talking of, there is 7-star, 5-star doctors, and there is becoming tomorrow's doctor. Not only in the medical education, but in other education systems, they are moving towards the competency-based learning, and the competencies, they are the one which are going to define your product. So the paradigm shift is from the content to the focus on the competencies, from rigid to the flexible opportunities, from summative assessment to the formative assessment, and emphasis from schooling to the education. And most important thing is a paradigm shift of teaching to learning. So what is important is how we are going to transfer the learning. Motivation behind these modern transformations are based on the education psychologies and the theories, the requirements by the medical education organizations, and in Pakistan, and in Jibas, and in Pakistan, we are looking forward towards the WFME and the PMC. And they are the one who are driving the forces and is recommending us the various types of curricula. And this is the proposed KMU graduate competencies which we are proposing. That is, they should be care providers, professionals, global citizens, entrepreneurial leaders, and the scholars. Issue is, can the curriculum in use make the desired product? This is one of the module which is present over there. Yes, we do have an integration, and a vertical integration is there. But to encompass all these competencies, there is a requirement that which we need to have certain intervention which needs to be made. The current status of education in the eyes of the stakeholders, they think like that the curriculum is implicit. There is a lack of teacher commitment, varied learner commitment, non-existent teacher training, diverse learning opportunities, varied clinical workload, non-existent monitoring, and assessment not aligned with the outcomes and assessors' competence. These are all the issues which needs to be addressed. So what's the solution is the holistic conceptual building of integration, avoid null curriculum, and implementation of the curriculum. These are the possible solutions for that. And how the historical developments of medical education curricula, they started off from the apprenticeship model, then the Flexer report came, and then the Case Western Reserve University curriculum came into existence, problem-based learning in 1968, the CP integrated in and the competency-based in 1998, spiral curriculum in 1999, and experience-based learning in 2004, and currently the longitudinal integrated clerkship model that is going on. So if we look onto the integration, what it brings the breakdown barriers between the basic and clinical sciences. It's promote acquisition of retention and progressive development of knowledge and skills, and facilitate applications of the concepts. How to integrate? There are horizontal, vertical, and spiral models which are present. And out of that, if we look into it, if we have to make an intervention into an already going integrated model, which is vertical one, so in the spiral you have got the opportunities where you are going to put the interventions which can go longitudinally, and they can be these longitudinal. In all 5 years you can develop the various competencies which you are going to design. The integrated curriculum models which are available is problem-based, case-based, and clinical presentation. And most suitable one for us, because we have got a lot of clinical patients and the clinical teaching material available to us. The clinical presentation is the one which can be included into this this inductive framework. How we are going to adopt it, the systems approach is one which is adopted from the industry, and it gives you a roadmap that how you are going to assure the competence and how you are going to have the improvement. And it starts with the input, the process, the product, and the outcomes. And the process are going to have the quality assurance. The product is going to be detection of the product which is not suitable to go into the market, and it produces a rework. So it's very important that we have to put our emphasis on the quality assurance. And what are the types of different curricula which are framed out of when we are going to doing the monitoring and the evaluation? If we look over here, the recommended curricula are the one which are being given by the agencies which are doing the monitoring, and the written curriculum is one which is produced by the organizations. So they put them into a taught curriculum which is processed over there, which is supported by the curriculum and logistics. And out of that, there is going to be one which is going to be assessed, and you are going to find out that there are certain null curricula and there are hidden curriculum which are present over there. And finally, the learned curriculum. So if we look over here, to reduce down this null curriculum and to bridge the gap between the written curriculum and the learned curriculum, what is required is that we need to have certain intervention. And these interventions are going to come when we are going to have certain modules which are going to address this, that there is a deficiency in the clinical load or varied teaching and learning is there. This is going to be bridged by the simulated training, because it gives you the most important one is the assurance of the content coverage which it is going to provide, and at the same time gather the measurable data on students and patients. The simulation technologies, there are a huge number of simulated technologies which are available, but it is the most important one is that it is you who is going to select that which one is going to work for you. The learning domains which are going to be covered through them is the psychomotor skills, the soft skills, the peer-assisted learning assessment, and the affective domain. If we look into it, the high fidelity simulators and we have got low fidelity simulators, the cost balance is going to be created through that we are going to target the learning objectives. We are going to look for that which are going to be helpful for the clinical reasoning and which procedural trainings are required for these students. How do we optimally implement it is that we are going to target the task, we are going to develop the faculty, and institutional commitment is the most important thing. This is again one of the slide which I am repeating, that these are the proposed one which are going to be the future or the pen picture of a graduate of a King Edward Medical University. And the roadmap to achieve this is through the developing curriculum with product definition, implement the curriculum with monitoring, evaluation of curriculum for improvement. And nothing is impossible if you have got a will. And if you have a will and you have the attitude, you are going to achieve it. Thank you very much for your patience, please. Any questions? हम थिंकिंग मोड का टाइम दे रहे हैं जी, प्लीज फाइजल.
Thank you so much, sir. Respected sir, I want to know that you have talked about the vertical model of learning. So, how can you improve? Like, I am related to my subject of anatomy. So, I would like that anatomy should be correlated with the surgery, and our students of anatomy, if we tell them about the some procedures, clinicals, so we must have some data from the surgical department that we can show them and we can give them a good assess.
Ji Faiza, you are talking of the vertical integration. And for vertical integration, the most important thing is that what learning strategy we are going to adopt. When we are going to adopt for example, a hernia, So we are going to start with a clinical presentation that this patient has presented with these signs and symptoms and he has got a hernia. Now let's start looking on to what's the anatomy of it. And when we are going to, and why we want to learn this anatomy, this is going to come from the surgery. So from the year one, they are going to have the direction that why they are learning, how they are going to solve the problem of a patient who is going to come with a hernia. So this is how you are going to, the clinical presentations you are going to make, and if you are going to give the students this, they can do wonders, because they are going to have 5 years where they can integrate the basics and the clinical sciences, and then they are going to be better doctors. Thank you very much.
Thank you very much, sir. We are very pleased that our guest of honor, Professor Asad Aslam Khan, has also joined us. So please come on the stage and have your seat. So we would proceed towards the inauguration session. Professor Asad Aslam Khan is the former Vice Chancellor of King Edward Medical University and Professor of Ophthalmology. Now I would request for the recitation from the Holy Quran, Qari Harun Rashid. Please come forward and recite few verses from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الذي خلقني فهو يهدين والذي هو يطعمني وإذا مرضت فهو يشفين صدق الله العظيم. इन आयात का मफ़हूम कुछ इस तरह से है, मेरा रब तो वही है जिसने मुझे पैदा किया है, फिर वही मेरी रहनुमाई भी करता है और वही है जो खिलाता है और पिलाता है, और जब मैं बीमार पड़ जाता हूँ और वही मुझे शिफा दे देता है. वाखिर दावाना अल्हम्दुलिल्लाहि रब्बिल आलमीन.
Jazakallah. This is the 42nd International Scientific Symposium that is being held in collaboration with Kemkana, Kemka UK and Apna, and we are very glad that more than 55 workshops have been planned in collaboration with Kemka UK and Kemkana, and almost 45 have been done before 17th December, and we would continue with the workshops after the symposium too. We are really proud that Ms. Fatma Fazal is among us. She is the lady that has changed the Mayo Hospital. For her outstanding contributions to the Mayo Hospital has been witnessed by everyone. Action speaks louder than the words. I would like to invite Ms. Fatma Fazal and her team for a presentation on the restoration of Mayo Hospital.
Thank you, Ji. Bismillahirrahmanirrahim. Assalamu alaikum. Thank you so much, all team of King Edward Medical College, University, and all doctors, Kemkana, Apna, and all these their representatives. Thank you so much for inviting us. We are part of Mayo now. I think we own Mayo. I don't know how. Thanks to Dr. Asad Aslam. When we started working, Dr. Saab was there, and he was the one who encouraged us and who showed us the way how can we work. And then Dr. Mehboob Shaukat Sahab was there, and all these doctors, Dr. Ibrar, everybody. I cannot name all of them because, mashallah, these all wonderful people, and now our present CEO and all these people, they are really helping us a lot. Our mission is to improve the infrastructure of and health providing situation at Mayo Hospital. You can, because we were very, very upset when we saw the situation at Mayo, and we were really surprised to see the situation, how you people are working there. Because it was not only for the patient, it was for the doctors and all those staff who are working there. It was not at all, like I feel it's not humanly possible to work in that state. So we, alhamdulillah, thanks to all our generous donors who have contributed generously, and whenever we inaugurate one project, our next donor come up and tell us that I want to do the next project. So we have already done for 12 projects over there. Today we are inaugurating 2 more, so total 14 projects will be completed today, inshallah. And next two will be inaugurated very soon. We are already working on pediatric surgery unit, which will be completed by end of January, and then the pediatric emergency that we are taking up for the next, and we are connecting pediatric emergency to the wards, theatres and everything. So alhamdulillah, we are blessed with a very, very, surprising team. Brigadier Shadab, Amreen Irfan, who is our Vice President, and all our other members who are really doing a marvelous job. They are not only contributing their time, they are very dedicated, and they are trying their best to work for Mayo Hospital. So I don't know how, but we own Mayo Hospital. We are trying to give our time, our resources, our efforts for this country, for these people, and we really hope for the future. Inshallah, we'll just complete Mayo Hospital. Abhi Dr. Fareed Sahab was suggesting me come to other hospitals. Let us finish Mayo. Then Lady HSN, we just visited and we were surprised. Unfortunately, Dr. Saiba ne hame dikhaya, and we were really very upset to see the conditions over there. We are here, inshallah. Doesn't matter kaun si sarkar aa rahi hai, kaun si nahi aa rahi. We are not political people, so we are just donor. We are helping donors. We are a bridge between all those donors who want to donate for Mayo. We are here for all those doctors, all those people who want to contribute, who want to donate for their loving country, Pakistan, and we are here to help Pakistan, our people, and our organization, our institutions. So thank you so much once again. I am really obliged. Thank you. You can see our presentation. Now we are showing you our presentation.
When me and Amreen Irfan saw many people sitting on the roadside, that hit us that why these people are sitting here. There is nothing where they can sit or take a shelter, at least in extreme weather.
So we decided that both of us join hands and do something for this hospital, which is an icon. It's the largest hospital in Punjab.
The hospital put to the public in 1871, nearly 150 years ago. So this carries a lot of legacy, a lot of history behind it, and a lot of well-reputed teachers, very big names have worked in this institution.
Mayo Hospital is a landmark building of the colonial period, but sadly the building has not been kept very well.
The place was in shambles. Some of the buildings were really in very bad condition because they're such old buildings, and there's so many patients there. They were putting bricks under the beds. They were using shopping bags as suckers. So we were just shocked at what is going on here.
I thought, no, we must do something, maybe very little, but we have to do something to improve the situation for all these people who are in misery.
ख्वाब है कितने बड़े अस्पताल को एक NGO उठा रही है और चैलेंज को एक्सेप्ट कर रही है कि हम इसका इन पर ना सिर्फ इंफ्रास्ट्रक्चर बल्कि यहाँ पर एक एटीट्यूड चेंज को लेके आएंगे। तो हमारी दिली खुशी हुई, दिली में खुशी हुई कि अल्लाह की शुक्र है कि इनको हमारा ख्याल है।
I decided that we are going to do the very first 2 operation theatres of the cardiac surgery. So I decided to sponsor this project on my own, and that was our first project. my friend, Zaida Ahsanuddin, decided to do the ICU and the general ward, and for the rest of the unit, we collected money, and it came out to be so good.
Their contribution has been very significant. I mean, you obviously need to have very clean environment to work. You need to have clean environment to stay. You need clean environment for your patients. You need a good environment. Always has a very good impact on your morale.
It was a totally new feeling. We felt that हमने बहुत महसूस अपने अंदर एनर्जी महसूस की काम करने की कि अगर हमारे लिए इतना अच्छा एनवायरनमेंट में हो सकता है तो हमें भी और ज़्यादा अच्छे तरीके से मरीजों की खिदमत करनी चाहिए.
बहुत अच्छा अरेंजमेंट सारा है. एक रिस्पेक्ट वाला जो एलिमेंट है वो बहुत अच्छा लगता है. अपने घर से ज़्यादा इज्जत महसूस होती है यहाँ.
More people, more donors kept coming, they kept looking at our work and kept coming to do various works.
The Friends of Mayo has really done wonders now. They have done so many projects. 3 projects I am doing. North Medical Ward I have completed. The cancer ward that I am doing. And more people are now joining because they realize that instead of making separate hospitals, it is always good to do something in a government hospital because we have everything there.
We have a culture here that every patient is attended by many attendants. They are sleeping on the lawns and in the veranda and they take a cover. So we've been able to produce a rest house sort of a thing where they can rest. So that will create a nice environment in the hospital without the congestion.
This sort of Sakavana is going to be 2-3.
There are so many other wards and other departments which need to be upgraded.
And the next upcoming projects which we have already identified, the most important project is the burn unit, specifically for the PEDS, that is PEDS emergency, which will be connected to this burn unit and PEDS surgical ward. Then there is East Medical and ENT ward.
If you ask me that why should people give donation to the fund, I said because of the results achieved and the trust they have created in their mind and heart. So that's why people come and they willingly donate and donate in crores.
We are looking forward for more donors to make this hospital one of its kind. We are a platform where they all can put together their efforts and make this hospital a heaven for many poor patients who are getting treated. We started this.
Huge applause for the Friends of Mayo Hospital and Camcana for their efforts to again make a Mayo Hospital the place where the people prefer to get the treatment and health care. And lots of applause for the faculty who have done all this work selflessly throughout the years. Now I would like for the welcome address by the chairman of the organizing committee, our Pro Vice Chancellor, Professor Ijaz Hussain.
बिस्मिल्लाहिर्रहमानिर्रहीम. उस्तादों के उस्ताद जनाब प्रोफेसर लतीफ़ मलिक साहब, जनाब फजल इकबाल साहब, डॉक्टर असलम, माई क्लास फेलो डॉक्टर मोहम्मद फ़तेह शहजाद, डॉक्टर तविंदर गूगल, प्रोफेसर असद असलम खान, very senior alumni of King Edward Medical University, faculty members, dear students, ladies and gentlemen, on behalf of our worthy Vice Chancellor Professor Mahmood Ayaz Sahab and the organizing committee of 42nd Alumni International Symposium, I warmly welcome you all to this inaugural ceremony of this symposium. This event has become a regular event of the academic calendar of King Edward Medical University, and we are highly grateful to our alumni from US and UK that they make it possible. They come and make us wiser. They share their experience and knowledge. The scientific program of this seminar was designed in alignment with the academic objectives of CAMCANA, CAMCA UK and APNA. It covers a diversity of topics ranging from medical education to medical research, biomedical ethics, and from preventive medicine to robotic surgery. There were speaker presentations, interactive sessions, poster presentations, and panel discussions. And I hope that it would have benefited all level participants. Thank you very much, ladies and gentlemen, for joining us. Thank you.
Now I would like to invite President CAMCA UK, Dr. Tabinder Dugal, for her talk.
थैंक यू सारा। मैं कुछ ज़्यादा नहीं कहूँगी, कल से बहुत बोल लिया मैंने और सबसे बात भी काफ़ी हो गई है। ऑल आई वांट टू से इज़ दैट आई रिप्रेजेंट कैमका यूके एंड एज द फर्स्ट female chairperson of this organization, I would like to encourage ladies to come forward in leadership roles, क्योंकि इतनी ज़्यादा तादाद है अब that they are needed and they need to come forward and take up leadership roles, because they are leaders in the house, they raise the kids, and they should also take up leadership roles in the places of work. So that is one thing I wanted to talk about. The other thing is I wanted to thank all the people who have been so kind, VC Saab, Professor Ayaz, and my colleagues from North America, and the worthy guests that have come here, and my teacher, teacher professor the hamare, and you know, it's such an honor to be here and to be able to see all these people and interact with them. My organization is a relatively small organization. We have got about 500 to 600 members who are working in the UK, and anybody who wants to come and work in the UK, we are always there to be contacted. We try and do these activities, जो कि मेरे colleague हैं Dr. Athar Saeed, he does a couple of activities for improvement, quality care and improvement, and we are always here to collaborate. So these activities help us open up our minds and hearts to further collaborations. So we are always here for that, and we can be contacted through emails and phones, and we are always here to exchange those. कोई भी अगर कोई information चाहता है PLAB के बारे में या coming and working in the UK, we can help them, and also offer of help to anybody who wants to collaborate on anything that we can help with. So that's all I wanted to say, and also a couple of words about our charitable projects that we have done. We've done a charitable work in Huzdar, Balochistan, where we built some houses for the flood affected people, and we've also raised some money for insulin for children who are in the flood affected areas. So they are the couple of activities that we have done apart from what we did in Ramadan for the Ramzan ration scheme and all that. So it's a charity, CAMCA UK is a charity that continues to support people in Pakistan and also the educational activities. So thank you very much again for your kindness and hearing me out.
Thank you very much. Yesterday we have a wonderful session by CAMCA UK that was brilliantly organized in collaboration with King Edward Medical University, and Dr. Athar Ahmed Saeed is here, and there is a lot of applause for him. Thank you very much, Dr. Athar Ahmed Saeed. Now I would like to request the President CAMCANA, Dr. Fateh Shehzad, for a few words.
Bismillahirrahmanirrahim. Assalamu alaikum. MashaAllah, hall full hai. It's very happy to know that students are really interested in these programs. As President of Gymkhana, on behalf of members of Gymkhana, Board of Trustees and Executive Committee, I welcome guest of honor, chief guest, faculty of KEMU, my senior students and teachers, and the staff who makes these things happen. Also, I would like to welcome Fatima Fazal, who's worked with us very well in doing many projects, and Mr. Azhar Khan, who came on my request, although he's having knee pain and it's very hard for him to walk. I would like to thank VC Professor Mahmood Ayaz Sahib, Dr. Professor Saira Afzal Sahiba, organizing committee, staff of KEMU and Gymkhana for making this happen and for welcoming us and making us feel like at home. This is our home. As you all know, Gymkhana stands for King Edward Medical College Alumni Association of North America. Although KEMU is now university, it used to be King Edward Medical College. So we have kept this name for honoring the college and have not changed. Gymkhana is structured. There is 5 members Board of Trustees, then there's 4 members of Executive Committee, and there's 6 members of Council, and then various committees. Gymkhana does various projects in US as well as in various parts of Pakistan. Our special interest is in Mayo Hospital and KEMU. I would like to briefly show a few pictures and describe what Gymkhana has done for Mayo Hospital and KEMU. It's not to brag about Gymkhana, it's just to honor the donors who have donated their hard-earned money to improve conditions at Mayo Hospital as well as educational activities at KEMU. Gymkhana का जो मिशन है वो एक शेर में मैं अर्ज़ करता हूँ, और शेर अगर ख़राब हो जाए तो माइंड ना कीजिएगा। शिकवाए ज़ुल्मत शब से तो कहीं बेहतर था, शिकवाए ज़ुल्मत शब से तो कहीं बेहतर था, अपने हिस्से की कोई शम्मा जलाए जाते। थैंक यू। तो इस शेर का जो मैं मतलब समझा हूँ कि तनकीद ना करें, शिकायत ना करें, बल्कि जो आप काम कर सकते हैं पॉजिटिव वो करते जाएं और उम्मीद रखें कि सब इससे बेहतर होगा। नेक्स्ट स्लाइड प्लीज़। One of our program is scholarship program, which was established many years ago by our seniors. They collected funds and started endowment and started giving scholarships as well as loans. It started with 2 scholarships, and today we have various categories and various scholarships. As you can see on the slide, there are Thanks Scholarship, and that's run by Dr. Bashir Chaudhary and class of 1970. There are 220 scholarships which have been converted to tuition fee. This is an announcement I wanted to make on behalf of Thanks Scholarship Committee, that the funds they were utilizing for scholarships, they were underutilized, and now they will pay tuition fee of all first-year students coming to KEMU. With the goal of making King Edward Medical University tuition free, which will be first year, second year, third year, fourth year, final year. And it will cost $40,000 a year only for first year. If we go to 5 classes, 5 years, so it will be $200,000 a year. There is another Gymkhana need-based scholarship. There's 110 scholarship of 6,000 rupees a month, and that totals to $36,000 per year. There are Gymkhana Merit Award, which is given to students who have done research and exceptional educational performance. This is awarded to 2 graduates, $7,000 each, and that totals to $14,000. There is a loan program we do to postgraduate doctors who graduate and sometimes final year students who have planned to go to United States for residency and they need money for their USMLE steps, step 2 and step 2 and step 3, as well as for their matching fee and their travel to US. So we have given 39 loans and scholarship, each worth of $5,000, and that is $195,000. So the total amount awarded last year in 2022 was $285,000, which is equal to 63 million rupees, depending on the current value of rupee. For any scholarship program and loan program, we have a process. It is application, then there's a vetting of the application, then there's a personal interview, and then the scholarships and loans are awarded. Loans are to be returned starting from second year of residency, so we can give more loans to the upcoming residents. Now, one thing, especially the chair of the scholarship committee and loan committee requested to inform that those who cannot get into residency program, we do not demand return of loan. Next project we have is a Gymkhana computer lab. It's in the physiology biochemistry area. Gymkhana pays for all the expenses. There are 50 PCs and some printers, internet services. They are provided to the students and graduates of KEMU from Gymkhana donors. There's a Gymkhana Learning Center, which is again for KEMU students and graduates. There is a project in the anatomy department, Anatomy Learning Center, which is donated by class of 1980. Thanks to class of 1980 for donating their funds. Gymkhana is a visiting faculty program where academic staff in various universities in USA, they physically come and give lectures as well as lectures with a video link. We are going to sign an MOU to start some research work as well as more educational activities. 2 people are behind this project. One is Dr. Maqbool Ahmed, who donated $6 million to build Maqbool Ahmed Block. He talks to me on and off, and he requested to start educational and research activities, and we have determined to start that in his honor. And the second person who pushed me for that is Fatima Fazal, and we respect and we thank you. Various webinars are done. COVID is, alhamdulillah, over, but when the COVID was in its peak, we did webinar with staff and students and provided information as well as financial help with the personal equipment as well as some food items to the people who were not able to get out of their homes. I would like to mention again Maqbool Ahmed Balagh, and I would like to thank Dr. Asad Aslam. Without him, this was not possible. And Dr. Maqbool Ahmed, who is a graduate of, I believe, 1968, and he is a well-known ophthalmologist in US. He lives in state of Illinois. Very humble person, and he has donated his money for Maqbool Ahmed Balagh with only one goal, to have more educational research activity at KEMU and to have a better facility for the students of basic sciences. One of our Gymkhana member and KEMU graduate, Dr. Hussain, donated his fund to develop Hussain Advanced Skill Lab for the basic life support skills. Some of the smaller projects we do, pediatric unit, if they need any equipment, we have provided them by requesting donors, and with the help of professor and head of department of pediatrics, we are able to provide them ventilators, some equipment for the IV, as well as some incubators, thanks to the donors. We did raise some funds for Gymkhana flood drive. We are going to build 50 homes in various parts of Pakistan. I would like to mention one story about raising funds, that how generous our graduates are who are in US and other part of the world. We started fundraise on Facebook. One of our seniors, Dr. Chauhan, he called me. He said, "We're still living. Why are you raising funds on Facebook? Stop it, and whatever your goal is, I will pay for it." And he did write me a check for the remaining amount, which was $10,000. At the end, I would like to mention our late teachers, Dr. Hayat Zafar, Dr. Bilqis Jamal. Their three children are in US, Dr. Aisha Zafar, Dr. Saima Zafar, and Dr. Fawad Zafar. Dr. Fawad Zafar has done a tremendous job in providing corneas to Pakistani patients who cannot see. Up to date, there are 4,895 corneas provided to various parts in Pakistan. And this is all free of cost to the patient. There's Zafar Mir Foundation. Every year they give 32 scholarships and postgraduate loans, which are worth millions of dollars over the last decade. And I thank you in honor of your father. Thank you all.
Thank you very much. Such an overview of the charitable activities that have been done by Gymkhana, from scholarships to the healthcare delivery and Mayo Hospital, and today there would be the inauguration of the burn unit. Now I would like to call for the address by our worthy Vice Chancellor, Professor Mahmood Ayaz.
बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम। कल से आप मेरी स्पीचेस सुन के तंग आ गए होंगे, मॉर्निंग में, आफ्टरनून में, इवनिंग में, फिर रात को डिनर पे, सुबह लेक्चर, फिर लेक्चर। तो आई थिंक दैट It's time to show you a video about King Edward Medical University. So we'll just show you a video of King Edward Medical University. It will show you everything. Please. Lights off. Sound.
पाकिस्तान में तहजीब सकाफत का मरकज़ शहर लाहौर, जिसके हर बुर्ज, हर मीनारे तारीख के अनमें महफूज सफ़र, और इसी शहर लाहौर के पल में ये सफ़ेद मखमली इमारत, इसका दरवाज़ा खुलता है तो इल्म की राहें रोशन होती, तशनगार इल्म की उम्मीदों और उमंगों का महल, इसके दरो दीवार, इसके झरोखे, राहकारी और ये कवाड़ इसकी अजमत की गवाही, इसकी एक एक ईंट दास्तान वो है इन रोशन सिर्फ लोगों की, जिन्होंने इस मादरे इल्मी से अपनी प्यास बुझाई, इसे दुआ बख्शा और तारीख के उफ़क़ पर अपने ताबिंदा निशान हमेशा के लिए हम तिब्बी तालीम और तहक़ीक़ में अपनी मिसाल आप पाकिस्तान का सबसे मोतबर तिब्बी तालीमी इदारा किंग एडवर्ड मेडिकल यूनिवर्सिटी लाहौर।
किंग एडवर्ड मेडिकल यूनिवर्सिटी एक तिब्बी तारीखी इदारा है जिसकी पहचान आवाम का है। यहाँ के प्रोफेशनल्स न सिर्फ अपने अजीज बल्कि दुनिया भर में अपनी तालीमी और तिब्बी सलाहियतों को पुरकार लाते हुए दुखी इंसानियत की खिदमत की बदौलत इदारे को नुमायां हैसियत दिलवाने में कामयाब रही है। इदारे में मुसलसल बेहतरी का अमल जारी है, जो वाइस चांसलर प्रोफेसर महमूद अयाज की ज़ेर निगरानी नई मनाजिल तय कर रहा है।
1860 में लाहौर मेडिकल स्कूल के नाम से कायम होने वाला जनूबी एशिया में तिब्बी तदरीस का सबसे कदीम इदारा है, जिसके फारिग तहसील तलबा और तालिबात को 1868 में डब्लिन यूनिवर्सिटी के तलबा के बराबर करवा दिया। इस वक्त इस यूनिवर्सिटी के तकरीबन 20,000 से ज़्यादा फारिग तहसील तलबा दुनिया में हर बर्रे आज़म में तिब्बी तहक़ीक़, तदरीस और इलाज के ज़रिए इंसानियत की खिदमत करते हैं और अपनी मादर इल्मी का नाम रोशन कर रहे हैं। किंग एडवर्ड मेडिकल यूनिवर्सिटी लाहौर 54 से ज़ायद तिब्बी शोबाजात पर मुश्तमिल है, जिनमें बेसिक साइंसेस के 8, सर्जरी एंड एलाइड हेल्थ साइंसेस के 26 और मेडिकल एंड एलाइड हेल्थ साइंसेस के 16 शोबाजात के साथ साथ 4 मेजर नॉन टीचिंग शोबाजात भी शामिल हैं। किंग एडवर्ड मेडिकल यूनिवर्सिटी से लाहौर के 7 अस्पताल एफिलिएटेड हैं, जिसमें एशिया के सबसे बड़े अस्पताल मेयो अस्पताल समेत लेडी वेलिंगटन अस्पताल, लेडी एचिसन अस्पताल, गवर्नमेंट कोट ख्वाजा सईद अस्पताल, गवर्नमेंट सैयद मीठा अस्पताल, गवर्नमेंट नवाज शरीफ यकी गेट अस्पताल और गवर्नमेंट मियां मुंशी अस्पताल शामिल हैं। अस्पतालों के जरिए किंग एडवर्ड मेडिकल यूनिवर्सिटी अंदरून लाहौर की 100% और लाहौर शहर की 1/4 आबादी को तिब्बी खिदमात फराहम कर रही है। इसके साथ साथ 8 तिब्बी इदारे भी किंग एडवर्ड मेडिकल यूनिवर्सिटी के साथ मुंसलिक हैं, जिनमें कॉलेज ऑफ ऑप्थेल्मोलॉजी, कॉलेज ऑफ नर्सिंग, स्कूल ऑफ फिजियोथेरेपी, सेनेट सेंटर वगैरह शामिल हैं। इस इदारे के तलबा और असातिज़ा तिब्बी तालीम और तहक़ीक़ और खिदमत इंसानी में अपना एक अलग मुकाम रखते हैं। किंग एडवर्ड मेडिकल यूनिवर्सिटी से अब तक MBBS ग्रेजुएट्स के अलावा MDMS प्रोग्राम के जरिए 416 उम्मीदवार, जबकि MPhil के 164 और PhD के 10 उम्मीदवार पास आउट हो चुके हैं, जिसका क्रेडिट सरबराह शोबाए बायोमेडिकल साइंसेज प्रोफेसर रक्षक चौधरी को जाता है।
मुझे आपकी कायदाना सलाहियत के पूरे खिलाफ, मुझे आपकी काबिलियत के पूरे और मेरी इस चीज़ का इत्मीनान है कि दुनिया में जहाँ कहीं होंगे अपनी काबिलियत और अपनी इल्मी सलाहियत पर पूरा लम्हा मनवा लेंगे। और मैं चाहूँगा कि आप इस दुनिया में फैल जाएँ और जाके जितना ज़्यादा इल्म हासिल कर सकते हो इल्म हासिल करें, लेकिन एक शर्त के साथ कि वापस आप अपने इस दरसगाह में वापस आएंगे, यहाँ पे लोगों को मज़ीद तालीम देंगे और अपनी मालूम होने की खिदमत करेंगे। और मेरी तमाम तो दुआएँ और मेरी ख्वाहिशात हमेशा आपके साथ हैं।
बयान से लेकर आज तक इस इदारे ने इसके खिलाफ तिब्बी तालीमी के साथ साथ इंटरनेशनल रैंकिंग और आलमी तिब्बी इदारों के साथ इश्तराक में भी अपना नुमायां मुकाम बरकरार रखा है। HEC की QS रैंकिंग रिपोर्ट के मुताबिक किंग एडवर्ड मेडिकल यूनिवर्सिटी 2019 से 84 तक 90 स्कोर के साथ टॉप मेरिट ऑफ पाकिस्तान, इलावा वर्ल्ड यूनिवर्सिटी रियल इम्पैक्ट और हायर रैंकिंग में किंग एडवर्ड की नुमाया पोजीशन की। इस शानदार कारकर्दगी पर गवर्नर पंजाब की जानिब से वाइस चांसलर किंग एडवर्ड मेडिकल यूनिवर्सिटी प्रोफेसर महमूद अयाज को अवार्ड से भी नवाजा गया। यूनिवर्सिटी की ऑर्गेनाइजेशन के लिए 2013 में साबिक वाइस चांसलर प्रोफेसर फैसल मसूद मरहूम ने यूनिवर्सिटी में IT का शोबा कायम किया, जिसकी मदद से यूनिवर्सिटी में बिजनेस प्रोसेसेस को ऑटोमेट किया गया, जिनमें डिजिटल लाइब्रेरी, पेरोल मैनेजमेंट सिस्टम, बायोमेट्रिक अटेंडेंस सिस्टम और प्रोक्योरमेंट मैनेजमेंट सिस्टम शामिल हैं। गुज़िश्ता चंद बरसों में यूनिवर्सिटी के बहुत से प्रोजेक्ट पाए तकमील को पहुंचे, जिसमें 5 मंजिला कायद-ए-आज़म ब्लॉक का क़याम भी शामिल है, जो कि 600 सीटों के जिना ऑडिटोरियम, इम्तिहानी मरकज़, जदीद लाइब्रेरी और लेक्चर हॉल्स पर मुश्तमिल है। HEC और हुकूमत पंजाब के ताउन से किंग एडवर्ड मेडिकल यूनिवर्सिटी में 2 नए गर्ल्स हॉस्टल की तामीर की गई। इसी इदारे के फारिग तहसील किंग एडवर्ड के नुमाइंदे डॉक्टर मकबूल अहमद ने अपनी इस मादर इल्मी के लिए तकरीबन 2 अरब रुपए की लागत से 4 मंजिला आलीशान हदीद तर्ज तामीर से प्रोफेसर असद असलम खान जश्न आज़ादी की खुशियाँ हों, तिब्बी तालीमी सरपरस्ती या तलबा और तालिबात के तालीमी और इंतज़ामी मसाइल के हल के लिए वन विंडो ऑपरेशन के तहत स्टूडेंट्स फैसिलिटेशन सेंटर का क़याम इन तमाम तर कामयाबियों में वज़ीर सेहत पंजाब डॉक्टर यास्मीन राशिद की खुसूसी सरपरस्ती हासिल रही है। इदारे की रुकनाई का एक और काबिल सताइश कारनामा मस्जिद अबादीन का क़याम है, जिसे यूनिवर्सिटी की साबका प्रोफेसर तकिया सुल्तान आबादी ने 3 करोड़ की लागत से तामीर की। इस मस्जिद में ख़वातीन तलबा और साथिया के लिए अलहदा फ्लोर मंजूर किया गया। किंग एडवर्ड की काबिल फ़ख्र नुमाया शोबा तिब के अलावा सिविल सर्विसेज में भी अपना नुमाया मुकाम रखती है, जिसकी मिसाल बैरिस्टर नवीन अहमद अमान और डॉक्टर अहमद जावेद काजी, जिनकी अपनी इस मादर इल्मी के लिए खिदमात काबिल कदर है। कोविड-19 के दौरान किंग एडवर्ड मेडिकल यूनिवर्सिटी ने अवाम नास को मुफ्त तिब्बी सहूलियात की फराहमी यकीनी बनाने के लिए शोबा टेलीमेडिसिन का क़याम है, जिसमें साबका वाइस चांसलर KEMU प्रोफेसर खालिद मसूद गोंदर का किरदार काबिल कदर है। अब तक तकरीबन 20,000 मरीजों को हर जगह तिब्बी मुशावरत और इलाज की सहूलत फराहम की जा चुकी है। किंग एडवर्ड मेडिकल यूनिवर्सिटी के मौजूदा वाइस चांसलर प्रोफेसर डॉक्टर महमूद अयाज की जानिब से एक कलील अरसे में यूनिवर्सिटी के MD, MS और MDS के पोस्ट ग्रेजुएट तलबा के लिए ई-लॉग मॉनिटरिंग सिस्टम का कामयाब इजरा अमल में लाने के साथ साथ सिर्फ 2 माह से 8.8 मिलियन रुपए की लागत से इस इमारत को सोलर पैनल पर मुंतकिल कर दिया गया है, जिसका मकसद माहौल दोस्त तवानाई का फरोग और इदारे को बिजली में खुद कफील बनाना है। इसके अलावा पेशेंट रेफरल सिस्टम, कैंपस मैनेजमेंट सिस्टम, रिसर्च साइट और हाल ही एक्सपो सेंटर में किंग एडवर्ड की जानिब से की गई तिब्बी इजादात नुमाइश के लिए पेश की गई, जिनमें लैप्रोस्कोपिक सिमुलेटर्स, खुराक की कमी के शिकार नवज़ायदा बच्चों के लिए रेडी टू यूज फूड सप्लीमेंट, कैंपस मैनेजमेंट सिस्टम और टेली मेडिसिन सिस्टम शामिल हैं। मारूफ आलमी इदारों ने इस फूड सप्लीमेंट के फॉर्मूला की खरीदारी में गहरी दिलचस्पी का इज़हार किया है। वाइस चांसलर प्रोफेसर महमूद अयाज के विजन में इदारे की तारीखी विरसे की इसकी असल शक्ल में बहाली को यकीनी बनाया जा रहा है। कदीम इमारत पटियाला ब्लॉक में मौजूद लाइब्रेरी हॉल के तज़ीन व आराइश वॉल सिटी के इश्तराक और मारूफ माहिर तामीरात नैयर अली दादा की रहनुमाई में म्यूजिक हॉल और हॉल रोड हॉस्टल की तारीखी इमारत की इनकी असल शक्ल में बहाली और तज़ीन व आराइश के मंसूबे पर काम जारी है। हॉस्टल्स में मुकीम ज़ेर तहक़ीक़ डॉक्टर्स की ज़रूरत को मद्देनज़र रखते हुए 50 मिलियन रुपए की लागत से ओवरहेड ब्रिज की तामीर का अंतरिम आगाज हो रहा है। इलाहाबादी 320 एकड़ पर मुश्तमिल मुरीद के नारवाल रोड पर न्यू कैंपस का क़याम भी मुस्तक़बिल के मंसूबाजात में शामिल है, जहाँ पर 4 अज़ला के संगम में 1000 बेड्स पर मुश्तमिल मेरो अस्पताल 2 भी कायम किया जाएगा, जिसका TC1 मंजूर हो चुका है। तिब्बी तालीम के इस शानदार मरकज़ की बेमिसाल तालीमी रिवायात को आगे बढ़ाते हुए दुखी इंसानियत की खिदमत के नए मयारात कायम करते हैं, अपनी मादर इल्मी को दुनिया भर में अज़मत से सरफराज करते हैं।
Thank you very much for being patient to see this video. I just wanted to reassure my alumni that we'll follow your footsteps and will not be lagging behind. Thank you very much.
Thank you very much, sir. Now I would like to request the guest of honor, Professor Asad Aslam Khan, for his talk.
बिस्मिल्लाहिर्रहमानिर्रहीम। प्रोफेसर लतीफ़ मलिक साहब, डॉक्टर मदर चौधरी, प्रेसिडेंट कैमकाना, प्रेसिडेंट कैमका यूके, प्रोफेसर महमूद एजाज, वाइस चांसलर के मेडिकल यूनिवर्सिटी, प्रोफेसर इब्रार एंड महमूद शौकत साहब, रजिस्ट्रार, प्रो वाइस चांसलर, उस्ताद कराम, हाज़रीन महफ़िल, अस्सलाम वालेकुम। मैं ज़्यादा लंबी तकरीर नहीं करूँगा, लेकिन मेरे स्टूडेंट्स के लिए पैगाम है कि कभी आपने गौर किया है कि वाई एलमनाई फ्रॉम कैमका यूके एंड फ्रॉम कैमकाना दे कम बैक एवरी ईयर टू देयर alma mater. They have their practices there, they have their families there. They can go with their family for excursion trip somewhere, but no, they have passion for their alma mater. That's why they come every year to Pakistan to KE Medical University and College. मेरा सिर्फ आप लोगों को स्टूडेंट को ये पैगाम है कि हम 5 साल यहाँ गुजारते हैं किंग एडवर्ड में और 1 साल गुजारते हैं हाउस जॉब का। ये 6 साल हमारी ज़िंदगी पर मुहित रहते हैं। मैंने आज तक किसी नॉर्थ अमेरिका में, पूरे यूरोप में, मिडल ईस्ट में, पाकिस्तान में कोई भी किंग एडवर्ड का अलमनाई ऐसा नहीं देखा जिसके दिल में ये पैशन ना हो कि मुझे अल्लाह ताला कोई वसाइल अता फरमाए कि मैं अपने अल्मा मैटर को पे बैक कर सकूं। तो मेरी आपसे ये नसीहत है, मेरी आपको एडवाइस है कि 5 साल गुजर जाएंगे, हाउस जॉब कर देंगे, वेर एवर यू गो नेवर फॉरगेट योर अल्मा मैटर। With every minute you think how to pay back your alma mater. और उसके लिए हम कैमकाना, शुरू में तो कैमकाना बनी और जिस तरीके से उन्होंने ये मसाइल कायम की कि किस तरह अपने मादरे इल्मी को पे बैक करना है, वो अनप्रेसिडेंटल है। उसके बाद कैमका यूके आया और जिस तरीके से जो वो अपने मादरे इल्मी को पे बैक कर रहे हैं वो भी काबिल तकलीफ है। यहाँ पर मैं एक मिसाल दूंगा डॉक्टर मकबूल अहमद साहब की। 1968 के ग्रेजुएट हैं, ऑप्थल्मोलॉजिस्ट हैं, यूनाइटेड स्टेट्स में 21 सेंटर रन करते हैं ऑप्थल्मोलॉजी के, 21 सेंटर। लेकिन ही 72 ईयर्स नाउ। लेकिन 2010 में जब मैं वाइस चांसलर था तब मुझे उन्होंने कहा कि मेरा दिल करता है कि मैं कुछ पे बैक कर दूं, लेकिन मेरी शर्त ये है कि मैं अकेला करूंगा जो कुछ करूंगा। मैंने कहा जी आप एक हमारा फार्माकोलॉजी डिपार्टमेंट है, बहुत पुराना हो चुका है, उसको हम ऊपर मंजिलें भी नहीं बना सकते, कुछ भी नहीं कर सकते, तो आप यहाँ पर एक मल्टी स्टोरी बिल्डिंग बना दें। उन्होंने कहा ठीक है, लेकिन मेरी शर्त ये है कि मेरी ख्वाहिश ये है कि केई का स्टूडेंट अगर यूएसए और यूके का स्टूडेंट एक अच्छी कुर्सी पर बैठ के, एक अच्छी लेबॉर्ट्री में बैठ के तालीम हासिल कर सकता है, तो वाई नॉट केई का स्टूडेंट एक अच्छे ऑडिटोरियम में, अच्छे क्लासरूम में, अच्छी लैब में, अच्छे डेमोस्ट्रेशन रूम में, अच्छी लॉबी में क्यों नहीं बैठ सकता। तो मेरी ख्वाहिश है कि आप 6 मुल्कों को विज़िट करें और उसका डिज़ाइन ऐसा बनाएं कि पाकिस्तान का कोई भी इदारा, आप लम्स हो, आगा खान को हम प्रेफरेंस बनाते हैं ना, वहाँ पर बड़ी फैसिलिटीज़ हैं, लेकिन इस मकबूल अहमद ब्लॉक बनाने के लिए वाशिंगटन यूनिवर्सिटी, सेंट लुइस, यूनिवर्सिटी ऑफ सेंट्रल फ्लोरिडा, डबलिन यूनिवर्सिटी, मैकमास्टर यूनिवर्सिटी, यॉर्क यूनिवर्सिटी, टोरंटो यूनिवर्सिटी, 6 इदारों का विज़िट किया गया, इसका डिज़ाइन बनाया गया। मकसद ये था कि ये बिल्डिंग किंग एडवर्ड के शायान शान होनी चाहिए, ये बिल्डिंग किंग एडवर्ड के स्टूडेंट्स के शायान शान होनी चाहिए, उनकी भी लेवल किसी तरह भी किसी भी USA, UK के किसी भी तालिब इल्म से कम नहीं है, और उनकी ख्वाहिश थी कि मैंने अकेला करना है, और उन्होंने 1 अरब और 50 करोड़ रुपए से इसको कंसल्ट कराया, और अभी भी उनकी ख्वाहिश है कि कुछ और कराना है तो इसके लिए करवा लें। यहाँ पर मैं फ्रेंड ऑफ मेयो का जिक्र करना ना करूँ तो बड़ी मुझसे गुस्ताखी होगी। जितना हम जो पैथेटिक कंडीशन था मेयो हॉस्पिटल की, यहाँ पर MS मेयो हॉस्पिटल भी बैठे हैं, मैं उनको भी खुशामदीद कर दूँ, वो भी माशाल्लाह बड़े अच्छे दिल लगा के और मेहनत से काम कर रहे हैं। लेकिन मीर साहब जो हालत थी कि मेयो हॉस्पिटल की, आप यकीन करें अगर जो फ्रेंड्स ऑफ मेयो मिसिस फातिमा फजल और मिसिस अम्बरीन इरफान, आज मैंने नई थाम नहीं ली, अगर ये सामने ना आए, और नईर अली दादा साहब, पीर साहब, जिन्होंने इसको अपना घर समझा और हर वार्ड को उन्होंने, आप देख लें नॉर्थ मेडिकल बना, आप ईस्ट मेडिकल को देख लें, आप साउथ मेडिकल को देख लें, नॉर्थ सर्जिकल को देख लें, बड़ी वार्ड की एंट्रेंस देख लें, मुसाफिर खाना देख लें, अब पीडियाट्रिक सर्जरी का बर्न यूनिट और इंटेंसिव केयर यूनिट। तो वी आर ग्रेटफुल टू फ्रेंड्स ऑफ मेयो कि आपने इसको अपना घर समझा, और जिस तरह अपने घर का ख्याल रख रहे हैं, इस तरह आप मेयो हॉस्पिटल का ख्याल रख रहे हैं। तो मैं 1985 का ग्रेजुएट हूँ, 44 ईयर्स अनइंटरप्टेड मेरे यहाँ पर गुजरे हैं, 1 सेकंड के लिए मैं यहाँ से बाहर नहीं गया। तो मेरी वाइस चांसलर साहब से गुजारिश है कि आप प्लीज़ कोई प्लान बनाएं कि हम जितने भी दुनिया में जितने हमारे अलमनाई हैं, हम इनको इन्वॉल्व करें, और ताकि जहाँ पर कोई कमी ना रहे। हमारी ख्वाहिश है कि यहाँ पर कोई कमी ना रहे, इस अदारे का तालिब इल्म महसूस ना करे कि मुझे यहाँ चीज़ नहीं मिल रही। विद ऑल दिस रिमार्क्स आई एम ग्रेटफुल टू कैमका UK and National Alumni for your precious time. Thank you very much.
Thank you very much. Now I would like to request the chief guest, Dr. Mazhar Iqbal Chaudhary, for his words.
Bismillahirrahmanirrahim. Thank you very much, Vice Chancellor, Professor Ayaz, and the faculty who has invited me as a chief guest on this very auspicious gathering of doctors, consultants, our alumni, and the students of the King Edward Medical College. Sir, it's a great honor, and coming back to your alma mater is always a pleasant experience, soul searching and finding your identity. And I'm happy to see that over the years, the facilities have improved, the infrastructure has improved many times. I am the class fellow of Professor Asad Aslam, and we spent from 80 to 85, remained the student of this university. And the university and the Mayo Hospital was in a miserable condition at that time. The building was deteriorating, the infrastructure is absolutely coming down. And then I have the honor to be the teacher and served the Mayo Hospital and King Edward Medical College as an assistant professor, and worked as a registrar, senior registrar and the assistant professor in Mayo Hospital. Sir, two things are very important I must want to say, and coming to the politics, and now I am also the legislator and the member of Provincial Assembly, and belong to Pakistan Muslim League Nawaz group of political party. We believe in the hard work. Our leader Shahbaz Sharif, as you know, always believe in the improving the things. So two things I want to emphasize here is that first of all, हम जितनी भी तरक्की करते जाएं, जितना भी हम इम्प्रूव करते जाएं, लेकिन जो असल कॉज है, द मदर ऑफ ऑल इविल्स, हम उसको यहाँ पर रियलाइज़ नहीं कर रहे. दैट इज़ आवर पॉपुलेशन जो हमारी बढ़ रही है इस मुल्क की, वो 2.1% की ग्रोथ रेट से बढ़ रही है. फर्टिलिटी रेट ऑलमोस्ट 5-6 है. तो इतनी रैपिडली ग्रोइंग पॉपुलेशन में हम ये सारा कुछ इम्प्रूव कर रहे हैं ओवर द ईयर्स. میں یہ کبھی بھی نہیں کہوں گا کہ ہم نے امپروو نہیں کیا. پاکستان ہیز امپرووڈ اے لاٹ. ہم اپنی اگر اسٹوڈنٹ لائف سے دیکھیں کہ یہاں پر مزربل لیبز ہوتی تھیں اور وارڈز بالکل ڈیٹیریٹ ہو چکے تھے, اور اب آج الحمدللہ جب ہم اپنے البم میٹر میں آتے ہیں تو وی فیل پراؤڈ آف اٹ کہ ایوری تھنگ از امپرووڈ. اور جو ہے لیکن ہم یعنی اس پاپولیشن گروتھ ریٹ کے ساتھ کیسے ساری جو ہے وہ ان چیزوں کو جو ہے وہ اس پیس کو پکڑ سکیں گے. اتنا انفراسٹرکچر, اتنے اسکولز, اتنی جو ہیں یونیورسٹیز, اتنے روڈز, اتنے گھر, ان چیزوں کو ہم نہیں میٹ کر سکتے. تو بینگ اے ڈاکٹر, میری یہاں پہ اسٹوڈنٹس بھی بیٹھے ہیں, میرے کولیگز بھی بیٹھے ہیں, ٹیچرس بھی بیٹھے ہیں. وی بینگ دا ڈاکٹر, ہم نے پاپولیشن جو ہے گروتھ ریٹ کو اور فیملی پلاننگ کو اور پاپولیشن کنٹرول کو جو ہے وہ ہر سطح پہ ایمفسائز کرنا ہے اور اس کو اچیو کرنا ہے. اور اس کے لیے جو ہے وہ ہمیں محنت کرنی چاہیے, اور اسپیشلی آل یعنی جہاں پر بھی ہم کر سکیں. دوسرا جو ہے وہ ہمارا ملک اس وقت کلائمیٹ چینج ولنریبلٹی میں بھی سب سے اوپر ہے, اور اس کے ساتھ جو ہے وہ آپ نے دیکھا ہوگا کہ فلڈز نے کتنا جو ہے اس دفعہ میرا خیال ہے سب سے بڑا فلڈ پاکستان میں آیا ہے. ہسٹری میں اتنا بڑا نہیں آیا کہ 1/3 آف دا پاپولیشن از ڈسپلیس, پیپل آر ہوم لیس, لائف اسٹاک از فنشڈ, اور لوگ جو ہے پریگننٹ وومنس آر آن دا روڈ. اور یہ ساری چیزیں جو ہیں یہ جب تک ہم ان چیزوں کو کنٹرول نہیں کریں گے ہم اپنے ڈیولپمنٹ گولز کو پورا نہیں کر سکتے. تو کیمکا اور UK کیمکانا اپنا بڑی پریسٹیجیس جو ہے ہماری آرگنائزیشنز ہیں الومنائی کی, اور انہوں نے بہت زیادہ ہمیں کنٹریبیوٹ کیا ہے. لیکن ہمیں یہ بھی سوچنا چاہیے کہ جو ہمارے بچے باہر جا رہے ہیں ان کے لیے واپس آنے کا ماحول پیدا کرنا بھی ہمارا سب سے بڑا فرض ہے, کہ ہم اپنی یونیورسٹیز کو, اپنے کالجز کی ورکنگ ایٹماسفیئر کو, ان کی جو ہے سروس اسٹرکچر کو اتنا بہتر کریں کہ وہ واپس اپنے ملک میں آئیں اور آ کر یہاں پر وہ جو ہے سرو بھی کریں, نہ صرف ہر سال آئیں اور آ کر یہاں پر ڈونیشنز دیں اور اپنا جو ہے, بلکہ ان کے بچے اور وہ خود اور ہمارے جو بچے باہر جا رہے ہیں وہ بھی اپنے ملک میں ٹریننگ کے بعد واپس آئیں. یہ ہمارے اسٹوڈنٹس سرمایہ ہیں, ہمارا جو برین ڈرین ہو رہا ہے اس کو روکنا بھی ہمارا فرض ہے. یہ بہت امپورٹنٹ ہے ہمارے لیے کہ اس پر بھی ہمیں کام کرنا چاہیے. اور اسپیشلی جو لیجسلیشن کے حوالے سے, بینگ دا ممبر آف دا پروونشل اسمبلی, میں نے ہمیشہ کوشش کی ہے کہ اپنا انپٹ جو ہے وہ لیجسلیشن میں دوں. بے شک وہ MTI ایکٹ ہو, بے شک وہ ہیلتھ کیئر کمیشن کی جو ہے ریسٹرکچرنگ ہو, اور جو ہے یہ ہمارا یونیورسل ہیلتھ سسٹم جو اب شروع ہے اس میں بھی کوشش ہوتی ہے کہ ہر طرح کی جو ہے وہ پازیٹیو انپٹ دی جائے تاکہ یہ چیزیں جو ہیں وہ مزید امپروو کریں اور ہم اپنا جو ہے اپنے جو ورک فورس ہے اسپیشلی اس کو جو ہے وہ بہتر سے بہتر کر سکیں. مجھے سب سے زیادہ خوشی جو ہوئی ہے وہ یہاں پر فاطمہ فضل صاحبہ اور فاطمہ فرٹیلائزرز نے جو انپٹ دی ہے, ہمارے جو ہے lot of work I have been seeing it, or especially this pediatric burn unit. I tell you, this is such an important work you have done. I have experienced and I have passed through this havoc experience of my own son who has burnt himself a few years back, and there was no place in Pakistan to take my own son for the treatment. And this Janab burn unit came afterwards, and now this pediatric burn unit is very important because that is the age group where the children are vulnerable to burn, and there is no available facility in the Pakistan. And even abroad, you see, it becomes very difficult. In the Middle East, and nowhere such facility exists, especially in the public sector where you can get the free treatment. And I advise you to please collaborate with some burn units abroad, and I am ready to help you out in this regard because I have the experience of treating my own children in USA, because I have to take him on air ambulance to USA, and they are a very good organization, Shriners group of hospitals and the pediatric hospitals, the pediatric burn units. has saved my son. And now, alhamdulillah, he is a resident of surgery in USA, and you see in the second year of surgery. So we must get the franchise or the collaboration of some burn unit abroad. So they bring us the expertise, they train us, they give us all the software and the treatment plans for this burn unit, which we have built to the state-of-the-art level. Thank you very much, and we need. Thank you once again, Kemkana, Kemka UK, Apna, and 107 delegates are here. I am really surprised to learn this. Dr. Fateh Shahzad, my old UC junior, is as a president of Kemkana, and UK Kemka is a new entry into this institution because you see Kemka UK I think has been formed later on, maybe 30 years, but not very active now. It's active, and it's very good that they are also here, and people from Australia and other countries are also here. So it's a very good experience to be here. I am really honored, and thank you very much.
Thank you very much. Now I would like to request the chief guest, the guest of honor, the presidents of Kemkana, both presidents, president of 2021 as well as of 22, and the president Kemka UK to please come forward. We have to distribute certain awards. Everybody. Kemkana Hamdani Research Award. The first category is the undergraduate category, and I would start with the winner 4. Next, undergraduate student research award, and the winner 4 is Morish Fatima, 4th year MBBS. Morish Fatima. She has also displayed her poster, and after this award ceremony, I would request all the vice chancellors, principals, chief guests, guest of honors, and the senior professors, please visit those posters that are present in the corridors of the library hall. The next prize is for Huzaifa Ahmed Chima. He is from final year. Morish Fatima. Huzaifa Ahmed Chima, final year. Abia Shahid, final year. And Qasim Mahmood, final year. For the postgraduate category, the third now for the postgraduate category, the third position goes to Dr. Khansa Junaid, Department of Community Medicine. The second position goes to Dr. Ambar Arshad, Postgraduate Resident, Department of Community Medicine. And both have more than 90 impact factor. And the third prize goes to Dr. Mariam Ayub. She is the resident of Department of Psychiatry. All these 3 students have more than 90 impact factor, that is calculated by Thomson Reuters. So very well done. There are certain sheets from Camcana. First is for Dr. Tabinda Dugal. I would request the President Camcana, Dr. Fateh Shehzad, to please give the sheet to Dr. Tabinda Dugal. Next is for Dr. Attar Ahmed Saeed from Camca, UK. Next is for the chair of CAB Camcana, Dr. Muhammad Aslam. Thank you very much, sir, for all this hard work that we are having such a populated academic activity. Dr. Arshad Rehan, Ms. Fatima Fazal, Mrs. Fatima Fazal. For the Chairman Organizing Committee, the Pro Vice Chancellor King Edward Medical University, Professor Dr. Ijaz Hussain. Professor Dr. Muhammad Saqib Saeed, Advisor to the committee, Dr. Riyasat Ali. Professor Syed Asghar Naqi, Secretary Organizing Committee, Professor S.N. Oman, Professor Ibrar Ashraf Ali, Professor Muhammad Harun Hamid, Professor Mustahsan Rashid, Dr. Munib Ashraf, I would like to request our Vice Chancellor, Professor Dr. Mahmood Ayaz, to please give the shade to the guest of honor, Professor Asad Aslam Khan. Dr. Fateh Shehzad, President Camcana. Dr. Irfan Munir, President-elect Camcana. बात करेंगे डायरेक्टली स्टार्ट करते डॉक्टर फवाद करीम, Chairman Transport and Accommodation Committee, Dr. Bilal Aziz, Mr. Fazal Elahi Bilal from Registrar Office, Mr. Tariq Irfan, Mr. Muhammad Shafiq, Mr. Qasim Amin, Mr. Ashar Hussain, Dr. Salman Kazmi, Mr. Qasim Amin, Mr. Ashar Hussain, Muhammad Ijaz Afzal, Mr. Badrul Hassan, Mr. Farooq Javed, Muhammad Afzal, Mohsin Hafiz, Muhammad Rashid Javed, and Dr. Ramsha Khan. Now I would like to request our Vice Chancellor to present the shield to the Chief Guest, Dr. Mazhar Iqbal Chaudhary. I would like to request all the presidents to present a shield to our worthy Vice Chancellor, Professor Mahmood Ayaz. President Camcana 2022, Dr. Fateh Shehzad. 2021, Dr. Muhammad Aslam. Chairperson, Camca UK. Our chief guests, guest of honors and senior professors. We are so glad that you have joined us today. Thank you very much. The words are never enough to say gratitude to all the efforts that have been made. It is not a 1 day or 2 day activity. Actually, there is a whole hard work, commitment and dedication that spans over more than 6 months. Continuous phone calls from the Camca UK, Camcana, Apna, and after this session, we would have refreshments, so please proceed for the refreshments. And before that, I would request all the senior professors, vice chancellors, our chief guest, guest of honor, to please have a round for the poster exhibition and then proceed for the refreshments. And all the students, please keep sitting. I have few very important announcements for you. And after this, we would have 2 sessions. One is the surgery and light, other is the medicine and light. And 3 of our speakers would be adjusted in surgery and light session, and other 3 would be adjusted in medicine and light session. So we would complete all these speakers speakers who are being scheduled for today's
that can be repaired, because the results of repairing an aneurysm in an elective setting is far better than what it would be in an emergency. Because if someone comes in with a ruptured aneurysm, there's a risk that about 90% of the people who will have a rupture will die. Only 10% will reach to the hospital. So that's how grim the situation is, and that's where the ambulance service is very good. And we know how bad the situation can be in countries where the ambulance services are not very up to date. Those who make to the hospital, those 10%, only 50% survive the operation, and 50% die. So the stakes are all stacked up against you. So all these index procedures that I've talked to you about, these are really, really crucial, critical conditions for which specialists are needed. And for that reason, centralization has happened in UK and almost all of the West at the moment. So by centralization, I mean you cannot just have one surgeon working in a department and say that this person can offer you the best service with acceptable surgical outcomes in a department. You need to have a group of surgeons, because the vascular surgery emergency can happen anytime. You need to have a certain number of surgeons who can be on call, and you can't make them work 48 hours at a stretch. So this is all important, and the centralization also makes you have the best anesthetist, the best intensivist, the best sonographers in one place under one roof. So this is the concept of having a specialist healthcare service which is centralized to one place. And Mayo Hospital is absolutely an amazing place to have such a healthcare setup, because it's a university hospital, and I think it's well set for that. And the whole idea is to improve the care and outcomes of the patients. So this is a very important graph which I think will, I'm trying to convince you that how centralization helps here. So you see, here you are seeing the adjusted operative mortality and looking at the annual surgeon volume. So you see where the surgeons are operating more than a certain number of cases, like in carotid endarterectomy, where they have done more than 40 carotids in 1 year. The operative mortality is half of what it is if it's less than 18. So the more you operate, the less is your mortality, and the more safe surgeon you are. If you look on the other side, this is how much a hospital volume is. You see the hospital volume also has got a similar impact. So a large number of patients come to a hospital, they get the best service, their operative mortality goes down. This is only possible if you have the right people in a group, in a department, in a hospital, where all these people are present. So what is required to have a vascular surgery unit? I'm sure anyone can guess that, but I've just enumerated it here. It's an indicative template, and you can modify it according to your wishes. So you need to have vascular surgeons who can operate with acceptable safety margins, and they should be trained vascular surgeons. Vascular interventional radiologists who can help the vascular surgeons, because now most of these operations have become endovascular. You need vascular anesthetists and intensivists, because the vascular patients are the most crumbly patients. They have got ischemic heart disease, they've got renal impairment, they've got COPD because they're smokers. So they need to be optimized. So you need to have all these essentials there to have a safe operation for these patients. You need to have vascular specialist nurses who can do the surveillance for AAA, the smaller aneurysms. The bypass grafts that you do, they can do the surveillance for that. They can do the wound care. A surgeon doesn't need to look at a wound. It's a job of a vascular nurse, not a surgeon. It's a waste of time of a surgeon. Heart clinics can be led by a vascular specialist nurse, and if they need some input, they can ask a vascular surgeon to come in and have a look. The vascular sonographers are very important in all of this, because they're the ones who run all the duplex imaging. A radiologist does not do duplex imaging. They do better things like doing CT scans, MR scans, PET scans. So you need vascular sonographers. And then you need MDTs, and you need a hybrid theater where open and endovascular surgery can be done together. So when you have all these essentials, which are not that difficult to find, then you implement these international guidelines, you do quality improvement projects or audits, and you see how your practice is comparing with the acceptable outcomes internationally. And this is a very simple exercise, it's not rocket science. if we look at what is the minimum number of vascular surgeons which is required in a population, it is about one vascular surgeon for 100,000 population. And this is in UK. The number of people that have got vascular disease in Pakistan is far more than what we see in UK. And how many vascular surgeons do we have in Pakistan or in Lahore? Perhaps one or perhaps no one. So you have to think about it very carefully, where we are standing and where the world is heading to. And you need to have an on-call rota of at least 1 in 6 vascular surgery consultants to run this whole service. Because you can't just load everything on one person and then let him deliver. It's not going to happen. So the title of my talk was Occam's razor. What does that really mean? It means that the things which are very simple, you shouldn't make them complex beyond necessity. It's a simple concept. We have all the evidence, we have all the guidelines, we have a pathway which is there to follow. So what do we need? We need a will of someone to implement it. It's very simple. And I think there's high time, I think, for the paradigm shift to occur. And I do acknowledge that change is always difficult and is always resisted. And when vascular surgery was separating from general surgery in UK and I was there, it was more like a professional divorce. And it was a very painful experience for the general surgeons to let go of vascular surgery. But it's history now, and history only remembers what is being done for the betterment of the patients. And that's what is the purpose of us working as healthcare professionals. So what are the potential barriers that we see in bringing about this change? And this is something which I have basically taken up from China because I'm an adjunct director of a research institute there. And this is something which they told me that they were facing about 20, 30 years ago, that there was a lack of will of people who were indigenous. They did not want to let go of certain things which they were doing for decades. There were some ego problems, there was territorialism, they were feeling threatened. But then what made a change? It was the government. They were very heavy-handed, they used an iron will, and that was the end of all the disputes. And I think all the reservations and opposition is a matter of history now. So vascular surgery is a fully developed specialty in all of these countries now. I think I'll leave this talk with this final verse, which Imam Jafar mentioned in his book. The servants of the merciful are those who walk on the earth in humbleness. And when the ignorant address them, they say peace. So I think this is very much relevant because whenever there is a message for change, there's always a resistance because people always think of what they're doing is right. But if you want to change, you have to stay humble. You have to accept what the truth is. And this is in the Quran, and this is what one of the greatest religious scholars also tells us as well. And this is the last slide that I'll leave before I finish my talk. I thank you for your attention.
Thank you very much for the excellent talk. And there was a fallacy. The students said that आपने सुनना है, चुप करके बैठे नहीं तो बाहर चले जाओ. Please leave. If you want to listen, you listen. Otherwise, you please leave the hall. When we were in our training years, we were told that Pakistan as a country does not have many vascular diseases and it's a disease of the West. And now with the epidemic of diabetes that we have, if you visit the surgical wards in Mayo Hospital, at any given time you will have more than 40% of the patients with diabetes and its complications in surgical wards, having large wounds and amputations starting from a toe and ending up above knee, and then bilateral amputations as everybody talked about. So having a department of vascular surgery is a real time need for, I think, all of the hospitals of this city at least. And Mayo can take lead with your help, inshallah. Thank you so much. Our next speaker is Professor Dr. Mary Nassar, the Professor of Gynecology, and she's going to talk about factors affecting post-placement IUCD insertion rates.
नहीं मैंने अंदर दिया है उनको, यहाँ पे एंटर कराया. एंटर करा के आई मेहरुन निसा ये इधर ऊपर रखा है जी अस्सलाम वालेकुम dear audience. I am Professor Dr. Mehrun Nisa, Head of Department of Obstetrics and Gynecology, Lady Aitchison Hospital. We have seen that in the last 2 days, so many programs, it is observed that the difficulties in managing different programs and their implementation is a gross difference between the population and the available resources. There is population explosion and scarce resources, the management of which the alumni from different countries, UK and different social organizations are here to help us out. But what about population explosion? जब बात फैमिली प्लानिंग की होती है या आबादी कंट्रोल नहीं हो रही, me as gynecologist feel something in my heart that I am responsible as gynecologist why our population is not being controlled. So different factors, it is a multifactorial problem and a lot of researches are going on national and international level, and especially in the African and Asian poor countries, developing countries, the programs are implemented but their failure rate is high and still population explosion is there. With this perspective, I have written this article and which was published in 2021 in this journal Biomedica. The immensely increasing rate of population is one of the biggest hindrances in the progress of underdeveloping world, including Pakistan. इस वक्त पाकिस्तान की आबादी 22 करोड़ से ज़्यादा है और among the sustained millennium development goals, one of the most important goal set was to reduce maternal mortality less than 70 per 100,000 live births. To start with, WHO and this Millennium Development Goal was set from 1990 to 2015. The goals were set to reduce maternal and perinatal mortalities. These goals were achieved in developed world, but the underdeveloping world of Africa and Asia, these goals were not met. And then sustained Millennium Development Goals till 2030 are set up to achieve these goals, especially in underdeveloping world of Africa and Asia, including Pakistan. One of the most important steps to improve maternal child health is provision of an effective, long-active contraception. Different researches were carried out once the Millennium Development Goals failed, and it is observed that yes, in the African and Asian countries, ladies after delivery go and they come back with another pregnancy. in spite of all the available method, including intrauterine contraceptive device. So what should be done? So post-placental IUCD we place the IUCD immediately after delivery of the placenta. So the female is protected at that time, and at least 5 years she is protected. So keeping these challenges into consideration, program of this PPIUCD was launched in tertiary care hospitals. PPIUCD was approved and including in the WHO eligibility criteria for contraception, and in Pakistan it was introduced in 2012, and it was supported by different agencies like USAID, Green Star, etc. In our institution where I was working, Government Teaching Hospital Shadra at that time, it was being run by the help of National Committee of Maternal Neonatal Health, and it was started over there in July 2019. As the program was, we were monitoring it, and all the data, all the record was being kept. So we decided to have a study on this program. Different factors affect PPIUCD insertion rate, because we were already inserting interval IUCD, but the programs were not successful. So I was thinking, what are the factors? And each one of you, why our programs are failing? So these are patient factors, there are factors associated with healthcare professionals, the doctors, the nurses who are actually delivering the mothers, and they are responsible to keep these IUCDs. But why they are failing? Availability of trained birth attendant. Nurses and doctors, they should be trained to how to place these IUCDs. Presence of a trained counselor. This was something addition in our program when we started over there, because normally routine mein hamare paas counselor nahi hota, and this was again provided by National Committee of Maternal Neonatal Health Organization. And general factor like we started in July 2019 and then monitored this program till September 2020. So COVID came in between, COVID era. So that was another factor. स्टार्ट में तो हमारा ये फैक्टर एडेड नहीं था, लेकिन जब ये स्टार्ट हुआ और द डाटा हमारा मॉडिफाई हुआ, द चेंजेस वी ऑब्जर्व कि ये प्रॉब्लम्स अब आ रहे हैं, तो हमने उसको भी एज अ फैक्टर कंसिडर करना शुरू किया और उसको भी हमने डाटा में डाला. Objective of this study was to explore the factor affecting post-placental IUCD insertion rate, and this study was, IUCD placed in the uterus. It, prevents implantation of fertilized ovum, and the copper ions, they kill the sperms as well. In this way, it is contraceptive, and setting as Government Teaching Hospital Shadra attached with Fatima Jinnah Medical University Lahore. This study was intervention study, a semi-experimental. The intervention was the presence of this trained counselor, which routinely is not there, although so many other factors were there, but this was something new and we taken in this study as the intervention. Over 15 months, July 2019 to September 2020, a total of 4,474 patients were inducted, and a trained counselor was there to counsel them. And all the details were entered into a pro forma, and parallel workshops were conducted to train our doctors and nurses how to place PPIUCD. Results: 3,292 participants qualified for the insertion, out of which 802 female consented, and PPIUCD insertion rate overall during this period was 24.36. The results, table 1 shows, you can see that in the normal vaginal delivery, the rate was 36%, and C-section it was 12%. And you can see this is the overall from July 2019, September to the overall trend you can see. When started, program, it was 10% and it rose to 31% in November. And with the onset of pandemic, COVID, it fell down to 10% in June when it was in peak. And again it rose to 33% and overall was 24.36%. Counseling, 30% pre-counseling, the rate was very less, and when this post-counseling with this by this trained counselor, it rose to 70%. And these are different factors. I already mentioned patient properly counseled, the rate was recorded 25%. Presence of trained birth attendant, the doctors, the nurses who were trained through workshops, a little rise was seen, 6.7%. With the presence of this trained counselor who was working in OPDs, antenatal clinics, antenatal wards, labor room, this rose to 35%, and COVID-19 9.2. So different studies showed rates as low as 8 to 50% because of differences in the factors. We concluded in our study, keeping the rest of the factors balanced, the main factor remained presence of a trained counselor. So implementation, trained counselor must be appointed in our setting. We should counsel the patient as well as the healthcare professional, because the healthcare professional, they say, in overcrowded environment, we don't have time to counsel the patients and place the IUCDs. So this is very important. Thank you so much.
Thank you so much. If we have a question, so I request the audience to have a question with Professor Mehrunisa.
Yes, please.
Right, ma'am. Thank you so much. So next presentation is on the what can be the cost of sacrificing pronator teres muscles in mid-diaphyseal fractures of radius, and the presentation is going to be given by Dr. Faisal Masood. He is the head of the Department of Orthopedic Surgery in King Edward Medical University. Professor Faisal Masood.
May I take this, may I have this permission by the chair to invite the students on the front chair, sir? Okay, Professor Sarnaki has given the permission. All the students, please come to the front chairs. आप आगे आ जाओ. Especially जो बच्चे बिल्कुल दीवार के साथ बैठे हुए हैं, please come forward. ये सारी सीट्स आपके लिए ही हैं. और आगे आ जाओ. Girls, you are also invited to come on the front rows. Please sit in the front rows. Dr. Rishpa, would you please guide them? Thank you. Osama, please guide the students. Okay, thank you very much.
Bismillah ar-Rahman ar-Rahim. Mr. Chairman, Co-Chairman, with your permission, what can be the cost of sacrificing pronator teres muscle? I am Professor Faisal Masood from Orthopedic Department, Unit 2, Mia Hospital, Lahore. And the study introduction is the fractures of radius and ulna are very common. They constitute about 8% of the major fractures, and in upper limb they are responsible for almost 40% of the injuries. And in adults, they have to be managed by open reduction and internal fixation with plate osteosynthesis. and the widely accepted approach for this fixation is Henry's approach. It is called the landmark approach for all these fractures of radius. So Henry approach is widely considered the workhorse for exploring the volar radius. So it has not been changed since its original description from 1945. The rationale of this study was in Henry's approach, pronator theory is invariably dissected or cut, or later on a modification by MacLean was introduced in 2015 in which it was partially sacrificed with Z-plasty and repaired. And this allows the pronator teres tendon to be repaired once the osteosynthesis was conducted. Preservation of pronator teres tendon has the theoretical advantages of preserving pronation strength as well as avoiding the unnecessary time while dissecting and repairing the muscle. Pronator teres has its peculiar features. It is a good landmark in the trauma situation where the tendons and muscles are swollen. It is the guideline and confirming the correct tissue plane, and generally the fracture of proximal 1/3 and middle 1/3 they lie under the insertion of pronator teres. Traditionally, pronator teres has to be sacrificed by taking a long periosteal sleeve that not only incorporate longer surgical time, but also you have to go for an attempted repair. So in future reconstruction, pronator teres is a very good landmark in radial nerve injuries, and hence dispensing or sparing this muscle and tendon is useful in future reconstructive surgeries if required. So the rationale was a plate can be slided under the muscles just by mobilizing it. So preservation of pronator teres tendon has the theoretical advantages of preserving the supination and pronation, which are the sister movements responsible for all our daily activities in on forearm usage. So the traditional pronator teres dividing approach, you have to sacrifice, it takes longer time, it requires a lot of dissection, and a futile attempted repair is incomplete or unsuccessful most of the cases. While in our approach, pronator teres sparing technique, you can slide the plate under the muscles, avoiding all such dissections and avoiding the reconstructive attempts. And there is nothing extra cost. So no repair or no reattachment is required. So you can see in this slide, on the top is the attempted repair, and in our pronator sparing, the muscles is left intact with its anatomical continuity. So we describe a pronator sparing approach, which is a little change of Henry's approach. Plate osteosynthesis was done by sliding the plate under the tendon, and it is a safe, simple, reproducible, practical, and has other theoretical advantages. So the objective was to assess the outcome of this approach. We had 43 patients which presented in the emergency of Mayo Hospital. They all were adults. From 2020 to 2022, the inclusion criteria, all the fractures of radial shaft involving the proximal and middle 1/3 from 18 to 60 years. Exclusion were the pathological fractures, tumors, and open fractures. And those fractures with skeletal dysplasias because they had a different bone pathology. We evaluated the union and function using Anderson et al. Criteria and function using the DASH score, in which we take into account the flexion and extension as well as supination and pronation of the forearm. We compared both. This is a prototype case in which the fracture of the middle 1/3 of the radius and a distal 1/3 of the ulna is there. The traditional pronator teres you can see in the picture, it is preserved with its belly, and the plate has been applied without disturbing the original anatomy. And you can see the continuity of the pronator teres is well preserved, no additional time required for taking a longer periosteal sleeve or attempted repair. So we had little male preponderance higher than the females because of the more outdoor activities, and road traffic accident was the cheerleader in most of the fractures. In pronator teres resection, the unsatisfactory rate was little higher as compared to pronator teres sparing approach. So results in group A, out of 26 patients, The 19 were male and 7 were female. In group, it was little higher in males as compared to female. Mean age group was as comparable to the international studies. Union was achieved in all cases without any complication, but the dash score was significantly different in the pronator sparing approach. So discussion is, we could find only one study. This is a pronator TD sparing volar approach for osteosynthesis in mid-shaft diaphyseal radius fracture. It was from McLean and it was published in 2015. This is the international evidence to document or to augment this approach. And so we could find only one study to support our idea. The conclusion was the Henry's approach is widely considered the workhorse for exposing the volar radius and has not really changed since its original description from 1945. And pronator TD sparing volar approach to the forearm addresses all the questions, avoids unnecessary dissection and gives good functional results. So it is does not potentially or theoretically causes weakness of the pronator teres, which is a very vital muscle in the forearm. So this is a better upper limb function compared to another group. Thank you very much. Any questions?
Thank you very much, sir. If you have some questions from the audience.
Thank you.
The next presentation is, thank you very much, sir. The next presentation is on identification of the literature gap about curriculum flaws, a proactive thoughts. May I request Professor Dr. Mohammed Sharif, the Chairman of and Professor of Head of Department of Pediatric Surgery, King Edward Medical University, Sir Professor Mohammed Sharif.
Bismillahirrahmanirrahim. Thank you, Chairman and Co-Chairman, for giving me opportunity. And this is actually not a study, it is just a, as the title shows, provocative thought about the curriculum flaws. Actually, when I was doing this CHEP course and then I did this certificate in medical editor publications course, and now as a MME scholar, so we're given some assignment that writes something about the curriculum flaws. So there are so many flaws and there are so many viable and non-viable factors which can actually cause the improvement and disimprovement of curriculum. Problem is people are thinking about these flaws and some advanced flaws, but my talk is about actually one basic flaws which I identified when I searched the literature in different search engines. So even people are talking about co-creation, that students should involve in the curriculum development and curriculum evaluation program and curriculum implementation program. But I think still we are now at the basic level. Even our students did not any awareness about the curriculum, what is curriculum. So I started one study on this performa cross-sectional, then still it is going on, and I found that more than 50% student of undergraduate and postgraduate did not have awareness about the curriculum, their own curriculum for which they are doing studies, undergraduate degree or postgraduate. So this is very important factors. So we are talking about the involvement of student, but still student even did not know about what is curriculum. And the other flaw which I am talking about, that there is no actually incentive for the curriculum developer. Professor Aslam Naqi is here, he is a well-known medical educationist. So if there is an incentive for the curriculum developer, evaluator and for the implementer, then I think our curriculum get improved more. So this talk is about identification of literature gap about curriculum flaws. So medical curriculum is an ever-changing landscape. and integrated curriculum depends mainly on student-centered learning and specialized teaching with well-trained faculty. So, new problems and flaws emerge as medical educators around the world try to improve it. So, we should always try to improve it and evaluate it. Even we are not actually, first it is developed, there is no change in the curriculum for many years. So, there is a need to change, and it is a continuous process to make changes in the curriculum for the improvement. And this, for improvement, we should check for the flaws, if any flaws, which can be corrected. So what I noticed that I cannot find any this research about this role of incentive for the curriculum development. So this was various engine which we searched, and there was no any reference about this. Even I cannot find every article about the awareness of curriculum among students, and also the second one about the role of incentive among the curriculum development. So if you see this SWOT analysis, one patient safety curriculum by WHO, and if we can see here, there is a strength, weakness, opportunities, and the threats. So this is termed SWOT analysis, SWOT. So if you see here the weakness, so if we put this flaws, their lack of incentive for the curriculum developer here, and if we put here that if we give incentive, then it can become the one of the strength of the curriculum. So this is my thought. Maybe later on, actually, further studies will be needed in the future about this important issue, whether it is important or not important. So my talk was about just a provocative thought. So we have seen some references and we have discussed in discussion, but there is a lack of incentive to the stakeholder results in a bad quality curriculum development. So we conclude from our literature review that further research is needed to study the lack of incentive for curriculum developers and lack of awareness among students about curriculum. This will help us to analyze these barriers in a more robust and effective manner so that effective solution can be proposed for the further improvement of curriculum. Thank you so much. Any question?
So I have any questions about the curriculum development or the gaps in the Please introduce yourself and then
Assalamualaikum. I am Juwaira Khalid from final year MBBS. And my question would be, what are some of the examples? What would be an incentive for teachers in the process of teaching? For instance, we students have this incentive of passing out from the university. So what could be an incentive for teachers?
Very good question.
Actually, we are talking about the incentive for curriculum developer. So developer include the teachers, faculty members, and also according to the new thought that this concept of co-creation, students should also be involved. So your question is about what is incentive for teacher that they can pass the student. This is your question. So passing student is a different criteria. Actually, the talk is about the incentive for curriculum development. But for passing student, it is not the incentive for teacher. Actually, if the incentive will be there for the teacher, not only for teacher, for all stakeholders, including the even IT peoples and like this, and this will be leading to improvement of curriculum, well-organized curriculum, and indirectly it will help the student for passing the exam. But as far as the passing is concerned, the one factor is if the student study the curriculum and they do their preparation according to curriculum, and from the first day they should be given orientation that this is your whole curriculum for the 5 years program, and you should do preparation according to this curriculum pathway, then it will help the student to pass early.
Thank you, sir. Right, the next presentation is to be given by Dr. Zubair Chima. He is from UK, he works in a department of urology, and he will be talking about changing the landscape of prostate cancer awareness and management in Pakistan. बातें तो कर सकते हैं, तालियां बजा सकते हैं 8 मिनट के बाद. Thank you. अब बातें करना शुरू कर दें.
All right, good afternoon, everybody. Thank you very much, panel of chair. I'm Dr. Zubair Chima, one of the consultant urologists. I do used to work in UK. I moved back here in Pakistan a couple of years ago. So that red spot in the map is the place where I got my urology training, and that building on the right is the Royal Derby Hospital, where I worked as a consultant urologist before moving back. I don't have any disclosures to make. So yeah, the title of the talk is about prostate cancer, how we can change the landscape of its awareness and management in Pakistan. So if we look at the title, the problem we are going to deal with, are going to address is prostate cancer. And whenever we are faced with a problem, the first thing we need to ascertain is to see how big is the problem, how we can identify what was the size of the problem is, and then we can address its solutions. So in terms of the prostate cancer, I think it's worth to have a look at the population cohort to see what kind of population cohort we are dealing with. If we look, this data is probably a few years back, but what it suggests that more than 50% of the population is male, and that's more than 110 million probably in Pakistan, and this is the target audience which at some stage of their life may develop prostate cancer. If we look another data, which is again pretty old, from 2010, the cohort of people who are between 50s to their 80s in terms of their age, so the right target group, which probably will be developing prostate cancer, that's again significant chunk of the population. So we have got a bigger population, we've got elderly people who are the target audience. In terms of the life expectancy, that's not much in this part of the world. The quoted figures are around mid-60s in male, much less than the Western world. So it's important to have that information in the background to address our problem. So other thing is to look at is, do we have any cancer registry to see how big the prevalence of the prostate cancer is in Pakistan, and then we devise the ways to tackle it. So unfortunately, we don't have a national registry as such. There are some hospital-based registries in Punjab, Karachi, and the Shaukat Khanum Hospital, which can give some idea about the size of the problem. So I worked in Shaukat Khanum Hospital for a couple of years when I moved back, and I looked at the data set of the patients who presented to them with the prostate cancer. Now bear in mind, this is only a small chunk of the people who present to the Shaukat Khanum Hospital, so it just gives you an idea, maybe a tip of the iceberg, but not the complete picture. But it's interesting to have a look into that to see what kind of clinical patients come to us. So we looked at the 1 year's worth of data between January 2020 to December 2020. A total number of 201 patients were enrolled in the hospital treatment for the prostate cancer. If you look at their age group, the majority of them were between 50s to mid-70s. That's what you usually expect. But again, nearly 11% between 45 to 55. So that's worrying. So quite a lot of young people presenting with prostate cancer. What kind of clinical symptoms they present with? Majority, as you would expect, will present with lower urinary tract symptoms, some with, at a late stage with the systemic features. That's too quick. All right, okay, so buttons all right, okay, that's fine. So if we look how those people were diagnosed, this is interesting. Around 50% had a TURP. So that's a surgical intervention for lower urinary tract symptoms. So interestingly, so these people ended up suffering with their lower urinary tract symptoms, and then had a surgical intervention to treat those symptoms and found to have a prostate cancer. So they were not screened to have that. and 5% had a metastatic deposit biopsy. So that's a big number. I'm trying to press it once only, so is there any other way we can do it? So PSA is a blood test usually done for the screening of the prostate cancer, and you can see around 43% of the patients did not have a pre-diagnosis PSA. That's again, from a urologist's perspective, is a worrying sign. If I ask you to click on that, will you move to the next slide? I'll just ask you next slide. That's okay. So we can do it from that end. Okay, so this is looking at the Gleason grade or the histological findings of the prostate cancer. If you look, the worrying sign here is the Gleason grade 9 and 10, which is by far the most aggressive prostate cancer, and you can see around 40% of the people present with that advanced Gleason score. Next slide, please. So in terms of the T stage, around 65% presenting with a locally advanced prostate cancer, which is T3 or T4. So if you talk about the truly localized prostate cancer, that's only 15% who will be candidate for a radical treatment presenting to us with the prostate cancer. So people presenting late at their stage. Next slide. Half of the people presenting with the bony mets, worrying sign. Next slide. Okay, so if we look at the localized disease pattern, so these are the patients who had a localized disease and probably will be candidate for the radical treatment in terms of the surgery or radiotherapy. You see a lot of patients who are only in their young age, 45 to 65, 7% of the patients, and presenting with aggressive disease. Next slide. So younger patient cohort, if you look at that, only patients who are in their 45 to 65 years old, 4 of them had a metastatic site biopsies. 44 patients had a surgical intervention and then found to have a prostate cancer. Around 1% had a locally advanced prostate cancer. So young patient, locally advanced disease, worrying sign. Next slide. So what facts do we retrieve from that data set? Patients are certainly presenting at a young age. They're presenting with the symptoms, and more aggressive disease on presentation, and metastatic disease is not that uncommon. Next slide. So again, coming back to the topic, how we can increase the awareness. Now we have concluded that it is a significant problem and presenting at a younger age with aggressive disease, how we can manage it and increase the awareness. Next slide. So in terms of the awareness, next, there are 2 parts, public awareness and the physician awareness. As far as the public awareness is concerned, next slide. Yeah, keep ticking. So the key things are the education of the public. So how we can increase the education. We need to educate the people that if they are getting those symptoms which can be prudent to prostate cancer, they need to report it early on. And I think it's important to have seminars. This is the age of social media. A lot of you are probably still looking at their mobiles. So all that information is very vital to get to the people. So use that media which is readily available to place that information to the people. Next slide. So physicians, so it's equally important that we also train our younger generation of physicians. Younger generation of the physicians, so that the accurate referrals can happen at the appropriate time. And it's not rather like reinventing the wheel, it's just sticking to the basic principles. So the patients who is coming with certain symptoms, more important to the prostate cancer, let's say low urinary tract symptoms, if they're not getting better, so treat them to the secondary care physician. So specialist education is very important. Next slide. Next slide. So in terms of the management, once we have talked about the awareness, next slide. So these are the key points. I'll be going through that. It's working. So improving diagnostics is very important. So prostate cancer diagnosis has changed in the last few years, and the role of the MRI scan and the prostate biopsies have really revolutionized the diagnosis. And it's very important to have the right skill set of the clinicians, which can be reproducible and standardized to diagnose the problem, and that's where the uroradiologists and pathologists are very important. Clinical pathways, it's very important to have clinical pathways for the primary care and the secondary care where the accurate referrals, when the red flags signs are there, i.e. any worrying alerts or increased PSA or family history, they can be referred accurately. So most important is the MDT. I think this concept is again not new, and quite a few centers in Pakistan are working with. And this is a set of professionals sitting together, like urologists, radiologists, pathologists, and oncologists, discussing all those high-risk cancers so that the right treatment can be offered to the patients and the learning opportunities can be achieved. Again, the point which I think Dr. Sadat referred to earlier about the centralization of the treatment. The prostate treatment, cancer treatment is a very specialized area in terms of both surgery and radiotherapy, especially surgery, if it's a radical surgery. It's very important to have a centralized centers where the same skills can be reproduced, good results can be achieved, and there are better training opportunities. About the time, we have a National Cancer Registry to record out that data set so that we can accurately target the problem. I think it needs a mutual effort, and institutes like this are very important, where people can get together, share their experience, and devise a pathway where eventually the patient benefit will happen. Thank you very much. I'm happy to take any questions.
So we have a question from Dr. Zubair Cheema. Thank you very much.
Thank you very much. Thank you.
So now we may request Dr. Nukbatullah Awan to talk about the comparison between the intralesional steroid injection
Bismillahirrahmanirrahim. जी सर, ये फोर्थ ईयर है। जी सर, थैंक यू सर। Bismillahirrahmanirrahim. Thank you sir for giving me this opportunity to present my today's talk at comparison between intralesional steroid injection versus autologous platelet-rich plasma therapy following surgical excision of oral keloid. So let us, next slide please, let us briefly go through what are keloids, and then I will present briefly my study. Keloids are basically benign growth of dense fibrous tissues arising from an abnormal healing response to a cutaneous injury extending beyond the original borders of the wound. Intralesional triamcinolone acetonide remained as first-line therapy, but this was associated with side effects and recurrence. Currently, surgical excision for oral keloids and small keloids and then post-operative steroid injection is being practiced as first-line therapy at many centers. Platelet-rich plasma is a good alternative. It is basically an autologous blood-derived product, and it has promising results in improving wound healing with lower keloid recurrence. So we conducted a study at ENT department, Mayo Hospital, Lahore, between January 2021 to October 2021. 84 patients with oral keloids were divided into two groups, Group A and Group B. Patients with oral keloids, only type 1 and type 2 were included in the study according to Chang-Park classification, and those patients without prior treatment, they were also included. Patients presenting with oral keloids type 3, type 4, type 5, patients with hypertrophic scars, and pregnant patients were excluded from our study. Group A patients received platelet-rich plasma after excision for 4 sessions, first on the day of surgery and rest 3 sessions 1 week apart. Group B patients received intralesional triamcinolone acetonide after excision in 4 sessions, similar to those which were PRP. So evaluation was done after 3 months by the patient and observer assessment scale. Of the 84 patients which were included in the study, all 84 patients were females with a mean age of 22.5 years. The mean scores for SAS scale for both groups are given in table below, and these scores show statistically significant improvement in all parameters of SAS scale for group A patients. So we concluded that PRP is superior in preventing recurrence of oral keloid after surgical excision. So these are the results of our study. You can see in group A, these all parameters such as pain, color of the scar, itching, stiffness, thickness, irregular margins of the scar, vascularity, pigmentation, relief to the patient, and pliability of the wound were statistically much better as compared to group B in those patients which received steroid injection. Thank you very much, sir.
Thank you very much. If you have a question, you can ask Professor Dubbad now. Thank you very much, sir. Please introduce yourself. Please introduce yourself before putting on the
Sir, thank you for the presentation. My name is Umar. I am from final year. My question is that why were all the patients included in the study female?
Due to our cultural and religious issues, ear piercing is the basic cause of oral keloid. So, as a Muslim, males avoid to get in routine ear piercing. That was the basic cause of development of oral keloid.
Thank you so much, sir.
Right, sir. Our next presentation, thank you very much, sir.
Thank you, sir.
Our next presentation is by Dr. Thank you very much. So our next presentation is by Dr. Azwa Janjua, and she is from Department of Pediatric Surgery, and she will be talking about the changing paradigm from open herniottomy to laparoscopic needle herniottomy in children. Dr. Azwa. So वादा यही है कि आप हर 8 मिनट के बाद तालियां ठीक तरह से बजाएं। So if there's a delay, तो हम पहले दूसरी presentation करें. Right.
Assalamu alaikum everyone. I'm Dr. Azra Zindwa, postgraduate resident from Department of Pediatric Surgery, Mayo Hospital, Lahore. Today I'll be presenting the changing paradigms from open herniatomy to single port laparoscopic assisted needle herniatomy in children. So as we all know that herniatomy is a major surgical condition in pediatric population, and it is more common in males as compared to females. And it is by routine method of its surgical proceeding is it is done by an open groin incision. Minimally invasive surgery is overtaking this conventional approach these days. The best method of repair for a herniatomy in patients in pediatric group is still debatable. Although the recent data shows that laparoscopic percutaneous extracorporeal closure is superior and safe, but no such data existed in our country. So my present study was carried out to compare the outcome of laparoscopic percutaneous extracorporeal closure in pediatric age group versus the open herniatomy in children. Okay, the study was a randomized controlled trial which was carried out in the Department of Pediatric Surgery, Mayo Hospital, Lahore from June 21 to December 21. The number of patients, there were 33 in each group, and they were divided in two groups. One group, Group A, was proceeded with laparoscopic percutaneous extracorporeal closure, while Group B was routine herniatomy. The patients were followed up after 1 week, 1 month, and 3 months. Okay, all patients from 6 months to 12 years of age were included in the study. Both unilateral and bilateral hernias were included. The criteria for diagnosis was history and clinical examination. No further investigations were included. All the recurrent hernias with any other association as undescending testes or hydrocele or sliding hernias were not a part of the study. And all the patients who could not tolerate a general anesthesia or had a contraindication for pneumoperitoneum were not included in the study. Okay. A total of 66 patients were analyzed, and all the data was collected through a pre-designed proforma. The results were analyzed by SPSS 26. Now this is a short video showing how we proceeded with the technique here in our department. Can you please play it? Video chala. So basically what we did that after creating pneumoperitoneum by a single supraumbilical port, a little stab incision were given at the point of deep ring which was localized. You can see that this is a needle piercing through the one side of the deep ring. We used a 16 gauge lumbar puncture needle with a double suture Prolene 2O incorporated inside. After introducing the needle, almost half of the ring was taken and the suture was introduced inside as in the form of a loop. After introducing sufficient length of the loop, another needle which would traverse through the other half of the ring were introduced through the loop. That was a single suture. Here. After introducing a sufficient length of this suture, the loop was tightened and the needle was retracted outside the abdominal cavity. So you can appreciate the ring is open here, wide open. And you can see that how it is being closed. The knots were tied extracorporeally. So this gives us this minimal stab incision is required for this technique other than the laparoscopic port. So the purpose of our study was to compare the operating time and complications rate in terms of recurrence in both the groups. So as per our study, the operating time was more or less similar in both the groups, but the recurrence rate rate was also same. In terms of post-operative hematoma, which was quite common, predominant in the patients with open hernioctomy technique, stitch abscess was also observed in a few patients with open technique, but none was observed in the laparoscopic approach. And the major thing was that this cosmetically the scar was much better in the patients operated through the laparoscopic approach. You can see here the little stab wounds, minimal scars in the patients with laparoscopic approach. This is a, should I wait? So you can see that as tissue manipulation is more in open technique, so you can see a bulge here in terms of hematoma, but no such thing is observed in patients with the minimal invasive technique. Here also, the chances for stitch sinus or abscess are much less as compared to the other group. So laparoscopic percutaneous extracorporeal closure in hernia patients was much better than open hernioctomy technique, both in terms of cosmesis and post-operative complications. So other than laparoscopic percutaneous extracorporeal closure, there are several other techniques which are being used worldwide as minimally invasive, and out of these, the Bernier technique is also being carried out here in our department. These are some other techniques which include extracorporeal riveting needle, hydrodissection lasso technique, and laparoscopic assisted simple suturing obliteration of the deep ring using epidural catheter. Thank you so much.
Thank you so much. Nice presentation. We have a question from Dr. Azra, so we have it now. Right, thank you so much. The next presentation is by Dr. Ahmed Humayun Sarfraz. He is Assistant Professor of Orthopedic Surgery, Unit 1 in King Edward Medical University, and he will be talking about the pattern of upper limb and lower limb amputations in emergency.
Assalamu alaikum. With the permission of the chairman, I am starting my presentations on the patterns of upper limb and lower limb presented to us in accident emergency. Amputation is basically a surgery to remove all or part of a limb from the extremity. Disarticulation is the removal of the limb through a joint. There are two types, mainly as closed and the open amputations. There are the different patterns and the level of amputations that a surgeon may utilize in order to achieve the best possible result. Factors influencing the decision are the host factors and the limb factors. Host factors are the concomitant injuries, pre or functional status, expectation. Limb factors, level of injury, type of injury, contaminating and infection, soft tissue coverage, and vascular supply. Purpose of amputation is to relieve the symptoms, improve the function of the life, and life-saving in certain conditions. There are different types of amputations in the upper limb: forequarter, shoulder disarticulation, short above elbow, long above elbow, elbow disarticulation, wrist disarticulation, and the transmetacarpals. In the lower limb, hemipelvectomy, hip disarticulation, above knee, below knee, Symes, Chopard, Lisfranc, transmetatarsal, and toe disarticulation. Objective of the amputation: to assess the pattern of the amputation in the upper limb and lower limb and report the level of amputation and the mechanism of injury. 100 patients were selected in the year. It was a 2-year study conducted in 2018 to 20. Inclusion criteria are the patients between 10 and 60 years of age, both genders, auto-amputated or amputation after the injury. Exclusion criteria: below 10 years and above 60 years of age, diabetic foot, and gangrene and tumors. It was basically a retrospective study. We collected data from the patients arriving in accident emergency department May Hospital, Lahore between 2018 and 20. We devise a Mengele extremity score. On this scoring system, we plan amputation. If it is above 7 and 7, we go for amputation. There are 4 parameters of this Mengele extremity: skeletal or soft tissue injury, in which low energy, medium energy, and high energy, very high energy. They are scored from 1 to 4. Shock group, normotensive, transient hypotensive, and prolonged hypotension from 0 to 2. Ischemic group and age group less than 30 years, 0, 30 to 50 years 1, and more than 50 years 2. This is the crushed limb presented to us in accident emergency with comminuted fractures. For Mengele score is 7, and we did below knee amputation. Out of 100 patients, there were 75 males and 25 females. There were 60 lower limb and 440 upper limb amputations. Out of the 60 patients of the lower limb, 35 has below knee, 25 has above knee, and 4 hip disarticulations. Out of 40 patients, 25 has below elbow, 13 has above elbow, and 2 shoulder disarticulations. Traumatic amputation was the most common cause, followed by the machine injury. Look at the table of the demographic details of the patients. 75 were males, 25 were the females. Road traffic accident is the most commonest cause, 78%. Machine injury accounts for 22%. Upper limb, 40% involvement. Lower limb is 60. Mean Mengele extremity score is 7.8 plus minus 0.7. On stratification of the data, in the upper limb, above elbow are the 13%, below elbow are 25, shoulder disarticulation 2, lower limb above knee 21, below knee 35, hip disarticulation are 4. Of the both genders, males are affected more because they are usually involved in the outdoor activities and industrial workers, and males in upper limb 28% involvement and lower limb 47. In females, upper limb 12% and lower limb is 13%. Amputation has a psychological impairment amongst the amputee and psychiatric disorders, which are fear, behavior changes, and job adaptation disorders. Post-traumatic stress disorders, anxiety and phantom limb vary between 32 and 84%. High number of amputations were reported in the emergency, with the trauma was the most common cause. Low limb amputations were higher in both genders. Most common cause of the limb amputations were the road traffic accidents. Thank you very much.
Thank you very much, sir. So if we have any questions from the President.
Dr. Ahmed, could you elaborate through this study what kind of road accident, which vehicle is more prevalent? Event of this, you can so that you can recommend what the road.
High speed traffic violation, high speed and motorcycle injuries, high speed motorcycle and trucks which is on the GT road. They are usually presented to us with apna mesh limb and mesh code 7 and crushed limb. They are the.
So on the basis of this study, it would have been very good if you could have recommended certain things that.
Certain precautions while moving on the road, improve
so that
the.
it could be in the interest of the public.
Maintain the traffic violation and have a speed and use traffic signals. Do not overrush speed while driving.
So I think you can further stratify the data and elaborate your future regarding what mode of trauma and what are its implications on the level of it. Thank you.
Thank you.
Excuse me, Dr.
You have another question.
One study was conducted in the emergency department regarding the data, which vehicle is involved more. So we concluded the Chingchi rickshaw was the one of the most common vehicle which was causing the trauma to the lower limb, especially the tibia fractures, and it was the crushed and mangled limbs. So we concluded that the Chingchi rickshaw should be monitored or some change should be in the structure of the vehicle. This was the one of the commonest cause of Chingchi rickshaw in the law.
I think one of the reasons is that they are ill-trained, they are not having that licensing process, and they have mass passengers with them. Generally, motorcycles they are associated with one passenger, but Chingchi usually carry their overburden and they are least balanced.
Least bothered about
least bothered and least trained. So they have a huge impact on the burden of emergency work.
Right, sir.
So in this study, was there any number of patients in which the revision was done after below knee amputation?
Because according to the contamination and the infection, patients were from the below knee to above knee. 13 patients. Yeah. 20%.
All these amputations were done in A&E.
In A&E and elective. In close, I have in the initial I have described the close and the open amputations. Closed amputations are usually done in the elective surgery. Open amputations are done in the emergency department where the crushed limb they presented to accident emergency and myodesis and myoplasty was done. And the contaminated wound they are further reassessed and then they are closed on the elective surgery.
So there were a certain number of patients who were given a chance and different departments were involved.
Very interesting study, but I think one of the important components which is missing in this part, probably you should have, or we should know at least how many upper limb injuries were machine related or RT, because in our experience, most of the upper limb amputations or injuries are
machine
injuries as compared to lower limb injuries. So you said that most of the injuries were
are due to road traffic accident, 78%.
60% were lower limb. So
and foot injuries.
That raised the percentage of road RTA. Otherwise, we would have stratified as per
stratification
lower limb mechanism. So probably in upper limb machine injuries.
Machine injuries is the highest. In lower limb road traffic accidents are the more.
So what we can suggest is that we can have a prospective study design in which we take the snapshots from all the other departments which are also involved with these injuries. This is only giving one side of the picture of the orthopedics and trauma. But the general surgery has lots of firearm injuries coming in, which may have delayed amputations, we have infections, we have diabetes, we have lots of vascular injuries, that we have patients with vascular problem, and maybe the 4th year class, and the fourth year class can contribute in that study. So we can take this snapshot, or go if we're interested हो तो they can meet us and then we can design something for you. Exactly. So that would give the true picture. Thank you very much.
Thank you, dear.
So now we have 4 interesting presentations. These are not from the faculty members. These are either from the house officers or the final year students of King Edward Medical University. Yes, you can clap. Right, the first presentation would be given by Dr. Aisha Batul. She is a house officer in Mayo Hospital now, and she'll be talking about a case report of acute disseminated encephalomyelitis as 8.5 syndrome with a unique presentation.
Yes. Thank you. Bismillahirrahmanirrahim. Assalamu alaikum everyone. This is Dr. Aisha Batul, and I'm here on the behalf of Department of Neurology, Mayo Hospital, Lahore, to present a very unique case report of Adam presenting as 8.5 syndrome with isolated 10th nerve palsy, a probable 18.5 syndrome. So, what is Adam? Adam is basically autoimmune monophasic demyelinating disease that predominantly affect the white matter of brain and spinal cord. It closely mimics the other demyelinating diseases from which it can be differentiated on the basis of neuroimaging. This disease has slight male predominance, and the mean age of presentation is 2 to 8 years. However, 20% cases present in second decade of life as in our case. So how do Adam presents? Adam basically has 2 phases of presentation. The initial phase has a prodrome-like picture that presents as fever, headache, vomiting, and certain signs of meningismus. And the second phase has neurological symptoms, and the neurological symptoms they follow the initial prodrome by the duration of 8 to 12 days. And it is characterized by the features of encephalopathy and the multiple neurological deficits that has wide spectrum of presentation, and they include cranial neuropathies, optic neuritis, transverse myelitis, and long tract pyramidal signs. Coming to our 8.5 syndrome, it is a very rare brainstem disorder that is characterized by the lesion of brainstem, and it affects the 3 major structures. The first one is abducens nerve nucleus that cause horizontal gaze palsy. The second one is medial longitudinal fasciculus that cause internuclear ophthalmoplegia, and the third one is the fascicular portion of 7th facial nerve that present as lower motor neuron type facial nerve palsy. So the 7th nerve and 1.5, it becomes 8.5 syndrome. So the rationale of my case report is to highlight the rare presentation of acute disseminated encephalomyelitis as 8.5 syndrome, because there is not a single case of Adam presenting as AHS has been reported. So this is the first case we are going to report. So briefly describing the case, we have patient 20-year male, unemployed, unmarried, right hand dominant, resident of district Vihari, presented to OPD of neurology department on 4th of October with presenting complaint of progressive loss of vision in left eye for 3 months and right-sided facial weakness with drooling of saliva and incomplete clear of right eye, and the progressive difficulty in walking for 1.5 months. So coming to our examination, the general physical examination was absolutely normal. Patient was hemodynamically stable, and he had average physique and build. According to neurological examination, his higher mental functions were intact, his speech was normal, and according to cranial nerve examination, I'm enlisting only the positive findings. His visual acuity was reduced in the left eye up to light perception, and fundoscopy showed pale optic disc bilaterally, and the left eye showed relative afferent pupillary defect. The other positive findings were there was horizontal right gaze palsy, and there was failure of adduction of right eye in the left lateral gaze, and there was nystagmus in the left eye in lateral gaze, and there was deviation of uvula to the left. Rest of cranial nerves were intact. According to motor system examination, the upper limbs were unremarkable, and according to lower limb examination, the bulk was comparable bilaterally. His tone was increased symmetrically in both limbs, and the power was 3/5, both proximally and distally. In the both limbs, his reflexes were exaggerated, and the plantars were upgoing. His sensory examination was unremarkable, and cerebellum was intact. So these are the picture of the patient. On the right side, it showed the failure of abduction of right eye in the lateral gaze, and the left picture showed the deviation of uvula. So in this picture, right-sided picture showed the impaired clear of right eye, that is basically a right-sided facial palsy, and the left-sided picture show deviation of angle of mouth. And this is the picture of fundoscopy that showed bilaterally pale optic disc. So based upon the clinical history and the examination, our differential diagnoses were multiple sclerosis, the second one was EDEM, and third one was neuromyelitis optica. So to confirm our diagnosis, workup was done. His baselines were absolutely normal. Lumbar puncture was done, and the CSF analysis showed increased protein and cell count that favors the demyelinating pattern of the disease. Our next step was CSF and serum analysis for oligoclonal bands that showed matching CSF and serum oligoclonal bands. His MRI brain with orbit and orbit with IB contrast was done that showed multiple areas of abnormal T2 flare signals in the right caudate nucleus, right midbrain, hemipons, medulla, and the lesions were also present in the bilateral temporal, parietal, and right occipital lobe. MRI dorsal spine showed patchy involvement from the level of T7 to L1. So here are the picture of MRI showing multiple lesions that also shows the involvement of deep matter and the gray matter. So based upon these investigations, our final diagnosis was EDEM. The patient was treated on the line of IV steroids, and that showed dramatic response, and no new neurological deficit was noted on his follow-up. So summarizing the case, what's unique about this case? As I have already mentioned, EDEM is an inflammatory disease that mostly presents as encephalopathy and multifocal neurological symptoms. But in this case, the typical presentation of EDEM was not observed. There was no history of any systemic illness preceding the neurological symptoms. Patient didn't have any typical features of encephalopathy, and a rare presentation of multiple cranial neuropathies were observed. So the purpose of this case report is that EDEM can present as an atypical presentation without features of encephalopathy. So whenever a patient with the features of 8.5 syndrome walks in your clinic, you should always keep the differential of EDEM in your mind so that the early vigorous treatment with steroids can be started to halt the further progression of disease, as we achieved in this case. Thank you.
Thank you very much. And the next case report is very interesting. It says it's on nanotechnology in medical diagnosis using quantum dots for detecting reactive oxygen species or ROS in states of chronic oxidative damage to cells. May I request Dr. Osama Khalid to present this case report.
Assalamu alaikum everyone. Today I'm here to provide you guys a glimpse of the things we can see and the things we are unaware of. Well, nanotechnology sounds cool, as well as quantum physics. But I will present to you how we can use this quantum physics in medical diagnosis that can help us. But before diving too much deeper in the complexities of quantum physics and how I will be using that, let's set the foreground for you guys so that we all can be on the same page. Sometimes there are problems that we can see, but at times there are deep-rooted manifestations we cannot. Take, for example, diabetes mellitus and the complications with it, carcinoma and the metastasis that occurs, and the process of early aging. Patients come to us and we see the problem that is there, but at times we are unable to see the underlying manifestations. With every problem, there is a starting point, the point we cannot quantify. In diabetic microvascular damage to cells, whether there is a DNA damage and uncontrolled cell division or early aging. Have you ever wondered what was happening to the cells when it first started to malfunction? What was the first step that led to the process of inflammation? And the answer is the imbalance of the very molecule of our existence, and that is oxygen, and the fight between its radicals, the superoxides and the peroxides. So I've devised an idea, a theoretical idea, to sense oxygen radicals that could tell us the degree of oxidative damage in cells. So let's solve the problem now. We have identified that if reactive oxygen species are there, causing the problem at the first place, so why not track the progress of these reactive oxygen species? If mitochondria is there, using this ATP to produce this oxygen species, so let's build up a sensor that could sense superoxides, hydrogen peroxides in the mitochondria and in the cells, and that could help us to identify problems that would otherwise develop after 10 years. Now, the sensor would send us a signal that would tell us the amount of superoxides and the peroxide production over time. But before that, we have to know how to build a sensor in the first place. That sensor should be able to sense a bioreceptor, and in this case, there is a superoxide radicals. Now, the sensor should be able to react to the reactive oxygen species, should be biocompatible, and be small enough to detect the signal. And the signal should be qualitative and quantitative at the first place. And here we are, the quantum dot, the really cool thing that is the future of medicine, I would say. What are quantum dots actually? So these are artificial cluster of semiconductor atoms. Now this image is very colorful as well as the quantum dots, because as semiconductors, they have a conduction and valence band. I know this sounds really complex, but the simple part is when they are excited or in a reaction, they would produce different wavelengths of light. And these wavelengths of light are a signal with the reaction. So my theoretical investigation highlights that by building cadmium, selenium, zinc sulfide quantum dots with this structure, of course, and by encapsulating it with a coating of a hydrophilic lipid. And the purpose of encapsulating it with a hydrophilic polythiol is that so it can dissolve in the human body, so in order to help us in this sensing process. So at the end, the quantum dot that can function in living cells. Now the wavelength of this quantum dot that I've shared with you, the cadmium selenium one, has a wavelength of light that can emit from 7 to around 2 nanometers. And all of the colors that you're seeing here are the wavelengths that would be emitted. And it would produce really a good signal of the intensities of oxidative damage that can be there over time. This is the creative representation of what a quantum dot looks like. As you can see, the protective shell, it has the quantum shell. Now, the slide is a bit misplaced, but the idea here is to use these quantum dots to in a redox reaction with superoxide radicals. And they would emit variable wavelengths of light. And this would represent us with the amount of oxidative damage that is there over time, whether the damage is there because of the DNA damage there, cancer cells are there, or it's because of the diabetes. But you might all be wondering why I'm discussing a bit of physics and a bit of relation. Why all this? Because the current measurements and the sensing techniques today that are available to us are limited to the level of a micron meter. Now, to set things in perspectives, the average size of a mitochondria is around 200 to 500 nanometers. The size of a DNA is 2.5 nanometers. But have you guys ever wondered what is the size of a human hair? 80,000 nanometers. So it makes sense that if a mitochondria is around 500 nanometers, these superoxide radicals that it would be producing are far much smaller. So the final perspective for you guys to tell about nanotechnology is that it has applications in nanobiosensing. Quantum dots can be used in targeted chemotherapy. Now for quantum dots, Using these in the human body can yield promising data regarding the oxidative damage that can occur in cells. And at the end of the day, we can prevent far complex diseases to develop in a 5-year gap, in a 10-year gap, and that would be the best thing we can achieve. Well, if I would one day develop a quantum dot, it would be some wearable device that would be able to detect some fluorescent signal that is because from the oxidative damage and help you guys keep an updated with the oxidative stress in your body, like the smartphones or the smart devices we have today. And that is to the presentation that or the idea that I wanted to present to you guys. Thank you.
Thank you so much. So now we have two very nice presentations. First, to be given by a very brilliant students of final year. पहले नाम तो बता दूँ. So probably these are both of them. One is probably the Messi and the other would be the Ronaldo of the future. Very brilliant students indeed. I've seen them work hard. May I request Mr. Qasim Mahmood first? And he would be speaking about the attitude of medical students of Pakistan towards e-health education program in improving their physical well-being and assessment of their level of physical activity across sectional study.
Thank you, sir. Bismillahirrahmanirrahim. My name is Qasim Mahmood and I am from final year MBBS, and the topic of my research is attitude of medical students of Pakistan towards e-health educational programs in improving their physical well-being and assessment of their level of physical activity, and it was a cross-sectional study. So what is e-health? E-health is the use of electronic devices and software programs for the transfer of healthcare resources. It includes e-apps, health apps, e-websites and things like that. As you all know, this is an age of drastic technological advancement, and reliance on technology has recently been increased. This has led to unhealthy attitude among young people, especially medical students, leading to prevalence of different chronic diseases among them. And we cannot deny the role of electronic media in the provision of healthcare resources. But despite recent advances in the healthcare provision around the globe, there is still a need of a proper e-health educational program aiming to promote the physical well-being and good dietary habits among young people like medical students. So we did this study to evaluate the attitude of medical students of Pakistan towards e-health educational activities, and we tried to assess their level of physical activity. So these were the same objectives of our study. We tried to evaluate the attitude of medical students towards e-health educational programs, and to assess their level of physical activity, and to study the relationship between their level of physical activity and obesity among them. So it was a cross-sectional study. Sampling was done by non-probability purposive sampling. Duration of study was 3 months. Sample size was 466 medical students. Study participants were medical students from first to final year MBBS, studying in different public and private sector medical institutes of Punjab, and the ethical approval was taken from IRB committee of KEMU. So we designed a questionnaire based on IPAC. IPAC is International Physical Activity Questionnaire. It assesses the level of physical activity for the past 7 days, and we circulated that questionnaire among the medical students using WhatsApp, Facebook, etc. And the data was analyzed and processed using SPSS version 23. So these are the results of my study. The table number 1 shows the basic characteristics of the participants. Around 55% of them were male, and around 45% of them were female, with a male to female ratio of 1.23. Most of them were in the age range of 20 to 22 years, and most of them were from the public sector medical institutes, and most of them from urban setting. This is the main part of my study. This part of our result section was based on IPAC. We used a short version of IPAC. IPAC is International Physical Activity Questionnaire, which categorizes the level of physical activity into vigorous, moderate, and low level physical activity. So out of our participants, 37.8% of them were engaged in vigorous level physical activity, and most of them were males. and around 45% of them were engaged in moderate level physical activity, and almost all of them were engaged in low level physical activity. So we also calculated BMI of the participants using height in meters and weight in kilograms, and most of the participants were having normal BMI. Around 13% of them were having less than normal BMI, and around 27% of them were having more than normal BMI. And the mean BMI of the participants were 22.7 with a standard deviation of plus minus 4.34. And out of the participants having more than normal BMI, around 67.2% were engaged in any vigorous level physical activity. So this was the part of our study telling us about the attitude of our participants towards e-health. We asked different questions like whether they know about the term e-health, whether they have used any e-health educational program to improve their physical well-being, and whether they agree on the notion that e-health educational activities can improve their physical activity. So 56% of the participants responded that they know about the term e-health, and around 80% of them agreed on the notion that e-health educational activities can improve their physical fitness, but only 34.5% of them were engaged in using them practically. So these are the key findings of my study. Mean BMI was 22.7 with a standard deviation of plus minus 4.43, and around 27% of them were having normal BMI. Most of the participants agreed on the notion that e-health educational activities can be helpful in improving their physical and mental fitness, but only 34.5% of them were practically engaged in using them. A small percentage of our study population were doing vigorous and moderate level physical activity, and there were more males engaged in more vigorous level physical activity, and we also noted a significant correlation between the level of physical activity and the BMI of the participants. So the study was limited as the sample size was small, only medical students were included, and as the survey was online, medical students having internet access were included. To conclude, I'll say in today's world, the reliance on technology has increased. While it is causing unhealthy attitude among the young people, it can also be used to develop e-health educational programs when the load of disease is sky high. So we did this study to assess the level of physical activity among medical students and their attitude towards e-health. And most of the participants were of the notion that e-health educational activities can improve their physical fitness, but only a few of them were engaged in doing so. So awareness would be raised among them to spend more activities on productive activities, and that can improve their physical as well as mental well-being. I'll conclude by saying eat right, move more, so that you can breathe easily. Thank you so much.
Right, ये please ना attendance वाला अभी रोक दीजिएगा. Last presentation है सुन लीजिएगा फिर उसके बाद बोलिए, right? सारी disturbance होगी attendance की वजह से proxies लगी. Right, may I request now Dr. Sorry, not Dr. at the moment. Final year students, Mr. Muhammad Umar Muhtar, the final year students, and he will be talking about lesson learned from 5 patients of persistent Mullerian duct syndrome, a rare case series. Dr.
Hello everybody. Assalamu alaikum. My name is Umar. I'm from final year. I'm very excited to be here and to share with you my case series regarding persistent Mullerian duct syndrome. अच्छा, प्रेजेंटेशन स्टार्ट करने से पहले ना मैं एक छोटी सी बात करना चाहता हूँ. काइंडली आप सुनेंगे? अच्छा, कल से ये सिम्पोजियम हो रहा है, राइट? वी हैव कम येस्टरडे एज वेल. बहुत अच्छी प्रेजेंटेशन हुई हैं. वी हैव हैड अ लॉट ऑफ डिस्टिंग्विश्ड स्पीकर्स, वी हैव हैड अ गुड साइंटिफिक डायलॉग. पर उसमें ना एक बात रह गई है. 4th ईयर का आना, एक दिन में सेंड अप है और फिर भी वो सिम्पोजियम लेने आए हैं. कैन वी हैव अ राउंड ऑफ अप्लॉज फॉर 4th ईयर? All right, now that we have broken the ice, I'd like to talk to you about the objectives of my study. So the first objective is to bring recognition to the rare condition of persistent Mullerian duct syndrome, and the second is to share with you some lessons regarding persistent Mullerian duct syndrome that were learned during the management of these cases. So let's start. Persistent Mullerian duct syndrome is a rare genetic condition it is characterized by the presence of female internal genitalia in a normal male. Basically, we have a healthy male patient and he has a uterus, fallopian tubes and vagina inside his body and he does not know about it. This condition is associated with the rare condition known as transverse testicular ectopia. This is a rare entity and less than 300 cases have ever been seen in the world. So we had 5 patients and they presented with inguinal hernia. Obviously they presented with inguinal swelling, examination was done and it confirmed the diagnosis of an inguinal hernia. Ultrasound was done to confirm the diagnosis. On ultrasonography, we saw a hernial sac that had a loop of intestine, but we also saw that the hernial sac also had a testis in it as well. And this same testis was absent in the contralateral side of the scrotum. An initial diagnosis of inguinal hernia with transverse testicular ectopia was made and surgery was planned. Alright. So the surgeon did the surgery and this was what we found. So on the slide you can see that the structure that is being labeled has an uncanny resemblance to the diagrams of the female genital tract that we see in our textbooks, right? So the star denotes the cervix, the arrows demark the fallopian tubes, and the arrowheads on the right side of the picture indicate the testes. So basically we operated upon a male patient and we found out that he had female internal genitalia that were fully functional inside his body. These specimens were sent for histopathology and the histopathology showed this. So basically on the right side the arrowhead indicates a seminiferous tubule. This is a specimen of the testes, and on the left side the structure that has a thick muscular wall and a lot of branchings into the lumen, it's the histopathology of the fallopian tubes. So a definitive diagnosis of persistent Maillard duct syndrome with transverse testicular ectopia was made. So how did we manage the patients? Obviously patients को hernia था, हमने hernia को treat किया. Secondly, the patient had abnormal female structures inside the abdomen. We took all those out. And lastly, all these 5 patients had one ectopic testis, right? So in adults, if the testes are ectopic, they have undergone dysplasia and are at the risk of development of cancer, right? So in the adult patients, we took out the ectopic testes, whereas in the infants, we had 2 infant patients. We took the testes and we fixed them into the scrotum to preserve fertility. So basically, what happens in this condition? In normal development, there is an undifferentiated gonad and there is the Wolffian duct and the Müllerian duct, right? So in the male, due to a substance called the Müllerian inhibiting substance, the Müllerian duct involutes. But what happens in this condition is there is failure of Müllerian inhibiting substance. The testes don't produce this in the male, and this results in the persistence of the female tract in the male. So I'll just discuss the most significant thing about this condition that I have highlighted in red. Basically, आप खुद बताएं, are the female internal organs supposed to be in the male body? Are they? No or yes? All right. So if a male has female internal organs in the body, what could possibly go wrong, right? So the main complication is malignancy. The abnormal structures face an unfavorable environment in the abdomen and they can develop cancer in them. Secondly, if the testes are ectopic, they will also develop cancer in them. And it is fit to note that the cancers that arise in the Müllerian structures are very deadly. And as far as the discussion of this case is concerned, there was an old school of thought regarding the treatment and a new school of thought. And the new school of thought recognizes the fact that the female genital organs might develop malignancy, and so they recommend the resection of those abnormal structures. So in the end, I would just like to conclude my presentation with some take-home messages. First of all, literature में हमने पढ़ा है कि 300 से कम cases इस condition के देखेंगे, right? So me and the team of surgeons that I worked with on this paper, we encountered 5 cases of this rare disease in just the course of 2 years. So it is quite a frequent encounter with this condition, and it didn't exactly happen by chance. We believe that this condition is underdiagnosed due to the lack of familiarity of the surgeon with this condition. Secondly, the take-home message is that if ever a patient is diagnosed, then the structures must be removed so that cancer can be prevented. Thank you so much for your patience.
Thank you very much. Take us to the conclusion of this session. तो प्रोफेसर सायरा यहाँ पे आई है कि मैंने इसका पूछा बच्चों से कहने पर इनकी बात सेटअप है और इनकी बड़ी सी ख्वाहिश है इनका सेटअप आगे करते हैं।
Dr. Aisha Batul, she's around. Dr. Aisha Batul, Dr. Osama Khalid, Dr. Qasim.
Pathology department for the postponement of your stand-up